I would request everyone to get seated here, please. It's about 2:30. We are going to start our workshop now, right on time. We also have an online telecast of this going on, so we have to be very much on time. A very good afternoon to respected seniors and my dear colleagues. On behalf of NANDED Orthopaedic Society, I, Dr. Ashish, your friend and colleague, Dr. Purushottam Pawar, with great pleasure would like to welcome you all to this trauma update and life surgery workshop organized by NANDED Orthopaedic Society in association with Maharashtra Orthopaedic Association.
Your overall guideline, it will be around for 2 days workshop, out of which on 14, that is today, we are going to have a case presentation and discussion over it. On 15, we are going to show 5 live surgeries which will be broadcasted live on Shield app. So in case if anyone has registered, he can look through it and get his CME point as well from that. I'm sure we all will have here a lot of academic feast for these 2 days and getting a chance to hear the most estimated faculties of our faculty of orthopedic department. Having said that, it takes me a great pride estimated faculties for the workshop. I would like to welcome Dr. who is an eminent faculty in our field of orthopedics. He is currently president of Maharashtra Orthopaedic Association. He has also been a speaker in many national conferences for over the last 3 decades. We are highly privileged to have him as a faculty and request Dr. Vijay Chichani sir to come on dais and welcome him. One small note, I also remember him for his very nice lecture, Abain Mujemar. I think he will definitely guide us over that. Yes, we will. We are eagerly waiting for it, sir.
Our second guest today is Dr. B. Shivshankar sir. A warm welcome to Dr. Vasudev Ladekone sir. Sir, please have your seat on the dais. Our second guest for today's workshop is Dr. B. Shivshankar sir. He doesn't need any introduction to our people of NANDED. He has already taken part in many CMEs in NANDED. He has been a past president of Maharashtra Orthopaedic Association as well as Indian Orthopaedic Society. May I request Dr. Prakash Bhandari sir to come on stage and welcome him. Welcome sir, welcome Shivshankar sir to NANDED.
Now I will call Dr. Gawai sir. He is consultant orthopedic surgeon at Saifi Hospital, Jaslok Hospital and Bhatia Hospital, Mumbai. Sir is also honorable professor in Grand Medical College and JJ Group of Hospitals. He is specially interested in complex trauma and joint. He has presented around 164 scientific papers in different state as well as national conferences. He has conducted and taken a part of 145 workshops in various parts of India. May I request Dr. Kailash Patni sir to welcome on stage on behalf of NANDED Orthopaedics. Please. Welcome, Gawai sir.
Our next guest of honor is Dr. Shivkumar Santapalli sir. He is a very well-known name in almost all parts of Maharashtra. He has been serving the people of Aurangabad for decades. He has performed maybe over more than 10,000 major orthopedic surgeries, which includes 3,000 joint replacement and deformity correction surgeries. He has also presented and published many research papers in regional, national and international conferences and journals. May I request Shrikant Davekar sir to come on stage and please welcome Dr. Shivkumar Santapalli sir.
नहीं एक दो बार बदला कि इसमें क्या वहां से वो नहीं निकल के ऊपर
Please, Rahul, give it a warm welcome to Dr. Shikshma Sandipure sir. Please clap everyone.
Next, I would like to call Dr. Girish Motwani sir from Nagpur. Sir is university gold medalist and pioneer in ankle and foot orthopedic surgeries. He is director of foot and ankle orthopedic care in Dhantondi as well as Suyog Hospital, Nagpur. He represents the center India's first exclusive foot and ankle orthopedic, and he has extensive experiences in surgical management for the lower limb. He's been invited for more than 35 national and state conferences. May I call Dr. Dabale sir to welcome him on stage. Dabale sir, please welcome Dr. Motwani sir on behalf of NANDED Orthopedic Society.
So please have this. Next, I would like to welcome Dr. Ashok Godke sir. He is currently working as associate professor at NANDED Medical College, Kamote, Navi Mumbai. Working in hand unit in the department, the secretary of Navi Mumbai Orthopaedic Association. I have been very fortunate to have been working as a postgraduate student under him. I was very fortunate for that. He has a special interest in orthoplastic procedures. May I request Dr. Prakash Chavan sir to please come on stage and welcome him. Welcome, Dr. Ashok Godke sir. Please have your seat on stage. We are also fortunate to have Dr. Rajesh Ambulekar sir, the head of the Department of Orthopedics of NANDED Medical College. We would like to call him on stage and please sir, please come sir. May I ask Dr. Bandewar sir to come on stage and welcome him please. After this warm welcome of our esteemed guest, I would also like to invite President of NANDED Orthopaedic Society, Dr. Mahesh Guptiar sir, and Secretary of NANDED Orthopaedic Society, Dr. Govind Shinde, so that they can take part along with our esteemed guest in the inauguration and lamp lighting ceremony. Please come on stage. Take it.
बोला समझ में आ रहा है, चल रहा है, बेस्ट चल रहा है। हाँ, मैं देख रहा हूँ।
After the lamp lighting ceremony,
देखने गए क्या?
now,
नहीं, यहाँ पर देख रहा हूँ।
now I would request Dr. Gadegone sir to please share some.
Good afternoon to everybody. On behalf of Maharashtra Orthopaedic Association, I welcome you all for this very prestigious CME, and this is a very prestigious Maharashtra Orthopaedic Association activity, continued educational program. I thank the organizing team of NANDED Orthopaedic Society, and they have arranged so nice day this CME. I congratulate them all. Dr. Prakash, Dr. Sinde, Dr. Naidu, and there are senior members like Chachani sir and my friend, classmate Prakash Bhandari are here. I am very glad. And the past president of Indian Orthopaedic Association, Dr. Shivshankar, Dr. Godke, Dr. Motwani, Dr. Gawale sir and Dr. Santapure, my executive member, they are here to deliver their knowledge, and it will be an interactive session for near about 1.5 days. And I assure you, after going from this, you will be the most happy person that you have gained something from this year. So I welcome you all, and I request the organizer to start the proceeding. Thank you very much.
Further, I will request our president of NANDED Orthopaedic Society, Dr. Mahesh Guptiwar sir, to say a few words about the journey of NANDED Orthopaedic Society. Please, sir. Guptiwar sir.
Thank you, Gadegone sir. Good afternoon all. I am Dr. Mahesh Guptiwar, President of NANDED Orthopaedic Society, along with our Secretary Dr. Govind Shinde. Welcome you all in the city of NANDED. I especially thank all delegates for this CME and also our faculty for this CME and live workshop. It is a proud moment for me standing as a NOS representative in front of you all. I will take this opportunity to unfold our NOS journey in brief. About 34 years back, the plant of NOS was planted by our founder members, Dr. Kursale sir, Dr. Patni sir, Chichani sir, Bhandari sir, and Lavekar sir, and thereby creating a platform for upcoming orthopedic surgeons. They started our clinical meeting on the first Wednesday of every month. That meeting is a great feast for neurons and taste bud too. In the meeting, there is a clinical discussion of the academic discussion of clinical cases. There is an exchange of thoughts between seniors and juniors. The views of the seniors are respected, at the same time junior views are accepted. Thus created a healthy and family-like atmosphere in our society. I am glad to tell you that till date we follow the same schedule of our clinical meeting on the first Wednesday of every month with the same enthusiasm. To keep ourselves updated and work at par, NOS conducted many CMEs, live workshops, symposium, and conferences with the help of eminent faculties from state level and national levels. We conducted 2 mega events of MOM1 in 1998 and 2013, and we are the first to conduct the Mohapan in Marathwada. Thus, we represented us at state level. Over the year, we nourished our NOS with the help of love, dedication, determination. With never say die attitude of our society, our beloved NOS member Dr. Paliwal sir elected as a MO executive member this year. NANDED developing fast, and we are here providing all kind of orthopedic cares in the form of spine surgery, arthroplasty, arthroscopy, pelvioacetabular surgery, and complex trauma here. NOS has always believed in betterment. Even the era of COVID, we conducted live CMEs and live workshops, where the NOS members were the delegate as well as faculty. It was just like a home function. Now, with the end of the COVID era, we are again ready with our motto, that is the theme of this year: sharpen the surgical rationale and improve the patient outcome. Today's conference is a part of that. Hope you all will enjoy the today's academic feast. With this, I conclude my words and take your leave. Thank you.
Thank you, sir. I think without pausing further in any delay, we will start our proceeding of the day. The motto and the criteria will be: each presenter will be given 10 minutes. He has to finish his presentation, and we have to be time bound because we are being online recorded. So, without further delay, I will call Dr. Mrityunjay Sharma, who is a resident and exam student from our government medical college, to present his case on fracture distal and radius. Mrityunjay Sharma. I would like to all our facilities to moderate this presentation.
Very good afternoon to all the SSLs, esteemed faculties who are present here. I am very thankful to you all for giving me this opportunity to speak a few words on this dice. Myself, Dr. Mrityunjay Sharma, and I'll be discussing the topic of discussion is middle third clavicle shaft fracture, which is being managed by intramedullary nail. So, as you all know, the most common mode of injury for the clavicle shaft fracture is fall on outside hand or a direct hit to the clavicle shaft, and the most common part being the middle third clavicle. As per the elbow classification, group 1 belongs to the middle third, group 2 belongs to the lateral third, and group 3 belongs to the middle third of the clavicle shaft fracture. Now, the clinical presentation with which the patient presents to our OPD or casualty is pain, swelling, tenderness, confusion with the affected lip held on the opposite limb, and the patient head tilted towards the opposite side. So the most common mode of treatment for the middle third clavicle shaft fracture, which we commonly do in OPD or in casualty, is conservative. But pre-fracture cannot be managed conservatively. The non-operative management comprises of clavicular bracing, figure of 8 bandage for 6 weeks with sling. The main motive is to immobilize the fracture fragment so that it promotes the fracture healing. This is the picture of clavicular bracing, which is preferred most commonly in the OPD. And along with now, the important thing which you consider is that when we should operate, like in which indications in which the patient should be given operative procedure. This includes those fractures which are more than 2 cm displaced, which are more than 2 cm shortened, and there is associated neurovascular injury or there is compound fracture which is associated with it. So this is the X-ray of intramedullary nailing, which is one of the modality of treatment. plating, and in case of compound fracture, we do external fixator. So what we did in our institute is intramedullary nailing with tens nailing with a small incision taken over the fracture segment. That is minimal incision, 2 to 3 centimeter, not a big incision. So here you can see the pictorial diagram of what we did with our patients. That is clavicular nailing by retrograde approach. First we did what the 2 to 3 centimeter small incision is taken over the fracture site, and by carefully dissection the fracture fragment is opened. Then by using 2.7 mm drill bit, the medial canal of the clavicle is rimmed, and using the same drill bit we rimmed the lateral part of the clavicle, and that lateral part of the clavicle is pierced, and a stab incision, as you can see here, the stab incision is taken to bring the rimmer out of the posterior aspect of shoulder. These are the clinical pictograph on which we took a small incision. Then rimming of the canal is done. Then a tense nail is passed from the medial in the retrograde fashion. And after giving a thorough wash under fluoroscope, all this procedure was done under fluoroscopic guidance. And after thorough wash, and after the confirmation that the nail is within the canal, the closure was done in layers. In post-operative duration, the patient was given appropriate antibiotic duration with passive physiotherapy started on the post of day 2, and patient was discharged with advice of not to do vigorous activity with overhead abduction for the next 6 weeks with continued passive physiotherapy. Here we did this procedure in at least 15 to 20 patients, 15 to 20 patients to see the output of what we are getting in that patient with regular follow-up, and what we received in the and what we got. Here you can see a patient came with a good range of motion with minimal scar, that is 2 to 3 centimeter, which is much more preferable. And another benefit of preferring clavicle nailing is we preferred unilateral deep cervical block with intracranial block over general anesthesia, because of which post-op comorbidity was very less. And we did this, we preferred this anesthesia in all our cases. In majority of the cases, what we observed is there was a good range of motion. There was a minimal complication. The only complication which we faced was due to the backout of the migration of the neck, which is the known complication, but it was very less. That is in 1 to 2 cases only, which we managed by the implant removal. Now, why to prefer intramedullary nailing over other procedure is that the incision size is very small, so the scar is very less. There is no subcutaneous palpable implant, which can create trouble for some patients, and moreover, it gives a good cosmetic result. There is a good cosmetic with good range of motion. So that's why we would recommend that intramedullary clavicle nailing should be preferred with mini incision over the fracture site. Thank you very much. The case is open for a discussion. Thank you much for your kind attention. Thank you very much.
PPT कट जाएगा लोग.
That was a good presentation, Dr. Mrityunjay. May I call upon Dr. Pratik Kulkarni, who will be presenting on lower and radial fracture.
पिक्चर में आपका PPT कट जाएगा.
Good afternoon, everyone. Myself, Dr. Pratik Kulkarni. I am junior resident at SCGMC NANDED. Today, I will be discussing a case about lower and radius fracture minus adherence. So, lower and radius fracture is one of the most common fracture encountered in orthopedic OPD. It makes about 8 to 15% of all injuries, all adult injuries of orthopedic injury, and the incidence is bimodal. And younger age group, the incidence is high due to the road traffic accidents and high velocity trauma, and in old age group due to osteoporosis, the incidence increases again.
Lower end of radius is high, if not managed properly, has a high function impairment and complication. So there are various modalities of treatment available now. Just a short slide about the normal measurements of the lower end radius. The radial inclination normal is about 22 degrees, and the volar height is 11 degrees, and the radial height normal is 11 to 12 mm. So the 141-year-old male right-handed dominant patient had suffered histoporotrophic accident, high energy trauma, during which he suffered injury to his right wrist. And the patient was having pain, swelling, and inability to move the wrist. So the patient was brought to the casualty. So upon quick general examination and the focal local examination, patient was found to have swelling tenderness crepitus and restricted motion at his wrist. So the patient, after stabilizing the patient and reassuring, patient was sent to X-ray, and this was the X-ray of the patient. Here we can see the fracture of his right lower end radius with intraarticular extension, and there we can also see the loss of radial height. So according to the AO classification, this comes under 2R3C1, Frickman type 3 and Fernandez type 3 classification. So there was no any associated neurovascular injury or DURJ distal radial nerve joint involvement was seen. So as the patient was young and he was a laborer by profession, so it's a high demanding job, and patient was having intraarticular fracture. So the treatment plan was decided with open reduction lateral fixation with plates and screws, for which modified Henry's approach, volar approach, was decided to be used. The patient was operated after anesthesia fitness under brachial plexus block with side support with CR intensifier. So modified Henry's approach used the interval between the radial artery and the FCR tendon. So the incision was extended. Upon deep dissection, the bailey of abductor pollicis longus was dissected with finger dissection, and pronator quadratus bailey was cut in L fashion from the radial side, and the fracture site was visualized. The fracture, the patient was having coronal split of the volar fragment. So the traction manipulation was done and reduction was achieved, which was held with K wire and which was confirmed under CM as the reduction was acceptable. The final fixation with plate and screw was done. So this is the post-op X-ray of the patient. Post-op period, post-op period patient was given limb elevation and antibiotics for 3 days. Passive physiotherapy starting from day 1. And on 2-month follow-up, patient was having good range of motion with terminal dorsiflexion, pain on terminal dorsiflexion. So that as per the treatment plan of the lower end radius fracture depends upon the need of the patient, the age of the patient, the bone quality of, and associated injuries like compound fracture. So in this particular patient, we decided to go for plating as the we wanted anatomical intra-articular reduction as the patient was high demanding. And so for extra-articular fractures, K-wire or cast can be chosen for the treatment, but for the high demanding patients, for good intra-articular reduction, the plating is preferred. Open reduction plating is preferred. Thank you.
Thank you, Dr. Pratik, for the presentation. I now welcome Dr. Atmaram Gargil, who will be presenting a case on stress fracture of proximal tibia.
Very good afternoon. I'm presenting the case of a 54-year-old female. She is having pain over the right leg for last 1 month after some pilgrimage, and she was treated somewhere else with the cast for 3 months. But she didn't turn up for the treatment, and after 3 months, she is unable to walk. This is the present X-ray. Now, patient underwent a treatment for the stress fracture somewhere else. I would like to take the opinion from the audience for this fixation. This is a pre-op X-ray.
May I request the faculty, please? Present the case. Can you show the pre-op X-ray, please? This was the pre-op X-ray of a 54-year-old female. Please brief about the case one more time.
54-year-old female, she is having gradual onset insidious pain over the right leg for last 1 month. She is having the pain aggravated only on weight bearing. There is no pain at the wrist 3 months back. And when she came after 3 months, she is unable to walk and the pain is aggravated.
Wait. May I request the faculty, if anybody wants to comment something on this X-ray?
Yes, sir. 3 months plaster.
Hello, have you given plaster?
Advice for the plaster, but she didn't take the plaster.
The plaster is not applied.
Not applied, sir.
So, what did you do next?
She underwent treatment somewhere else for this fixation. And after 1 year, she turned back to me with this X-ray. Now she is unable to walk for last 5 months. And this is a present X-ray with broken plate.
Atmanam, can you please go to the back slide, please? Yeah. Is this fixation justified? The osteotomy that was done?
Probably someone has done medial opening wedge osteotomy and maybe one more plate on the medial side and a bone grafting. The osteotomy could have prevented this complication. Bone grafting and medial plate.
Excuse me, 1 minute.
Yes.
My opinion is that along with that, that it is so corrective osteotomy should be accompanied with a fibular osteotomy. It's my only fibula is that.
Yeah, people are osteotomy is done.
So basically, the house means to say that there was inadequate fixation here. Inadequate fixation and bone graft is missing here.
So if you want to use the only one plate, the plate should be longer and the screw density should be the more distal, and yet the screw should be applied alternatively.
So Atmanam, this is the present X-ray now.
And this is the present X-ray.
Again, it is open for the house. How do we proceed?
No, before that, anybody does the opening event on the medial side with the plate on the lateral side. I think there is some problem with the understanding itself. We open it from the medial side must be cut.
Right.
With the plate.
Right.
Putting a lateral plate and expecting the width collapse is totally wrong.
So it's a clear message here that whenever we are going in for the osteotomy, the side from which we are doing an osteotomy, we have to plate that side first. And if you do a bicondylar plating, it will all well and good. And associated with that, if you put a bone graft, it is further beneficial for the patient. 1 minute.
X-ray is traumatic fracture or what? Is there a history of trauma?
Yeah, there is no history of trauma, sir, but there is a fracture and visible in the lateral view, sir.
So what do you think? It is a deficiency fracture or a stress fracture?
It is a insufficient fracture, sir.
Insufficiency fracture.
Okay, next.
So she presented at this stage, and so I want to find out what is the cause of her non-union as well as the stress fracture. So we did some battery of blood investigations. There is no any signs of infection was there. Although there is CRP is raised, her vitamin D3 was near about 20 international unit. She is HBCG reactive. So under universal aseptic precautions, we did a fixation of the fracture as well as the osteotomy of the fibula and the bone graft as well as the medial plate is added. Any comments on this fixation?
Go ahead, please.
The anterior contained by the lateral.
Yes, sir.
Basically, side.
is the anterior plate.
Yes. So there is a defect on anterior side, sir. When I open it, there is a defect is on their anterior side. Yes, sir. No, sir. So if you see the preoperative X-ray carefully, there is a defect is on the medial side. So this is the non-event case, sir. So in whatever the possible, you have to give the only
This
case.
is the iatrogenic arm. Not biological.
Okay.
This is the bracket. Connect to bracket.
Okay. So fracture ends were exposed and debrided. The fracture fixed the dual plating and bone grafting as well as the fibular osteotomy was done. The fracture is united well at the end of 1 year. These are the clinical images at the 1 year. Now there is some review of literatures on the high risk space fractures. There are various classifications are there. So we'll not go into detail of that. Thank you. Thank you very much.
Okay, thank you, Arpana. Thank you so much. Dr. Prahlad sir wants to.
Is there any role of teriparatide in this case?
Sir, teriparatide is not given, sir. Only vitamin D supplementation is given to patient.
So, sir wants to ask, does teriparatide help in faster fracture healing?
Yeah, sir, it may definitely help in the fracture healing, sir.
Okay, thank you, Arpana. May I request Dr. Swapnil Chakravarti to come up on stage, please? He is going to present the case on proximal humerus fracture.
First of all, I will like to welcome all faculty members and delegates from NANDED Orthopaedic Society. Myself, Dr. Swapnil Chakravarti, present case on proximal humeral fracture. In OPD, we get a lot of cases of proximal humeral fracture. Many times we are in dilemma, what treatment you should advise, with type of fixation, what is the approach. So I deliberately kept cases mainly on 4-part and fracture proximal humerus and fracture dislocation humerus. Proximal humerus fracture. This is the main classification. I don't want to go in detail, focusing on top on 3-part and 4-part fractures. Case 1, knee 2-part fracture. 27-year-old male patient with a history of trauma. On examination, there was swelling, RM not possible, no neurovascular deficit. This was anteroposterior X-ray showing 2-part proximal humerus fracture. This was post-op X-ray. Sorry, it was not immediate post-op. I got follow-up X-ray. This was the fixation. Now, case 2, knees 4-part fracture. 77-year male patient with a history of trauma, fall with an outstretched right hand. There was no comorbidity. Local examination, swelling present, range of motion not possible and painful. No neurovascular deficit. This was the AT and lateral X-ray showing a fracture dislocation of humerus with 4-part fracture. This was a CT showing anterior dislocation of humeral head with comminuted fracture tuberosities, both lesser tuberosities and greater tuberosities. Now the approach. I think case is open for the discussion. I want a discussion from this point.
Go into the X-ray and CT scan.
Basically, on the approach, which approach should be preferred, and lateral or deltopectoral?
What is the house preferred for this fracture? Deltopectoral or the deltopectoral approach?
Okay.
Okay, the house prefers the deltopectoral approach.
Now we have taken a deltopectoral approach. Titanium locking Philos plate was used. all the tuberosities were got tight hold with ethibond, and the sutures were tied over the phyllos plate. This was the intro picture with tuberosity well in place and fixation. This was the image post-op X-ray. Everything was going all right till this point. Patient was well at home. At the 4 month, my fellow seniors got a call that patient was having severe pain and not able to move his upper limb. Sir advised an X-ray, and we got this thing. Now, this was a problem we faced. What to be done? And what was the reason for this? Because
I want to go to that point first. That what might be the reason?
the reason, yeah, I want discussion on that point because technically we had done everything with the book style. Tuberosity is well tight. Proper phyllos plate was used. Sequence of the screws was followed on AO principles. No varus collapse. Nothing was there, but tuberosity was reabsorbed. What might gone wrong in this case? Any faculty member, if possible, or any delegates? Yes, sir, but seeing on the 4th month, there was no, there's grossly osteolysis of tuberosity as compared to humeral head.
Hello. Pointer. So can you explain what is wrong? Why he has pain at 4 months?
I think because of the screw poking inside and the tuberosity absorbed.
Now, if you see the X-ray, the head has migrated in relation to the glenoid.
Yes, sir.
The X-ray on the left side. If you can take the cursor there, cursor. Normally. Hello. So, in relation, this is the inferior border of the glenoid. Cursor is seen. Now, if you see the inferior border of the glenoid and the head here, it has migrated up. When does this migrate? When there is a rotator cuff insufficiency. So basically, and what you see here is a greater tuberosity which is resolved. So if you go back, probably why it has resolved, the fixation is poor and not adequate here. That may be one of the reasons. I don't say it has been prepared badly, but this is the foremost reason at 4 months. Avascular necrosis in the proximal humerus takes about 8 to 9 months to develop. It doesn't develop in 4 months. So this is not that. And the good part is the head, the anatomical head, it has united here, right? And the screw to begin with was loose. It is now, if you see here, there also, you can see that same screw which is going, it is already not locking. Probably it has been locked. So there is some collapse of the head. That is why the head has migrated. The screw has migrated, which is a normal sequence. The other good part is the otherwise the normal tendency in the proximal humerus is the head tilts in varus. It has not happened here. So this is pure rotator cuff insufficiency.
Sir, what might be the cause that even we had tied with ethibond, rotator cuff was not properly healed? What might be the cause in this case? Yes.
or usually what happens is part of the tuberosity to take in the boy, some is left behind, which may be the reason. Second is fragmentation, and third is your bite has to be from the muscular tendinous junction, from the tendon, not from the bone. So if you take it from the bone and you make multiple holes, you get a picture where the tuberosity resolves.
Thank you, sir.
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 Another
Okay, next case.
Another possibility, I think, of infection, deep infection.
Might be one of the possibilities.
So, okay. What you did
We
for
are
this?
not evaluated for that. The
Okay.
patient did not come back because of some reason. He was operated somewhere else later on because he was in Bangalore. He went away with just a removal of the one screw. He is okay and happy with the water functions he is having. So we left over like that only.
Okay.
Okay, now I'm going to my second case. Old fracture dislocation of the shoulder. 44-year male patient with a secondary history of trauma secondary to epilepsy, two episodes of epilepsy in 40 days. He was consulted one of the orthopedician. He got reduction done, but even after that, he get a second dislocation. Now, on local examinations, swelling present, rotation restricted, range of motion painful. This was his X-ray. This was this MRI scan picture. There's a defect on anterior part of the humeral head. Tuberosity fracture was there, so it was getting repeated dislocations. Now we had planned a modified Macklin procedure. In this, we transfer the tuberosity with the defect in the head, so that it will not re-dislocate, and patient will be having a good function and prevention of the dislocation. With that, this was his post-op X-ray. Thank you, sir. Thank you. Any comments for the last case? Because of time, I just rush in fast. Any comment from the house?
What you have, reverse Wilson's lesion.
Yes, sir.
In the humeral head.
Yes, sir.
Now, if you have transferred the lesser tuberosity on this lesion, it is still a deficient. The area covered by the lesser tuberosity to fill up the reverse Wilson's lesion is too small. We additionally required an allograft to fill the defect. So, modified magnetic alone will not help in this patient to get a good humeral coverage. It required additional therapy.
It should be supported with the allograft or extra bone graft. But I don't have his range and follow X-rays. Sorry for that, but he is very happy. I feel.
Achilles has done a very good job. The patient has not come up with the symptoms again. So I think he's doing fine as of now.
Thank you, sir. Thank you for the patient hearing. Thank you very much, sir.
May I call upon Dr. Prakash sir to present this case?
Good afternoon, friends. This is a recent case that I come across and I did it. A 52-year male operated case of fracture shaft tumor 13 years back, 3 times. First surgery, iron nailing was done, went in non-union. Then second surgery done, interlocking nailing with bone graft, again went in non-union. Then third surgery, nail removal followed by BCP and bone grafting was done. Ultimately, fracture united and patient was walking well, walking with a knee. Now this time, patient failed while walking, followed by pain, swelling, deformity, left high and knee. Patient is known case of diabetes mellitus under treatment, and patient is very irregular in follow up and doesn't follow instructions. On examination, there is an old heel scar, lateral aspect of the whole thigh, swelling, deformity, high and knee, tenderness, crepitus, abnormal mobility, suprapatellar area of femur, no distal neurovascular deficit. This is the X-ray. What should be done? This case is open for discussion.
Hello. We should rule out infection. Is it diabetic?
There is no infection. Patient was walking, he was normal. He failed and this is the fracture. What is to be done now?
This plate, we can try to remove this plate, and retrograde nail can be used considering the quality of bone, metaphyseal location of the fracture. Though removing this plate, this old plate looks to be very difficult, but if you could successfully remove this plate, then I would prefer to pass a long retrograde nail all the way up to his basement of hand. Distal few screws can be removed and a shorter nail can be used, sir, another option. Distal 3 screws can be removed and then we can accommodate a nail in that. Or the last option is a plate or plate. You can put one more plate on that. Yeah, that is also possible. The distal nail or a distal plate. Plate or plate. Yeah.
Anything else? Why, sir?
There are multiple options which can be done here, but seeing the combination, the nature of the fracture, any single implant is not adequate. There are so many permutations, whether you are able to remove some screws, whether you are able to remove the plate. If you are able to remove complete plate, probably the topmost screw is a stress riser there above the lesser trochanter, both these screws. We may get a IT fracture if you put a shorter implant. So apart from what has been discussed, even an antegrade nail with a plate is an additional combination which you can get, which you can do if provided you are able to remove the complete implant. Okay. Shivsankar sir, please comment.
I know the case anyway, but I agree with what Sangeet said. But even I earlier also commented, it's a double implant which is more important. Nail with a plate augmentation after removing, and if you are unable to remove them, put an anterior plate and a smaller lateral plate. So that is another option.
Okay. Thank you. Then what are the options? As we have discussed, these are the standard options just now. In older days, we were putting this patient on skeletal traction followed by hinge knee brace or external fixation and hinge knee brace. This is what I did. Remove of the screws with the 3 small incisions. Not remove the plate. Close retrograde suprapatellar nail and lock in dynamic mode. Why I have not removed the plate? Because cortex underneath plate was very thin. 80% plate was covered with a strong new bone. Screw holes which were not fixed with the screws were fully filled with a strong bone. In view of all this, to avoid pathological fracture, I have not removed the plate. And this is the final picture.
So this is how many days post-op now?
5 days.
5 days.
A little bit, but his opposite limb is also in valgus.
Hello. Hello.
This was done closely. Fracture site was not open. There is no lettering, sir. No, it was done closely. You don't have stock for at iliac crest for bone graft. Already both iliac crests were used in previous surgeries.
Prakash, a nicely done surgery. Still, the prognosis is guarded in this case. It is because if you see on the medial side, and our knee is only locking on the lateral to medial side, it is uniplanar.
Yes.
Already osteoporotic bone.
Yes.
It is in the white canal.
Yes.
Translational, rotational activity are going to happen at the fracture site because of the obliquity.
Yes.
Rotational malalignment. And it is not a valgus, it is a rotational malalignment of the distal fragment. I think this will not work. You need to have a bone grafting with additional small medial. Thank you, sir.
Thank you very much, sir. See, in 2009, I presented 40 cases of suprapatellar fracture femur, and I managed in this, all cases were managed by closed methods. So every case was united, but because the case was done in closed manner. Here also, I hope it will unite. But if it not unites, then I have given the option to the patient. Already prognosis was explained because this was a difficult case. So everything was explained. His general condition and other things were not permitting for additional procedure. So this is the final picture just now. I post further pictures when patient presents to me. Thank you very much.
Thank you very much, Johan, sir. I welcome Dr. Vijay Kamble sir to present his case.
Good afternoon. I'm presenting two calcaneal fracture cases. Especially Bhutani sir, you have to see the cases so that you will know where I am, how much you have to teach me in 1.5 days. This is case number 1, 45-year male, fall from height, having injury to left foot. This is pre-op X-ray. He was operated with old fracture, middle malleolus. This is very CT film. We did audit to sinus tarsa approach. This is a post-op X-ray. What we did it. So this is case number 1. Now going to the case number 2. So seeing this case, you have to teach us how to plan radiology, how to classify the fracture, because many of the time we are not able to classify as per the Sanders classification. We are not able to classify properly. How to plan surgery, how to plan approach, what is the implant choice there should be, and post-op protocol. Case number 2. This is case number 2. 50-year-old male patient, fall from height again. This is the pre-op X-ray, widely communicated fracture calcaneum. This is CT film. We tried for the open reduction and fixation, but it was severely communicated. So I had to decide we cannot reduce it properly. So I have gone for the subtalar orthodesis primary. This is post-op. Now next slide. So your expert opinion, how to proceed in such cases. Please guide us in 1.5 days so that we will improve.
Sir, can you put on the previous X-ray, please?
Previous
X-ray, the pre-op X-ray.
So, sir, for planning the calcaneal fracture, I think the two X-rays which is more important are the lateral view and the axial. Without these two X-rays, planning is not possible. So we need an axial view number 1. Even on the lateral view, it looks like a single. This is case number 1. First case 2. This is case 2. Okay. So. So if I just see the first lateral X-ray of this patient, it looks like it's an older X-ray. It's an older fracture. Is it true? It was a fresh fracture. So you said that it is non-reconstructible, intraoperatively decided.
The posterior facet was very severely communicated intraoperatively. I cannot reconstruct properly. Why
So
I decided to go on.
Yeah. So sir, in CT scan, in the preoperative CT scan, we need to look for 2-3 things. First, how do we decide that it is a reconstructible or non-reconstructible? Because accordingly, you have to counsel the patient. So the size of the sustentaculum is very important. If it is very, very small, sustentaculum, the medial fragment, which is a stable fragment, constant fragment. If it is very small, most of the patients they come in the non-reconstructible. You have to counsel the patient. Only one thing: size of the sustentacular piece on the axial cut. Sorry, on the coronal cut. Here we don't have a coronal CT. Any other CT? Any other? Any other? Yeah. So if you see on the second last row, it looks like a big sustentacular piece. So if you look at just below the talus, the part of the calcaneum, which is a sustentacular. So yeah. So this is a fragment which decides is it a reconstructible or non-reconstructible? Because it's the lateral part of the calcaneum which is always broken, which is always depressed, and you need to reconstruct this part to this part, the stable fragment. So it's a reconstructible if it is not older and if it is not very bad. It may be the non-reconstructible posterior fragment. But as far as the evidence and the literature say, it's a reconstructible fracture if we are opening it. Anyhow, if we are planning to fuse it, the fusion should not be in the direct this position. Because anyway, if you are planning the fusion, this is a joint depression type. So if you see the polar angle, it is almost a negative polar angle. So whole of the talus is depressed down. The talus usually remains in the 10 degrees. Talus usually remain in the 10-degree dorsiflexion, but because of the calcaneal depression, it becomes horizontal. And most of, if you fuse the talus with the calcaneum in this horizontal position without elevating this area, that leads to the anterior ankle pain because of the anterior tibiotallar impingement. So if anyhow it is not reconstructible, we need to put a graft on the posterior part of the talus and the calcaneum so that the talus get fused in this position to avoid the anterior tibiotallar impingement. This is called distraction block subtalar fusion. So you need to take a graft from the iliac crest, big graft, put it on the posterior part only, because if you put on the whole part, it remains in the same position, horizontal. Just on the posterior part, and then you put a screw, similarly what you have did. This gives an ideal long-term ankle-free, pain-free ankle. These are the few things we need to understand if we are, even if we are planning for the future. It should not be the main.
Thank you, Dr. Patni.
hello.
यहाँ का यहाँ मत हो, वो कोने तक जाके बात करो तो फिर आते सब बात करने आते हैं.
Begin the next session. Now we are going to call Dr. Sangeet Gawale sir to enlighten us about the column concept and importance of CT scan complex upper tibia fractures. For that, I would like to call moderator as Dr. Chichani sir, Dr. Gadewar sir, and Dr. Viras Musure sir.
Hello. 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 Hello.
Hello. Hello.
Hello. Hello. Hello.
Hello. Hello.
So my talk is on
8 minutes for presentation and 2 minutes for discussion.
principle of plate fixation in intra-articular distal tibial fracture is my presentation. My mistake it has
वरून या तुम्ही तिथे एक माणूस पाठवा ना कधी इथून बसून नाही जमत त्यांचा आवाज आम्हाला क्लिअर पाहिजे त्या आवाज कसा क्लिअर आहे त्यांना लेवल करून द्या त्यांच्या हिशोबाने
So that is a talk, principle of plate fixation of complex upper tibial fractures. What would be the outcome in such intra-articular fractures? He is an 18-year-old boy, sustained this type of fracture, and somebody else did just 2 lag screws without identifying the fracture, without doing a CT scan, and you can see here the fracture has gone in varus. There is a step on the medial side. So it was a medial condylar fracture which was unreduced and fixed with this 2 lag screws. And if you see the CT, which was done at about 6.5 months, you can see the step, and this is not reconstructable now. And probably the 18-year-old boy will have to live with a malunion where the cartilage is already damaged. So improper management would lead to pain, deformity, limited range of motion, and eventually osteoarthritis. So importance of CT scan was the idea of giving a message in this. So the fracture configuration, if you trace it, it was like this, and it required a posterior plate fixing the fracture perpendicular with the help of lag screw and buttressing that fragment. Instead of that, it was fixed in this way where the fracture subsequently got displaced. So analyzing the CT scan and then appropriately using the implant which will buttress or fix the fragment is the key when you are treating such difficult fractures. And for that, we must know what is a 3-column classification, which is based on CT scan, wherein complex bicondylar fracture patterns with posteromedial or posterolateral components help in planning the approach. So this classification takes into account 3 reference points. One is the tibial tuberosity, second is the anterior edge of the fibular head, and the third is a posteromedial ridge. And if you subtract or draw a line between the two, the posterolateral ridge, the posteromedial ridge, and the anterior head of fibular, anterior part of the fibular head, so you are left with the posterior column, which actually involves the posteromedial and posterolateral. So posterior sulcus of the tibia divides this into 2, and the anterior one is where from the anterior of the fibular head to the tibial tuberosity is your lateral column, anterolateral column, and on the medial side similarly is the medial column. So that is the importance and significance of this CT scan. But how does it help us? So when you evaluate and correlate the CT scan with the help of X-ray, 48% classification of the fracture have changed. So your planning, your decision, which was based on the X-ray, and the one which is done after seeing the CT scan, it changed in almost half the cases. Second, your operative plan also changes if you analyze the CT scan. So these posteromedial, posterolateral, anteromedial, anterolateral condyles, these are usually not identifiable clearly on the X-rays, even if you take oblique X-rays. So a CT scan will help you in planning, because the most important is you have to buttress, you should know where is the apex of these four fragments, and you have to buttress them so that you get a proper fixation, and your surgical approaches are based for these four fragments or these four type of fractures accordingly to where is the apex of the individual fragment. So if you have a posteromedial apex, you should have a posteromedial approach, and your plate should be posteromedially. Similarly, it is for the other parts. So analyze the fracture three-dimensionally will improve your surgical approach and fixation methods. So aim of surgical fixation is achieving an anatomical reduction of the joint surface, restoring the mechanical alignment of the lower limb, and then you can see how beautifully that heals in expected time. In a simple knee injury, here you see this as a normal X-ray, but when you do a CT scan, this is a 2D CT, which gives you a lot of information of how much is the defect, how much is the depression. And when you actually see, you can see the X-ray will not be visible if you switch on the light. So the articular depression, which is seen in this 3D CT, needs a surgical intervention. You have to elevate that depressed lateral column. So the two sides, the lateral side and the medial side of the tibia, the articular surface has a different configuration. The lateral side is convex. So when there is a depression, it shatters. There is multiple fragments. The depression is in multiple fragments. It splits into multiple fragments. There is a widening of the condyle. Can you switch off the light? And the same is not seen on the medial side. So here you have a depression. The convex surface goes down. And when there is an axial load transmission, there is a multi-fragment depression of the lateral side. So this requires a maneuver to elevate these depressed fragments. Once the appropriate involved articular fragment as a stable unit like this, and then restore the articular surface of the lateral, and then fix it with a raft plate or a buttress plate, which will maintain the reduction. When you go to the medial side, usually the medial condylar fracture is seen in type 4, 5, and 6 Schwarzschild. You must rule out neurovascular injury, which is very commonly associated with the medial condylar fractures. CT scan for assessment of the degree of combination, impaction, orientation, size, and location of the fragment is very important. And as we have seen on the lateral side, where you see multiple fragments, here since the tibial articular surface is concave shaped, so when there is an axial load transmission, so actually it splits into only two fragments. These are the anteromedial and the posterolateral. There is not much combination of the articular surface. So this leads to either the fragment going in anterior direction or posterior direction. Most often, the posteromedial fragment is seen in almost 60%. And if this is missed or if this is not addressed, it will usually it takes the femoral condyle along with it. That means with the posteromedial, there is always a dislocation of the knee. So reducing that anatomically will reduce the subluxation indirectly. So here you can see what has been done. Only a lateral plate. So the posteromedial fragment, which should have been addressed by a posteromedial plate, has been unattended, and as a result you can see there is an anteroposterior widening of the tibia, and the femur has followed that fragment and it is subluxated as compared to the proximal tibia. Medial condyle usually have a combination of three main injuries. The posteromedial main condylar fragment, which is like this. It never involves the entire condyle. It is not split into a medial or a lateral condyle. The fracture line usually runs from anteromedial to posterolateral like this. So actually it consists of 70 to 80% of the medial condyle. The main fracture plane starts anteromedially, passes through the center of the tibial head, involves the tibial eminence and ends posterolaterally. So it is that configuration. So posterocentrolateral plateau depression usually is in the weight bearing zone of the lateral plateau. So here is the extent of the medial condylar fracture, and the depression is usually seen here, not on the medial condyle of a medial condylar fracture. So proximal displaced osseous avulsion of ACL are more common in medial condylar fracture. So surgical approaches are based according to where is your fragment. So for the medial side, you have anteromedial, medial and the posteromedial approach. For the lateral side, you have anterolateral, posterolateral, frosh or a transtibular approach. And for the posterior condyle, you can approach directly by a direct posterior approach. Lobenhofer approach or the posteromedial approach of the for posterior condyle. In prone position, you take a dorsal incision lateral to the medial head of gastro muscle, partially proximally detach the soleus used to reduce and fix the main posteromedial fragment. And after a vision, fix the plate over the apex. Don't fix it elsewhere because it will not buttress. So visualize the medial, and whenever you are taking, so that was the Lobenhofer approach. When you take a dead medial approach, visualize the medial ligamentous structures, expose the pes anserinus and the medial collateral ligament and protect them. Don't put your plate over these two structures, over the pes and over the superficial medial collateral ligament. So superficial medial ligament is attached to the medial corner or the medial border of the tibia. So whenever you are fixing a plate, you should skid it underneath the superficial ligament. Medial approach and reduction, short anteromedial submeniscal orthotomy helps to expose the articular cartilage. It's crucial reference point to assess the anatomic reduction. So like this, you have to elevate the meniscus to see the articular surface, and after exposing the distal end of the medial fracture fragments and the posteromedial tibial crest, which is a second reference point, detach the underlying medial collateral ligament, which allows preparation for the posteromedial plate, and then reattach that ligament. So the reduction is performed like this. Posterocentral depressed plateau fracture is then elevated, reduced to the main fracture cap. So this is how you elevate the extent of the depression, which is seen in the lateral condyle when you have a medial condylar fracture temporarily fixed with K-wires. Here, whenever you are fixing, you have to visualize two reference points. One is on the articular side and other is the apex. So without identifying these 2 points, you will never get a proper reduction. So here, for identifying this reference point, you need a good exposure, and on the articular side, either a good Siam view or you should do a meniscus elevation through the center part of meniscus and give a valgus. So you can actually see the other reference point, which is intra-articular, and you fix it like this. So the buttress plate is going, when you put the screw here at the apex, which should be about 3 to 5 millimeters below the apex, when you try to fix this cortical screw, this fragment, the posterior fragment, will automatically go up. So for the medial side, you have to extend and externally rotate the knee, and then tighten the screw. It will buttress automatically. You don't have to do anything. See for the two reference point, one this and second, put the plate and the apex of the deformity. The cortical screw has to be 3 to 5 millimeter below the apex. Extend and externally rotate the knee and tighten the cortical screw. You will get anatomical reduction most of the time, and then pass the remaining screw like that. Manual hyperextension and valgusization will also help, wherein the apex bone-to-bone reduction and buttress or anti-glide plate can be used in that fashion like this. Bicondylar fractures usually are difficult. The medial side fixation has to be done. The reason is usually we don't see comminution on the medial side. The comminution is always of the metaphysis is always on the lateral side. You'll get, when you follow these rules, you'll get a result like this. When you have a comminution on the medial side, then the rule is little different. Again, you can use a bridging plate where you maintain the length of the medial condyle like this, and then restore the articular surface and then fix the lateral side, and you'll get good reduction and healing like this. So here, when you have a bicondylar, other most important thing is maintain, restore the length and maintain the axis of long axis of the lower limb. Whereas in any standard is not acceptable. Here you can see what has been done. This is not addressed, and as a result it failed. A casual application of the second plate without apex consideration result in an axial displacement and a varus collapse. So that has to be rectified by adding proper plate following what we have discussed. Posterolateral fragment, uncommon, cannot be fixed with a lateral plate. Fibula comes in the way. A fibular osteotomy can be done, and you have to protect the common peroneal nerve, or you can take a direct Frosch approach wherein you can go behind the fibula or anterior to the fibula because your nerve is dissected out of the approach. So second important thing is you have to address the soft tissues. Whenever you have a impending plebs where the soft tissues are not good, where there is lot of edema, sooner it is better to wait in those situations. Either you can use a temporary fixator or just keep them in slab, because when you see the ecchymosis, friction abrasion, sooner plebs are going to erupt, and if you operate in such situation, you will not be able to get a closure, and your complication rate are almost 50%. So what do? You wait till these blisters become dry. You see a wrinkle sign that takes about 2 to 3 weeks. So don't hurry up. Wait for that to resolve, and then once you do the surgery, you will get a result. Timing of the surgery: when there is a soft, pliable skin, wrinkle-free, consider the surgery. The incidence of compartment syndrome is about 18%. Higher rate of complication and poor functional outcome. Infection rate, if fasciotomy wounds are closed before, is about 11 to around 12%. If you are doing the fixation along with compartment syndrome, your infection rate is almost 50%. I'll just skip this. Yeah, and just concluding. Three or four slides. Bicondylar versus monocondylar fracture. Surgically treated monocondylar fractures have significantly better functional outcome compared to bicondylar fractures. Schatzger type 4 fracture has the poorest outcome out of all. Malalignment after fracture fixation greatly increases the risk of disease progression to knee osteoarthritis. Varus and valgus knee post-operatively with varus knee have a poor functional outcome. Valgus, the symptoms appear late, that is why you can pull on. Widening of more than 5 mm is suggested to have poor functional outcome. There are other non-osseous injuries which we usually neglect. These are the meniscal and ligamentous tear, cartilaginous damage. Meniscal tear are associated with about 40 to 90%. And in knee dislocation, 50% of the cases, knee is in a true dislocation at the lateral part here. You can see that 50% showed more or less reduced, and 96% of these, they have also associated ACL and MCL injuries. And in this complex fracture, only 60% of the patients, they return to the normal activity. Rest, they have a poor outcome. I'm talking of Schatzger type 5 and 6. So understanding the fracture, doing a CT scan, planning the surgical approach, and your fixation of the implant will change the results, which are poorer otherwise in these difficult fractures. Thank you very much.
Thank you, Sandeep. Sir, hello, sir. Will it advisable for each and every proximal tibia fracture to do a CT scan?
Yes, 100%.
Is there any need to bone graft each and every patient after elevation?
Unless there is a metaphyseal combination or the depression is quite significant. Otherwise, the wrap screw with the newer plate can address most of the issues. You don't have to graft those smaller defects. You can use an artificial bone if you are not sure. But the newer plates where you have wrap screw going subchondrally, they are enough to take care of that defect.
Last question. When there is a gap of bone space, there is too much comminution and 2-3 fragments are depressed. And the elevation is the subjective phenomenon. So how can assess? One of the method is that the meniscus you have to elevate and you can see. Yeah, in other methods, or can we any other methods are there we can see the proper reduction?
Elevation is a subjective phenomenon. Can you explain?
In some when you elevate, somebody feels it's okay. Somebody, if other assistant is there, he say we can elevate little bit. So there is different little bit elevating.
So in such fractures, so usually the medial side is less injured or less comminuted. So you have to build up the medial column first and then work on the lateral side. And if you have too much comminution, so just maintain the length and the axis. That is most important.
Okay. Sir, may I? Thanks.
Keep the anterior and the posterior horn intact. Elevate or cut the coronary ligament, the attachment of the center part of the medial meniscus, and elevate them. Give a valgus, so you can see beautifully the up to the intercondylar eminence. So what do you do in total knee? We are already cutting that. In total knee, what are we doing? We are elevating that deep part of the collateral ligament. No, you are there are two things, superficial and the deep part. I'm talking about the deeper part of the collateral ligament. When you're doing a total knee, the deep part
Let us
is
discuss this afterward, please. I call upon Dr. Sanpure to give his talk on.
Thank you, sir. Now we'll call Dr. Suprapatellar to enlighten us about the plate fixation of the complex upper tibia fractures.
Thank you all. My talk has been made very easy by Gawai sir. Most of the things probably you will find a lot of overlapping. So I'll try to skip whatever has been talked by Gawali sir, and I'll try to be in time as much as possible. So coming to the proximal tibial fractures and management of different fractures. We all know the mechanism of injury. It can be varus valgus or axial loading or a rotational force, or it can be combination of all of them. And understanding the mechanism of injury is very important to know the pattern of the fracture, and then we can decide the plate fixation. Again, this has been talked right now about the X-rays, various views of X-rays. I did not have to repeat the importance of CT scan. In few selected cases, we can subject them for MRI. MRI is also necessary to understand the status of collaterals and meniscus. So as we just now discussed, CT scan is it has got 100% sensitivity and it is must in all cases. Again, we discussed this very famous fracture Schazzer classification. We all have been following this for many years now. So type 1 to type 4 labeled as partial articular fractures. Type 5 and type 6 are complete articular fractures. So it is very important to classify these fractures before we plan the fixation. Similarly, we have AO classification, type A, exarticular, type B, partial articular, type C, complete articular. So type A and B may correspond with Schazzer 1 to 4. Type C corresponds with type Schazzer 5 and 6. So coming to the treatment principles, we have to reduce the articular surface. It has to be anatomic reduction of the articular surface. And for the metadiphyseal region, we have to restore the length, axis, and rotation. At the same time, we should be able to repair if there is a torn meniscus. And the aim of the surgery is to start early mobilization. We all know since our post-graduation days the indications for non-surgical treatment. I need not have to repeat them if the articular step is less than 3 millimeter, if the condylar widening is less than 5 millimeter, and if there is no varus, valgus tilt up to 5 degrees can be acceptable, and these are very few indications for managing the fractures conservatively. Coming to surgical indications, for the lateral condyle, lateral tilting of the tibial plateau more than 5 degrees, step off of more than 3 millimeter, condylar widening more than 5 millimeter. Coming to the medial condyle, the indications being all displaced medial condyle fractures should be fixed. Bicondylar fractures with varus valgus tilt more than 5 degrees, and a posteromedial displaced fracture has to be fixed. Just now we discussed we should be aware of compartment syndrome. Position of the most of the cases can be done in supine position. Few surgeons may use this angle frame. Coming to the approaches, for pure split fractures we can use minimally invasive approach, that is before. But for fracture specific, for medial or lateral, for pure depression we can use a medial approach or a lateral approach. Or for bicondylar fracture, a single midline approach can be used. But what is common for bicondylar fractures is combination of anterolateral approach with a posteromedial approach. So this is the commonest approach, a combination of two approach we are using. Earlier, many years back, this Mercedes-Benz approach was there, but with a lot of soft tissue complications, it is being discarded. So this is how we take anterolateral approach from the tubercle, postomedial approach on the postomedial border of the proximal tibia. This is the anterolateral approach where at the same time you can visualize the lateral meniscus, and the lateral meniscus is the guide to elevate the articular surface. Right now, Dr. Gadewara was asking what is the landmark for elevation. So the under surface of meniscus can give a good guideline for elevation of the articular surface. This is the postomedial approach between the semimembranosus and the medial head of gastrocnemius. This can be done in a floppy lateral, in a figure 4 position, or can be done in a prone position. This is how the plate can be keeping the pes intact. We can slide the plate under the pes, or if at all you have to cut the pes, you can repair the pes. Superficial MCL can be elevated to some extent. Coming to partial articular fractures, that is type 1 to type 4. The surgical tactics for partial, so important is articular reduction. It can be direct reduction, or sometimes you can use a distractor on the medial side. Indirect reduction with the help of C-arm, or it can be done with arthroscope, and stabilization can be done with interfragmentary screws. And in elderly patients with poor bone quality, a T or L buttress plate can be used. So coming to type 1, it is just a split fracture. It can be done, open reduction can be done, or a percutaneous fixation can be done. And it is fixed with a lag screw or a buttress plate. So similar fracture, you can see here, good bone quality. I don't think the cursor is moving. A good young patient, good bone quality, only screw with couple of screws with washer is sufficient. Elderly patient, the X-ray below elderly patient will use the buttress plate. So type 1, either you can, depending upon the quality of bone, you can do it only with screws, or you can buttress it with plate. Coming to Chasga type 2, that is split depression. You have to take a submeniscal orthotomy, elevate and bone graft the fragment, and then fixation with a buttress plate. Chasga type 2 is mandatory to elevate bone graft and plate with subchondral screws. So here it is very important to put the screws in the subchondral bone to support that articular fragment. Another case where we have used the bone substitute to support the depressed fragment. Elevation, buttress plating, and bone substitute to support the subchondral collapse. This is another patient, 20-year-old patient, road traffic accident. This is, you can see split depression in the CT scan. Here an additional rim plate has been used. This is a 3.5 plate, a contoured, very small plate, additional fixation on the lateral tibial condyle. So in addition to a raft plate, a small plate, horizontally placed, contoured, low profile plate has been used to fix the comminuted lateral condyle. Coming to the pure depression type, that is type 3, which is unable to percutaneous techniques under CIAM, or some surgeon may use a fluoroscopy or arthroscopy. You have to create a metaphyseal window and elevate and bone graft it, and screws can be placed beneath the subchondral bone. So here this is being elevated. This is a case pure depression. You can see the cortical rim is intact. It is pure depression. So this is elevation and fixation only with 3 screws, plate, no plate. Another case, elevation and fixation with a small plate, rim plate. This is called as a rim plate with screws, multiple screws to support the subchondral bone. Type 4, it is a medial tibial plateau fracture frequently associated with postomedial fragment. So here 2 plates are required. And as we discussed, it is very common with peroneal nerve injury. It could be associated with popliteal artery injury. A femoral distractor can be used to achieve the reduction, and then a clamp is used to hold the reduction. A medial plateau fracture, CT scan. So here reduction and fixation using a posterior and a medial plate. This fracture required 2 plates, one on the posteromedial side and one on the anteromedial side. So 2 plates were necessary. So just couple more minutes and that's it. Coming to the type 5 and type 6, that is complete articular fractures. These are bicondylar fractures, require lateral and medial stabilization. So this was a bicondylar fracture. 2 plates were used, and this was done with a single midline incision. So this you can see here, you can see a single midline incision. This is how we do stabilization of the medial fragment. This is here we were lucky. A bicondylar fracture was fixed with a single screw, single plate, single lateral screw. But this is a very lucky situation where we could manage it with a single plate. Coming to the bicondylar fracture, single lateral plate is not sufficient unless you have a polyaxial locking plates are used. Uniaxial lock plates may require additional medial screws. Bicondylar plating with at least 1 lock plate is the best. We should always avoid varus. Single unlocked lateral plate is like a time bomb, and it is very soon it will collapse in varus. Type 6, 2 incisions. Most common is anterolateral incision and a posteromedial incision. If the soft tissues are soft and they allow 2 incisions. So we all, as Gawai sir said, always posteromedial plate has to be done first. Then anterolateral is the next fixation. These are few intraoperative pictures. First, we stabilize the medial fragment and then complete the fixation with a lateral wrap plate. Posteromedial fragment require additional posteromedial buttress. Higher subsidence is not done. Late flexion, varus collapse, and osteoarthritis is very common. This is another example of a posteromedial fragment fixed with posteromedial plate and then a lateral wrap plate. Another case of dual fixation, a posteromedial plate and a lateral wrap plate. We won't go into the details of external fixation. They are temporary fixation, hybrid fixation, arthroscopy assisted. So worst outcomes are associated with poor articular reduction, inadequate fixation, varus collapse, bone and cartilage defects, if a fixation is associated with meniscectomy and in elderly patients. So in summary, for a sagittal plane fracture, a single lock plate is sufficient. For a coronal plane fracture, posteromedial buttress is must. Always preserve and repair the meniscus. Prevent varus alignment and beware of the soft tissues. Thank you.
This question. Is any question?
Wonderful illustration of the proximal tibia. Now we are hopping for distal tibia fractures. And Sir Motwani sir will help us to understand the principles of plate fixation in external distal tibia fractures. Thank you.
Good evening, everyone. So, next 10 minutes, my job will be to discuss the approach selection, and before the approach, we need to discuss about the general consideration about the pilon fracture. So, first thing is everyone know that what is the definition of the pilon fracture. All the fracture which involve the articular surface of the distal tibia, they have been classified as a pilon. All articular surface. Is it completely defined the pilon fracture definition? What is this? Is it a posterior malleus fracture or a pilon fracture? Any fracture involving the distal tibial articular surface is a pilon. So, how to define whether it is a malleolus fracture, because the fixation model is completely different, or it is a pilon fracture? So, posterior malleus fracture, if it is involved in the lateral view, if it involves more than 1/3 of the surface, it has to be considered under the pilon category. If it is less than 1/3, you can consider this as a malleolus fracture. So, all the fractures which are involving the distal tibial articular surface, except medial malleus, except lateral malleus, and the posterior malleus involving more than 1/3, has to be considered under the pilon. AO classification, we all are aware that the tibial pilon, and what they have considered in the type A is you have to consider 8 to 10 centimeter of the distal tibial length in the pilon category. So, mechanism of the injury, some things are very common in India. Some mechanism of the injury, they are very common in India, and we have seen many kind of such injuries causing a lot of complex trauma to the proximal tibia as well as the distal tibia. The fall from the height axial compression, this is not a new thing for us. We know that the talus is a pilon. It is actually a solid bone over which the distal tibia it gets hampered, and depending upon the force, axial force, where it left, medially or laterally, we get different kind of the fracture pattern. So the same kind of injury here, you can see what is a compressible surface where you get more comminution. If the force existing in the varus position, we get a compression failure on the valgus or the varus type, depending upon the axial force. Similarly, the tensile surface where there is a less comminution, and when the fracture is a simple looking, it is a tensile failure. So these are all the surfaces which we need to know before we apply a buttress plate or we understand the principle of the fixation. Plantar flexion injury, depending upon the force of the direction of the foot. What was the direction of the foot when the patient fell down from the height? And is it a neutral angle dorsiflexion or the plantar flexion injury, which give us the idea about where we need to work on which part of the distal tibia is more comminuted and it is broken, like anterior, middle, or posterior. So there are various mechanisms of the injury. One of them is the shear force, where the torsion is combined with the varus or the valgus, and it usually produces a larger fragments. So in the clinical evaluation, we are all aware that you need to understand the limb as a whole. Most pilon fracture, they have been associated with the high energy. What is the importance? You have to look for neurovascular as well as the soft tissue status. So evaluation of the other injuries associated with the pilon, like the syndesmosis, is also important. But the meticulous assessment of the soft tissue is the most important in deciding the proximal tibia and the distal tibial fracture, as Sangeet sir has already mentioned. There is a significant damage to the soft tissue because, as I said, this is a high energy trauma, and these are the various patterns which we usually see in our clinical practice. And this is an area where you have to keep away yourself from the patient, where you don't have to go into the active ORIF fixation. There are another way of classifying the distal tibial fracture also. Will not go into the detail, and I will not go into the detail into the AO classification. Depending upon the combination, they classify the three main categories: extra-articular, partial, and complete. But how to manage such bad injury is my job. So if you just look at what happened in the 80s and the 90s, and if you just look at the literature, you'll find that a significant amount of the patients, they have the significant amount of the patients, they have landed with the complications. You may see additional surgeries rate, you may see a lot of amputation rate also, and a lot of infection rate, because that was the era when everything was fixed in the one stage. Early open reduction interfixation, everything in the one stage, a lot of fracture stripping, bulky implants, 3 mm, 4 mm, prolonged tourniquet time, long surgery time, they have all landed with this dark era complications. So these are the limb-threatening complications that we have seen in 80s and the 90s. But if you see the today's protocol, everyone are aware that it is a two-stage protocol. We need to go for the open reduction interfixation. Once everything in the soft tissue part is settled, plan, scan, and so you have to span and then scan and then plan. Sorry. So first thing is the fixation of the fracture by the external mean that we all are aware, percutaneous and the limited approaches, and a low profile implant. And look at the complication rate. They are drastically reduced in these days. There's hardly 0 to 10% of the time we'll end up with the complication if we follow the same principle. So this is how we need to span it with the external fixator, which give us the traction and the stability. Do the CT scan, and then you plan on the CT scan what will be my approach and how to reconstruct the soft tissue as well. So here is a 32-year-old male. He fell down from the height, presented within a few hours to us. The fracture is short. Here you can see the talus is subluxated anteriorly. Soft tissue, they were very bad. The skin was compromised. So this is how it was managed. Let's see and understand each and every part of this three-stage principle. So here we are spanning with the external fixator. What does it mean? Along with the spanning, I am doing the fibula plating also if my soft tissue is supple on the lateral side. Why? Because if I fix one part of the injury, that gives me some of the advantage of ligamentotexis. We all are aware that there are the 3 sets of the syndesmotic ligament. So if you pull one bone, another bone, it comes into the place, and that is called the ligamentotexis. So this is how you get an importance in the first stage of the external fixation, where you get anatomical restoration of the fibula, and some of the part of the distal tibia they get aligned through the principle of the ligamentotexis. So this is how we plan on first stage. Now, a sequence of the bone fixation stabilization is very important. Many of the time we are confused what to fix first, tibia or the fibula. So there is a simple tip. Whatever looking simple, fix it. So if in first example, the fibula is looking at transverse fracture or a slight oblique fracture, 2-part, no combination, fix it. On the second case, you can see that there is a lot of combination on the fibular side. Compressile surface is a fibula, tensile surface is a tibia. 2-part fracture is a tibial, fix the tibia first, because this is a stage when we are getting the advantage of ligamentotexis. Ligaments from tibia is to fibula. So you can fix any of the bone. There is no one principle. Now, how we need to fix the fibula? What is the approach for the fibula? There are only 2 approaches. Either you put a direct incision on the fibula or you put posterolateral. And this, how you decide in stage 1 is you through your future anterior incision. So at least you should keep a gap of 5 centimeter. So plan it accordingly. And is there any posterolateral fragment? Look at here. Here's a big posterolateral fragment. So this is a posterolateral approach separating the peroneal tendons, fibula. This is how I'm doing a plating to the fibula, FHL, and this is a distal posterolateral unique cortical fixation only. Don't put a bicortical screw. So this is back to front fixation pattern, and this is how we maintain the length it doesn't reduces the articular cartilage, but you can at least mobilize the patient. Look at the infection rate, very less if you go with this protocol. And after the scan, you need to scan and then you need to plan. So how to plan? CT is a very important tool, same like the proximal tibia. It is important even in the decision making. It changes the decision making in 64% of the cases. So how to decide area of the injury? What is my area of comminution? Which approach I need to use depends. 1 minute, sir. Anterolateral or anteromedial, that depends what is the most dominated area. AO says look at the size of the anterolateral fragment. If it is a big size, go with the anteromedial approach. If it is a small size, go with the anterolateral. So same thing in the different language. These are the different surgical approaches: anteromedial, anterolateral, and this is how we fix it. When to add a medial buttress plate when there is a compression failure. Look at the example here. If I am not, this is a case where everything was done in the perfect manner. Look at the importance of the medial buttress plate. This got infected, medial plate was removed, and it is got into varus failure. So to avoid the varus failure, always buttress the medial compressible surface, and this is how we need to manage. So this is our take home. We need to consider the alternate approaches, fragment specific fixation, keep all the resources ready, and do the efficient surgery with a good preoperative plan. Thank you.
Any questions?
Hello. Thank you, Motwani sir. Now I would like to call Dr. Garibune sir to illustrate the suprapatellar nailing principles.
Sir, mic please. Sir, what is it?
What concept of the fibula fracture at the first stage is to avoid it. Then only you fix the fibula, otherwise fibula is fixed. Then you would totally plan the fixation.
So I completely agree with you, sir. You can avoid the fibular fixation in the external fixation part. But if your skin allows on the lateral skin, if it is allowed, at least the plating of the medial, the lateral fixation, your future part will be easy. So it is very easy to go, because with some ligamentotexis, your articular piece will come on the way. After operating 2 to 3 weeks, it is always difficult to mobilize the articular pieces. So at least if you fix it on the first floor, if it is allowed, otherwise no problem.
Thank you, sir.
So, good afternoon. This is suprapatellar nailing surgical technique. Mostly high energy trauma, high incidence of neurovascular bundle. Direct surgery into region would further damage the precarious blood supply. Complications and prognosis are directly related due to soft tissue injuries and hence bypass the precarious zone by nail. Challenges of nailing in the proximal and distal tibia, as you know all, wide medullary canal, intra-articular extension. Catastrophes of improper technique, procurvatum, valgus, and we will find that classical infrapatellar nailing with knee flexed to 90 degrees leads to predictable deformities, apex anterior, posterior translation of a distal fragment, and you get a valgus deformity. This is the classical thing which you see in practice. Differences in proximal and distal tibia. Quadriceps is the deforming force. In fibula is the deforming force. In between the two proximal fixation and distal fixation, entry point is crucial in proximal tibia, whereas central position of the nail is important in distal tibia. Nailing in hyperflexion, maintenance of reduction and imaging is very difficult. Hence, ultimate result, malunion, malalignment, instability, and failure. To overcome the deformity of proximal and distal tibial fracture, what is the solution? Suprapatellar nailing in semi-extended position with adjuvant clamps, polar screws to reduce and stabilize the fractures. Retropatellar approach, trans quadriceps. Gadegune Pandya Simshankar for suprapatellar nail. It is available in the style of Yogeshwar. We have designed it and modified it with both of us. Describe this simple method of suprapatellar nailing. Indications, all tibial fractures, but mostly proximal tibial fracture, segmental fracture. These are all instruments you will see here. Because of the lack of time, I will not be able to everything. Semi-extended position, multi-knock nail to be used in suprapatellar nailing. Posture under the knee to maintain 15 to 20 degree of flexion. Do it only in a supine position. Surface marking, you can see here, this is the most important patella, quadriceps tendon, and a quadriceps, this is suprapatellar incision approach. This is the Steinman pin is fast, and this is very important because between the 2/3 and posterior 1/3, it directs your guide wire and nail anteriorly and prevents posterior migration of your instrumentation. This is the Steinman pin. Also, it helps in the manipulation valgus varus. You can produce reduction, and this helps in all activity. Inflation of the knee joint with 30 ml of saline to see the palatability of the patella. Unless you have a palatable patella, you cannot pass a nail underneath the trochlea. Helps the testing the movement of the patella. That is so important in the management of this suprapatellar approach. Incision 2 cm vertical through quadriceps, 1 cm proximal to the upper pole of the patella. For optimal entry, it should be possible to run a finger easily under the patella and to the knee joint, and we have to break all adhesions with the articular forceps or by fingers. And then you pass the sleeve, insertion of the sleeve, trocar, make the entry point, reference point is a fixed, medial to the lateral tibial spine and anterior. If you have some problems of medullary canal, then you can pass antero-posterior pin also. Exchange of the trocar, guide to the sleeve and guide wire introduction. This is, you can see how it is to be done. So the most important is suprapatellar nailing. You have to pass a sleeve underneath the patella very, very carefully. Otherwise, you will damage all the chondral structure. That is not a condition to the procedure. So this is the guide wire it passed. And you can see here, proximal reaming is done. And with the anterior-posterior, mediolateral Steinman pin, you can guide your guide wire, guide pin anteriorly. This is the proximal reaming. And after the proximal reaming is over, then what you do, exchange the guide wire with the regular guide wire. And then with the regular guide, this is the sleeve, exchange of the guide wire. You can see it, and keep the fracture reduced while introducing the guide. So how to keep the fracture reduced? By a clamp or by manual reduction. That is the most important thing. And then for proximal reamer, what we have to do? Proximal reaming is done by a rigid reamer for near about 6 to 7 centimeter. Why? It is because if a flexible reamer used in a proximal part, it will go translate here and there. So we have to create a path first with the rigid and then reaming with a flexible reamer. This is the most important step. Monitor each and every step that the fracture should be reduced position. Then introduction of the nail, and last part we can do is some hammering. Nail must be in the subchondral and K-wire proximal locking. There are K-wire is there to see whether it is properly subarticular or not. And then proximal locking is done. 2 mediolateral, 2 oblique, one at the 45 and one at the 65 degree. And then after this, compress the fracture, see in the image, and then do the distal locking. So distal locking is a free-hand technique. You can use 3 locking bolt, 2 locking bolt, depends on the configuration of the fracture. You may also lock first a distal locking, and then by doing some pulling effect, you can do a proximal locking, removal of the jig, polar pin. If you think that there is a poor unstable construct and osteoporotic bone, polar pin can be replaced by another screw. After removing the jig and everything, you must wash the joint. That is the most important step by normal saline, so that the debris of any bone should not be inside the knee joint. This is the minimal invasive surgery, proximal and distal locking. CR positioning easy to execute during proximal and distal locking without changing the position of the fracture. That is the most important. These are all X-rays. I have done innumerable cases. There are so many cases to share. Segmental, proximal tibial, distal tibial, and comminuted distal fragment. It is one of the best method where we are facing with the problem of keeping the fracture fragment together in the distal fragment by intrapatellar approach. Do not change the position. Fix the fracture with the clamp or with manual reduction. Pass a very small Stillman pin into the calcaneum to give a traction so that your fingers and hand is not in the way of your emergency fire. Segmental fracture is the position is very concentrate on proximal fragment first. Reduce the proximal fragment, pass the reamer, and then negotiate into the distal fragment. Very, very good position method for precocious of PCC. And you can see here where plating or nailing by intrapatellar approach is difficult. So there are innumerable examples. Post-operative rehabilitation is very fast, close tunneling, and literature also supports that the proximal tibial nailing scores for the intrapatellar approach. In conclusion, suprapatellar approach, shorter fluoroscopy time, less knee pain, better knee functional recovery, more accurate fracture reduction, no increase of postoperative complications, but more RPCs are required. For further research, I have done till date 52 cases, and my results are wonderful. Simple access to entry at a proximal tibia facilitated fracture reduction, avoid patellar tendon injury, extended position of the lower limb allows easier fluoroscopic image, lower use of intraoperative fluoroscopy, cartilage damage is mostly theoretical. Therefore, friends, do this procedure, you love it, and probably you will be able to do a perfect anatomical restoration by suprapatellar approach. Thank you very much. You can do it by intrapatellar approach. There is no problem. A recent article in 2022 January, they said that you have now a very proper instrumentation. You can do it by minimally invasive suprapatellar approach also, but I have done it by intrapatellar approach, and it can be done because the nail is just lying underneath the tibial tendon insertion at the tibial tumor. Thank you very much. Yes. मी आता असं सुप्रापटेलर नेलच्या प्रेमात पडलेलं त्याच्यामुळे ऑल टिबियल फ्रॅक्चर्स आय डू इट बाय सुप्रापटेलर.
Thank you, sir. And I would like to call Dr. Shivashankar to explain us nailing in extremely distal tibial fractures.
The advantage of suprapatellar approach is you have kept the leg on a table. So you are taking the APL lateral of the CR and the surgeon can be operating also. That's one. And about the removal, why we are using suprapatellar approach? Because we don't want to, when we flex the knee, proximal fragment goes into procerbatum. So to avoid that, we are using suprapatellar approach to pass the nails in a reduced position. So once it is united, then removal is not a problem because the entry is almost same. It's only the approach instead of intrapatellar approach which causes the procerbatum. We have put it from the suprapatellar approach. So the entry of the nail is regularly from the same approach as the intrapatellar. So removal is done from the intrapatellar approach. Good afternoon. Probably this is the 7th or 8th workshop I have been conducting in NANDED. I remember the first one, yes, way back in 1998. Femur and tibia interlocking nailing. Then I came for Enders nailing, locking plate, suprapatellar nailing, recon nailing, so many things. And both the MOICons also I was here. Coming to my talk on distal tibial fractures. The limb can be positioned on an orthopaedic table, and the advantage is you can give a calculated traction and reduce the fracture and do a nailing. But the disadvantage is, as you can see, the surgeon has to stand on a stool. This is Dr. S. Venkat at Coimbatore. So he was doing this demonstration in way back in 96 or 97. So other way we do is by hanging by the side of the table or at the end of the table. I normally keep 2 or 3 pillows on the table which is marked with red, and over that I keep the knee and the, so that it is not going too much down on the ground. As said earlier, we can also use surgery frame for tibial fractures. The problem with a distal tibial fracture is because it's a wide metaphyseal area, junctional area, there is an instability, and as the interlocking bolt comes too near the fracture site, the chances of failure is very, very high. Coming to the fixation, you have to put a distal tibial nail exactly in the center, and nowadays we have got the multi-locking expert tibial nail available which has made our life easy. The fixation of fibula can be done either with an intramedullary rod. If the fracture of the fibula is about 8 centimeters from the joint line, then you can use this fixation, or you can also fix with a plate. So normally I fix with a nail if the fracture is transverse of the tibia and almost at the same level as the fibula. Then I'll fix with a nail, and if the fibula fracture is comminuted, then I will end up treating with a plate. So that is my indication. And I don't fix all the fibula also. There are some cases where I don't fix it. show some cases. And the order of fixation. Always, if you see the literature, every day says that fix the fibula first so that you can maintain the length. No, pass your guide wire in the tibia first. What happens is if you fix the fibula first, when you manipulate the tibia to pass the guide wire, your fixation in the fibula you will lose many a time. So always pass the guide wire in the fibula first, then fix the fibula. After passing the guide wire in the tibia, then fix the fibula. As in this case, I am using a talon nail. Then I am reaming the tibia. Then I am using a standard tibial nail which was available. This is a very old picture. So, and also the fracture was little high, so you can see a regular nail has been used and it has been fixed. So this is the way we do it. But for fractures which are very, very nearer to the joint, are up to 5 centimeters from the joint can be managed by putting proper polar screws. So polar screws are blocking. If you don't want somebody to go into that room, then we can put a block there. Similarly, if this tibial, the D nail was going always medially, so what I did, I put a block there medially. So the nail went lateral to that. So this is what the block screw does it. And this is the clinical picture in the same patient. And you can see that the alignment has been quite good. This is way back in 2005. This is another case. This case came to me almost after 4 months after the initial injury. I had to open the fibula and patient the ends and fix with tension band wiring. For fibula, this was my preoperative planning to pass 3 anterior posterior K-wires as polar and 2 lateral medial wires. Similar, same thing I have executed on the table, and my nail will be going in between them. So that has what happened. You can see that my nail went inside properly and the fracture united in a beautiful way. Unfortunately, I don't have the AP picture of the united fractures. This video of this distal tibia fracture is there in the YouTube. So this is a case which has been demonstrated. I don't want to go to the details, but I'll show some of the steps there. The guide wire, you can see that the guide wire is going medially, not in the center, and slightly anteriorly. So once I pass the guide wire, I pass the fibular wire and fix the fibula. Once I fix the fibula, I knew that my guide wire was going medially. What I did, I passed the K wire from anterior aspect medial to the K wire, and I tried to push the guide wire slightly towards the center. And this is what I did, and then I passed the nail. So my K wire is acting as a polar there that guides the nail now more towards the center. Can you see now? Whatever I wanted to achieve, I have achieved. So it's not necessary that you have to reduce and pass the guide wire. You should know how to overcome if any problem is recognized during the course of your treatment or while you are operating. Then I did the distal locking. Then whatever the guide wire I had passed, I passed a polar screw in that. So this is a smaller wire, which is a bolt. You can see 3.9 millimeter bolt. This is medial to the nail distally. That is polar screw which I have passed, and this is the end of the surgery. It's a 70-year-old lady. That's why I didn't mind little proconvatum deformity happening in the distal fragment. If you see, the Girish will be thinking I would have corrected this angle also. So I thought that 70-year-old lady, so distal fracture, I could have passed one more polar screw just behind the nail in the posterior aspect to correct that also. But I thought it's working, so I left it at that stage and it went out very well. Similar case, Dr. Kadigan subsequently shared with me after seeing my video on the YouTube. So almost identical case. Again, you can see he has used polar screw on the lateral side. I had used the polar screw on the medial side, but he has used the polar screw on the lateral side in the distal to the tibia. So where you don't want the nail to go, if there is no hook rule that it has to be passed medially, it has to be passed posteriorly like that. Where you don't want the nail to go, block it. That's all. So earlier I was using the regular tibial nails, but with the availability of the extreme distal tibial nails available in the last 3 centimeters, also we can do the nail proper fixation with 3 bolts. So this is was a regular tibial nail which has been used, and the fracture has united beautifully without any problem. Again, here you can see I have used a polar screw again in this case in the tibia anteroposterior picture. You can see that is to lateralize the tibia, when lateralize the nail, you had to support one of the cortex. Either the medial cortex of the tibia, the nail should be supporting, or the lateral cortex of the tibia, the nail should be supporting. And accordingly, you put the polar screw so that they are aligned properly. Another case, again, I have used a polar screw in the distal fragment and the clinical picture at the time of removal. So another case, again, here you can see there is little comminution in the tibia, so I have not fixed the fibula also, and the fibula is also slightly higher up at this after the implants have been removed. Very distal fracture, again, I have used, since the tibia fibula is not comminuted, I have used a wire, and you can see even in such cases also there is some amount of dynamization is required. So I always do the dynamization. Here you can see there is a fibula comminution. Though the fracture of the fibula is at the same time, I want the collapse to happen, so I didn't fix the fibula intentionally. If I fix the fibula, what happens is it acts as a distractor and the tibia will never collapse. It takes unusually longer duration of time. So I try to get the union first rather than maintaining exact length with the patient, and the patient did extremely well. Again, intra-articular fracture extending, we fixed that with K-wires first, then we did the nailing in this patient. One more case, non-union, again you can see I fixed the nail with the polar screw on the nail, yeah, and the patient is walking in the immediate post of failure. Last two cases, extreme nailing. These are not my cases, these are Rajat Varma's case. Very distal, badly communicated fractures, and these cases, they have done the nailing in King's Hospital in London, where we had come for Meet the Master activity in Aurangabad. He shared these slides with me at that time. You can see the alignment, getting the alignment is very important. That's Rajat Verma in the, on the right side. Another badly communicated distal tibial fracture, again in his own case, the CT scan, initially treated with the external fixator, then you can see all the wires are pushing them fragment in position, then each fragment is fixed somehow with one or the other screw, and a nailing has been done to neutralize, and you can see at the end. This is a picture and after the fracture is generated. Thank you very much.
So, Mr. Prasad, the session is over now. I hand over to the organizers.
We have had a wonderful discussion on the fractures of proximal tibia and the lower third tibia. Moving on to the next session, may I invite again Dr. Shiv Shankar sir for his talk on economical external fixation for distal radius. And to moderate this session, I would like to welcome Dr. Tunjanwar sir, Dr. Suresh Kadam sir, and Dr. Mukesh Malu.
Respected dear persons, can I start? Okay. Already we are running 1 hour late. I'll be talking about an innovative external fixator. This is just uses 40% of the regular inventory required for a multiplanar fixator. We all know comminuted fractures can get reduced well, but in due course of time, collapse happens, and that leads to the problem. So we have all have seen the badly deformed wrist patient coming late. This case, the surgeon had treated with a K-wire. In spite of that, you can see so much of collapse has happened and the fracture united in such a bad position. And subsequently, the patient was not ready for re-osteotomy at the fracture site and correcting the radial length. So I had to do only direct procedure and shorten the ulna. And stable fracture, K-wire fixation, yes, it does well, no problem. Unstable fractures, we can do the plating. Other people are talking about that, so I don't want to step on their area. We are really getting good results. For badly comminuted fractures, sometimes ligamento-taxis with external fixator is required, where we put 2 radial chance pins and 2 metacarpal chance pins with a hinge. And the problem is you cannot control the translation. If you see the second X-ray, second picture, the radius is translated. So with a uniplanar fixator, that translation cannot be controlled. And many a time these fractures additionally require internal fixation in the form of K-wires, or it also requires hinge. So these are the additional things these are required in this patient. So you can treat these patients with multiplanar fixator, like one of them is JESS. But JESS is such a cumbersome thing to pass so many wires. So you have to pass almost 15-16 wires and so many clamps you have to tighten. JESS is a good instrument. I think Elizro is a overkill for this ligamentotaxis in a distal radial fractures. So we have come out with the Solapur frame with just 40% of the inventory. So I'll talk about this. Earlier, when I was a resident and as a lecturer, what we were doing is we used to put radial side 2 Shan's pin and 2 metacarpal pins, ulnar side 2 Shan's pin and 2 metacarpal Shan's pin, and fix them separately as fixator, and cross connect these two with another 2 rods with another 4 clamps. So what was required was 12 clamps and 4 connecting rods, and 8 Shan's pin was required in all these cases to give a quadriplanar fixator. Once I was operating, I was a lecturer in medical college, I was operating, and after applying the radial side, I applied the ulnar side also. The sister said that the clamps are not properly matching. They are not getting tightened onto the rod. So that's why what we did was, I removed the one I had already fixed on the radial side. I removed the clamp and cross connected on the ulnar side. This is not the same case. So cross connected those clamps to the ulnar side, and Dr. Raghav Barve, who is in Pune now, he was assisting me. He said that there is one more clamp which can be still used, and he asked me to fix it in the center. So this gave a quadriplanar fixator in this patient. So the patient did so extremely well. I was very happy that my time of passing 8 Shan's screw has been saved to 4 Shan's screw, and using 12 clamps has been reduced to only 5 clamps. I was very happy that very minimal number of implants I am able to fix them, and the results were so excellent. Only thing is, you have to pass the Shan's pin. The number 1 Shan's pin you have to pass from the base of the second metacarpal into the base of the third metacarpal also. Don't just pass it in one metacarpal. And number 2 is passed in the shaft of the second metacarpal. And the angle between them should never be less than 90 degrees. It should be always more than 90 degrees. If it is less than 90 degrees, it becomes a uniplanar fixator. So always your angle between 2 Shan's pins should be more than 90 degrees. It should be ideally around 120 degrees. That is the angle you should aim at. Similarly, 2 Shan's pin, number 3 and number 4, are passed in the mid radius. Again, they are passed at an angle of 120 to 90, more than 90 degrees between them. So that is very important. And this is a 4 mm by 4 mm escalap clamp, which can take a 4 mm Shan's pin and 4 mm connecting rod. This is a 2.5 mm into 4 mm Shan's pin, which are all available by all these surgical company, which can take metacarpal Shan's pin on one side and regular 4 mm what we call connecting rod. So here you can see that I am peeling the base of the second metacarpal and making a small incision and drilling with a K-wire, and I will be passing the metacarpal Shan's pin through bases of both the first and second metacarpal. So this is how I normally do it. It hardly takes less than the time to apply a plaster in these police fractures. It hardly takes 5 minutes or 7 minutes for me. You can see it is going through both the metacarpals. That is very important. Then second one is passed. You have to flex the index finger so that the tendon is not impaled, and assistant holds the full flexion of the index finger, and the second wire is passed in the second metacarpal shaft. After you do it, again the radial Shan's pin is applied. It's a thicker 3.5 to 4 mm Shan's pin which will be passed there. So again in the similar fashion, you can apply the radial 2 Shan's pin one after the other, and this Shan's pin, it has come out of the opposite hand side, we normally confirm. Now you can see that I am tightening the clamps only. It's a X-shaped clamp. I'm tightening only on the two radial shank pins. I'm tightening. Assistant will give traction. One will give the traction from the elbow. One will give the traction from the wrist. And in that traction given position, I just tighten now the distal metacarpal shank pins, the escalar clamps on the distal metacarpal. So because getting a reduction is not at all a problem. Just give traction, it gets reduced. So whatever the position you get the reduction, in that position you can keep the hand and you tighten this clamp. So you can see that you can give plantar palmar flexion as well as ulnar deviation without any problem. This is a quadrilateral plane. It is not a uniplanar fixator. Again, you can see palmar flexion. Then extra length of the shank pins are cut and it should not hurt. So we apply sticking plaster. The patient uses the hand for regular activity. Normally, if the patient is given traction, I keep it in traction position for about 1 month time, reduce at 4 weeks, and remove this fixator about 6 weeks time. So this is an intra-articular fracture. You can see the volar Barton variety, beautifully reduced with external fixator, and the patient had a external to excellent outcome. Another patient, again, we cannot see the because of the fractality and the beautiful reduction and the excellent outcome. So this is the clinical picture, hardly any incision on the hand, and this is the final picture with well maintained all parameters of the wrist. So if you give anatomical restoration, the functional result is good, grip strength is good, and the pain will not be there. Just I will be showing few X-rays like this. So many cases I have treated. This is a bilateral case I have treated. Here there is a ulna which is unstable, so I incorporated a wire also in this fixator, and I could fix them. And this is another intra-articular fracture with external result. This is an impacted fracture. My own neighbor. So this patient came, though there was an ulnar styloid process fracture that was not unstable. So I just fixed with the fixator. Beautiful reduction I could get. Patient was able to do all activities. This is after 4 years. I called her to get a clinical picture. You can see, and because if you see the white area, you know that that's the fracture side. Otherwise, parameters are identical on both the sides of the wrist. In spite of an unstable fracture, he had a beautiful outcome. Another intra-articular fracture, again a good outcome. Again, you can see unstable fracture, stellar process I have fixed. Here there was a volar plate also which was separate. That you can see has come back to position. This is the ulnar stellar process I took. So this is the volar plate. You can see both these two X-rays. That fragment has come back just by ligament retracting. I have not done anything. Few cases where the patient have come late. This patient, no, this is not the thing. You can see there is a depressed fracture. I have not done any elevation, and on the right side it has come back to position beautifully just by ligamental fractures. This patient came after 3 weeks. So what I did was I used a distractor, simple distractor to get the length of the radius. And you can see there is a simple just distractor can be applied. I applied the just radius first and then got the length. Then I applied the solapur frame. Nowadays, what I do is instead of that, I apply the solapur frame first. Over that, I apply the just like this. I distract it, then I tighten the clamps in the solapur frame and I take out the just. This is one such case. This is another case. This is a recently came patient. This patient came almost 2 months after the injury to me. What I did was I have applied the solapur frame down, but I have not fixed all the clamps. Only the radial pins are tightened. All the other clamps are kept loose. So I am trying to distract them with a just distractor, simple distractor. On table I have distracted, and next 2 days in the post-operative period I am distracting again in the ward. And once normally it takes only 3 days. For a 2 months old case, just about 2 days or 3 days of distraction is more than sufficient, and it comes in alignment. Once it comes in alignment, I just clamp the shank pins to the vascular clamps and take off the distractor. You can see that I have taken off the fixator. Earlier there was a distractor on the hand. Now that has been taken off. And as I said earlier, to avoid osteodystrophy, that is reflex sympathetic dystrophy, if you keep the wrist too much distracted for more than 6 weeks time, almost always the patient lands in reflex sympathetic dystrophy. So at 4 weeks, I make it a point to, in the OPD itself, I release all the traction. I just simply tighten the bolts and again call them another 15 days or 3 weeks. Then I remove the implant. This was a bad wound of the volar aspect which you cannot plate it, and I have treated with a fixator. And another case, this was done in my absence in my own hospital. You can see that the shank spin, the metacarpal, is not at 90 degree, and it is not going to the basis of the second and third metacarpal also in an osteoporotic bone. This is the only case where I have the fixator came out. The pins, the shank spin came out from the fixator because of the osteoporosis. Otherwise, core shank spin has never given me any trouble, because many people say that core shank spin, how you can put two sides distractor. So it has never given any problem. This is the last case I am showing. One of my friend, Dr. Venugopal Sambaram, treated this with this passion, and the plastic surgeon was happy to do flap in spite of the pins which was not coming in his way. Friends, analyze the X-ray. Keep ready KVR fixation as well as external fixator. If you get good result, good reduction, stable fixation, immediately fix with KVRs and plastrate. Otherwise, you apply external fixator. Thank you very much.
Thank you, yes, sir, for your excellent presentation and timely presentation.
I think in a country like India, when economy will always be an issue, the kind of fixation sir has shown and the results that he has shown, most of our distant various fractures can be managed in that way. Calling upon the next speaker, Dr. Shivkumar Santupure sir, he will be speaking upon newer design plates in lower and radius fractures.
Coming to the locking plates and management of distal radius fractures. So we'll be discussion to recognize fracture patterns and identify those that require fixation, to understand classification systems and apply them, surgical approaches, and to understand implant design and indication in a specific fracture. So before we discuss the plating, we should understand the problem with lower end radius. The problem is metaphysis is relatively a weak point. There is low cortical to cancellous ratio in the distal end radius. Thin cortical bone, susceptible to osteoporosis and susceptible to fracture. So these are the problems with lower end radius. These are AAOS guidelines for operative indication, that is intra-articular displacement more than 2 mm, post reduction radial shortening of more than 3 mm, and dorsal tilt more than 10 degrees. So to understand the classification system and apply them, so there are several classifications. Additional CT scanning has implications. We already discussed importance of CT scan in proximal tibial fractures. So CT scan is equally important when we are treating lower end radius fractures. So additional CT scanning has implications for the accuracy of scoring the fracture types, especially for simple fracture types. So we all discussed columns, 3 columns in proximal tibia. So similar is the concept in lower end radius, that is column concept, and was discussed by many authors recently. So the column concept is similar here. Coming to the columns of the wrist, this is the radial column, this is the intermediate column, and this is the ulnar column. So we should understand the columns before we plan to fix these fractures. And these columns can be further subdivided into ulnar corner, radial column, the volar rim, intra-articular fragment, and the dorsal wall. So these are the columns. The intermediate column is subdivided, that is into dorsal wall, the volar rim, dorsal, ulnar corner, the free intra-articular fragment, and the metaphyseal defects. And the ulnar column is by the ulnar fractures. So stable fixation of all columns and components start with the simplest techniques. Advanced techniques are needed to address all the fragments. So these are some fragment specific systems which are available, which we can use to fix the smaller fragments. So these were the 5 potential fracture fragments which we discussed, that is the radial column, the dorsal cortical wall, the dorsal ulnar split, the volar rim, and the central intra-articular fragment. So a radial pin plate can be used for stabilization of the radial column. Ulnar pin plate can be used for stabilization of the dorsal ulnar split fragment. So these are small plates. These are called as fragment specific plates, which we use nowadays to fix it. So these are radial and ulnar plates. Dorsal cortical wall fragment stabilization by small fragment clamp. Simultaneously, stabilization of the dorsal wall fragment and intra-articular component is possible with these plates. So this is one example indication for volar and dorsal plating. So buttress plate by volar approach, dorsal approach 2L buttress plates were used. This is EPL tendon which is encountered during the dorsal approach. The extensor retiniculum is repaired beneath the EPL to prevent erosion against the plate. Coming to the role of volar plating, it restores the anatomy, secure articular congruency, it gives increased rigidity and allows early motion. Volar plating identifies the disadvantages of dorsal plating such as extensor tendon irritation, disruption of the periosteum. There are anatomical benefits of volar approach such as there is potential space on the volar side to put a volar plate. It avoids tendons and we can cover the plate with pronator quadratus. Coming to some anatomical considerations with volar plate, the surface is convex and the volar surface is limited distally by the transverse ridge, what is called as watershed line. Fixation must be proximal to watershed line, and the plate fixation is under the ridge. You should avoid contact with, so that you avoid contact with the flexor tendons. It requires disadvantages of a volar plate. It requires elevation of the pronator quadratus. It may strip fragments of some volar periosteal blood supply, and it has got less access to the articular surface, and we may face difficulty in bone grafting the dorsal defects. All these plates are, we all know they are locking plates, and they are fixed angle volar plates. So distal fixation by means of pegs locked to the plate. The pegs can be smooth or threaded, and they provide fixation by buttressing the fragment, and it supports the dorsal aspect of the subchondral plate to prevent fracture redislocation. So coming to the geometry of the peg plate design, so it has got a proximal peg row, it has got a distal peg row. So this creates a 3D scaffold that controls the dorsal and volar rotation of the distal fragment. So these are new generation requirements of the volar plate. It has got extended supporting surface on the ulnar corner. So more distal to capture volar marginal fragment, longer buttressing effect, because now it is a low profile plate and it has got more pegs. So this is an anatomic distal volar radius plate, which is being used very commonly nowadays. So how does it work? So we place the pegs into the subchondral bone, and it also provides cantilever effect. So this is how it provides the cantilever effect. It also provides buttressing effect and the threaded screws to capture the dorsal fragment. So at the same time, you are capturing the dorsal fragments. So coming to the approach, this we all know this is the FCR approach, about 8 to 10 centimeter of incision over the FCR. Pronate the proximal fragment to gain intrafocal exposure. You can hold the proximal fragment of the radius and you rotate it into pronation, and you get access to the intra-articular aspect of the fracture. This is how you pronate the proximal fragment. Position and secure the plate with K-wire. Apply screws or peg to stabilize the lunate fossa. Lunate fossa is towards the ulna. Fix the proximal row first to for stability. Properly applied plate just proximal to the watershed line. Repair the pronated quadratus over the plate. And this is, and then at the end of fixation, you must visualize everything under this arm. So visualize the articular surface with radial and volar tilt views and confirm the screw and peg placement. This volar plate also has got few complications, that is tendon irritation and rupture. So you should avoid fast pointing of the distal screws and keep the plate proximal to the watershed line. Intra-articular placement of the screws, extensor flexor tendon rupture or irritation, malunion and infection. Infection, I have hardly seen any infection with a volar plate. This is how intra-articular screw can lead to malunion, intra-articular malunion. There are, every fracture cannot be fixed with a, just last 2 or 3 slides. Every fracture cannot be fixed with a volar plate. There are limitations. Volar lunate fossa shear fragment cannot be fixed with a volar plate. You need a fragment specific plate. Massively comminuted fracture of the joint surface. Small dorsal marginal fragment of the sigmoid notch, essential for DRUJ stability, cannot be fixed with a volar plate. Comminution extending into the distal shaft cannot be treated with a volar plate. And dorsal shear type fractures such as dorsal Barton has to be fixed with a dorsal plate. So these are some newer plates coming. This is I'm yet to use this. This is a dorsal nail plate. This goes into the medullary cavity of the proximal radius. I'm yet to see that plate. So coming to the dorsal fixation of the distal radius fracture, multi-fragmented dorsally displaced fracture of the distal radius. Dorsal bony defects due to high velocity trauma should be treated with a dorsal plate. But for a dorsal plate, you must wait for 5 to 7 days to the swelling to go down. Midline incision in the third compartment, evacuate the hematoma, elevate the third, fourth compartment sharply from the capsule. This is a indication for a dorsal fixation, comminuted dorsal fracture. So coming to the conclusion, open reduction internal fixation is better in high energy fractures associated with depression of the articular surface. Open reduction gives better anatomic restoration, although not necessarily it gives higher patient satisfaction. New plating techniques allow the accurate and rigid fixation of the fragments. Plating allows early range of motion. Volar, smaller and more anatomic plates are better tolerated. Combination treatment is often indicated. Each fracture is unique and should be treated as such. So it is the surgeon and his understanding of the fracture, how to fix it, not the hardware, that makes the outcome. Thank you.
Very well concluded, Santipuri sir.
Now, can I request Dr. Ashok Godke sir to come on the stage and present about Kapanji technique in Western medial practice?
We have a question and answer session after the completion of the session.
Good evening, everyone. At the outset, I thank NANDED Orthopaedic Association and Indian Maharashtra Orthopaedic Association for conducting such a nice CME. So, just now we had two good talks with an external fixator and plating. So here I am presenting this Kapanji. This technique may be more economical, most economical of whatever is available nowadays. So distal of radius fracture, mostly we advocate for all the dorsal fractures where the dorsal plates is slightly problematic. So some extra-articular fractures, intra-articular extensions, dorso-radial displacement and impacted fractures. So these are the fractures. Different types of fixation available. Yes, closed K wiring, external fixator, just we had and a plating. Different plates, just we had that top. This is Kapanji technique in fixing distal end of radius. So Adalbert Ibrahim Kapanji, a French surgeon, he had described this intrafocal pinning. Very little inventory needed. So we just need a drill Siam 1.8 millimeter K wire with a diamond tip because we cross the opposite cortex. A strong wire cutter, angled wire cutter, because we cut the wire close to the bone, which acts as a buttress, hammer and a folded sheet. So this is the least inventory what we use in a Kapanji technique. Some example where there is a dorsal displacement. So procedure, we use a folded sheet under the wrist. We take a liberal incision. We don't just, without incision, we don't pass the K wire. So a transverse incision, we first try to fix the radial styloid, then the radial column, and then the intermediate column. So after taking incision, we separate the tendon and see to it that we don't injure the superficial region. This is the case. I do it under triple nerve block. We can do under a axillary block also. So this is medial nerve block, ulnar nerve block, radial nerve block. So we give a triple nerve block and a hematoma block. So what is being described? In this intrafocal pinning, we go 90 degree through the fracture site and then we reduce. So we don't use traction, counter traction. We go at 90 degrees. We then reduce the fragment and get it at 45 degrees. And further, we enter into the fracture site, then we reduce it, and then at 45 degrees, we get a purchase on the opposite cortex. So this way. So we use a diamond tip so that it should not go on the other side and injure the soft tissue. This is so after scrubbing, so we take a liberal incision. I mean, just a 0.5 centimeter, and this is the way we pass in. Here we had done just 2 wires and the fracture was quite stable. So the wire is cut deep inside and we suture it. Post-operative, we give an upper slab in full supination for 3 weeks. Later on, we change it into a splint. These K wires are removed under local or a block at 6 weeks, and we start physio. Now the advantage is we can remove the slab and start wrist mobilization. We encourage the finger mobilization. So These are intra-optics. We get a good movement of the wrist. Wide awake anesthesia, and so we give a slab. So we always give a dorsal slab with hand in functional position, what we call it as a change position. And with that, we encourage finger movements, thumb movements. This is the position in which we give a slab. Some examples. Here we have used 3 K wires. Intra-articular extension, very nicely reduced with a Kapanji technique. Again, fracture which is reduced. Here also an intra-articular fracture, very well reduced, and we had used one more wire. So first, we use the wire along the radial styloid. We maintain the lateral column, then the radial column, and then the intermediate column. So these are a few examples. So here it is the pre-operative, intraoperative, and after removing the K wires.
Can I ask?
Yes.
Which are all the wires which are to the fracture side?
All 3, sir. All 3 are intrafocal.
See, the styloid side wire doesn't move to the fracture.
It is just buttressing so that the styloid should not come down. We had even done a CT scan.
Hello.
So here the above one is pre-op, middle one is wire in situ, and lower one is after removal of the wire. Again, we can see here. So post-op, we give a dorsal slab. So MCP movements are to be encouraged. Now, what happens with if we give a cast and all, then the movements may not be done. But here we encourage, basically all these fractures, we want good functional outcome. So even after a week, we remove the slab and we even encourage for the wrist movement. Few cases, again in pediatric age group, whenever we have this bayonet type of fractures, where we don't want to pass through the physis, Kapanji technique is one of the best technique where we can reduce the fracture without injuring the physis. So correction of deformity on the table and a very good reduction. This is at 3 months. Another case, 58-year female. So we had done this Kapanji technique at 6 months. So conclusion, a very easy procedure, very economical, very low implant and surgery cost. No assistance or traction is required. So the basis is we pass in through the fracture intrafocal and then reduce. So there is no need of traction and counter traction. Minimal scar, just 2-3 stitches, and effective technique in treatment of selected unstable dorsally displaced fracture. Thank you.
Hello. So what is the advantage?
So usually with a percutaneous fitting, what we do is we keep the wires outside, number 1. Number 2, we put a cast, right? So we cannot mobilize the wrist. What we can do in this? Because the K wires are deep buried inside, and the K wire acts as a buttress which will not allow it to be displaced.
Migration of the pins are there?
Yes, in few cases we had in osteoporotic cases, but we could retrieve it.
Hello. Any case of dorsal cortex fracture, pivoting against the dorsal cortex.
हमारा भी आवाज बंद कर दे रहा है तो हमारा तो चालू है इकडचा आहे पलीकडा आहे हे सोड
Hello. क्लोज पकड़ा माइक क्लोज पकड़ा हेलो हेलो
Sangeet Goyal sir to come on and present presentation on principles of plate fixation and intra-articular distal engagement factors. So, some part of the lecture is already been covered. We come to the known complications, and these are inadequate fixation, intra-articular screw placement, loss of reduction and implant failure, iatrogenic tendon injuries, neurovascular complications. So these are the complications related to plating of the distal radius fracture. So very often we come across how many screws are required whenever you are doing a fixation in the distal fragment, how many screws are enough. The greatest construct stability is filling the locking holes in all the distal plate holes. Now, most of the locking plates, they have two rows of screw holes, the distal one and the proximal one. So the distal one screws, they have a hold in the subchondral bone, provided it is placed properly. So at least 3 screws should be placed in the distal row, or at least 4 screws in the distal fragment. Out of that, at least 2 screws should be in the distal row and 2 or 3 in the proximal row, gives adequate fixation for the distal fragment. The plate failure is higher if less than 15 millimeters of volar cortex is available for fixation. That means if you consider from the joint line, at least 15 millimeters of the distal radius should be available. That means your 2 rows of screws should be engaged in the distal fragment. For that, you require 15 millimeter of volar cortex. Fixing volar rim or shear fractures can lead to excessive distal placement of the plate, and that will give rise to a iatrogenic injury and complications. So your plate has to be restricted here. If you have shear fractures which involve the rim of the articular surface or very close to the articular surface, these are not suitable for plate failure and they are likely to fail. Watershed line, the volar radial cortex is concave and the limit to shift the plate distally is limited by this watershed line. So it is a transverse ridge located 2 millimeter from the joint line on the ulnar surface and 15 millimeters from the radial styloid process on the lateral side. So that is the watershed line, and these line restricts your plate. If you are going beyond that, probably you are encroaching the carpal ligaments which are attached just distal to that, and when you fix it, I'll come to that again. So that is the carpal ligament which are very close to the watershed line. Plate placement distal to the watershed line, the flexor tendons will be irritated. If your plate is distal to that line, the plate will be irritated. It will give rise to attrition ruptures, and out of all the flexors, it is the flexor pollicis longus which is very closest, and that is very often is irritated and comes to attrition rupture. Second, if your screws are out of the locking holes, if they are not flush to the plate, they may also irritate the tendon. So all the screws, they have to be flushed inside. They should not be protruding out. So here is your flexor tendons. Now you can see the difference between the two X-rays. On the right, the plate is too distal, and on the left is the one which is ideally placed. So if your
tip of the or the end of the plate will not come in close contact with the tendon. In the MRI, you can see how close is the tendon to the volar rim. So that is the reason your plate should not end distally. The complications which are related to flexor tendons is additionally, if you have inadequate reduction with the increased dorsal angulation, may place a strain on the flexor tendon, predisposing them to irritation or rupture. So if your reduction of the distal fracture, you are putting an anatomical plate, the distal locking plate is an anatomical plate, and if your reduction is not anatomical, the plate, or say for example there is some shortening, the plate will protrude out. It will not lie in the anatomical position, and if you have not maintained the reduction, it will look something like this, which will compress the median nerve, the flexor tendons as well. So this can, even in a malreduced fracture, may present 4 to 68 months later. They may come with attrition rupture or a median nerve compression, but this is more common when you are using an old type of plate. The newer plate like this, they have the tip which is beveled, the newer plate, and the older plate, they had a blunt end. So that is why there was more, this complication was more common with the earlier plate. Another potential cause of flexor tendon problem is the back out of the screw. When the screws are not properly locked or the screw loosen, and it is seen in about 12% of the patient at a mean of about 10 months. So lock them properly. If it is rotating, don't use that screw. Use it somewhere else in the distal row. Pronator quadratus, what is the importance? Now, if you have taken a flexor, if you have taken an FCR approach, flexor carpi radialis approach, you are elevating the pronator quadratus by taking an incision on the radial side and elevating it. So if your plate is covered by the pronator quadratus muscle, it will help you in avoiding the irritation of the plate and the screw to the tendon. So muscle will be in contact with the plate, not the tendon directly to the plate. It is, the other important thing is it is a dynamic stabilizer of the distal radio ulnar joint. Theoretical risk is if you tighten it tightly, if you suture it tightly, it may give rise to ischemic necrosis, by which there may be a deformity wherein patient has a pronation and he is not able to supinate the wrist properly. Recommendation is close the pronator quadratus, don't leave it open over the plate, but your closure should not be excessively tight. So that is the pronator quadratus, which lies in a transverse section like this, and your plate should be underneath that. Now, the second most complication is the EPL rupture of the extensor pollicis longus, and that is because of the long screws which are used. Now, whenever you are using a drill bit, don't penetrate the par cortex, don't penetrate the dorsal cortex, remain short so that the drill doesn't damage the EPL or the extensor tendon, and there is no need to have a bicortical screw if you are using a locking plate, and always take this view wherein you completely flex the wrist and then take a shoot where you can see the penetration of the screw dorsally before you close. So otherwise you replace the longer screws. Precise drilling and checking the adequate screw length is critical to avoid EPL injuries. The recommendations, as I discussed, is don't drill the dorsal cortex, use unicortical screw, and the newer plate, which Sanpure also described, which has pegs. They can be, there's no need to have threads because the mechanism is different. It's the angle stable construct where locking distally is enough. There is no need to have threads in the metaphysis. And whatever you have measured, another tip, whatever you have measured on a depth gauge, use only the 75% of the length. So there is no chance that you will penetrate the far cortex. But at the same time, your screw should not be less than 50% length. Otherwise, the construct will be poor. It will lead to failure. Reduction. The volar cortex adds structural support whenever it is properly reduced. So your reduction is a key which supports the construct of the fixation. When reduction is not anatomic, peg or screw placement will not correspond with the intended position in the subchondral bone of the distal radius. So this can lead to either soft tissue problem or loss of fixation. Key is adequate exposure. I have FCR approach video. If you want, I can show them at the end. Release the first extensor compartment as well as the insertion of brachioradialis on the radial styloid allows the greater visibility of the dorsal aspect of the fracture site. In some situation where you're not getting a reduction, where the styloid process is hindering, you can do a tenotomy of the brachioradialis. The same incision, if you take it, extend it longer, the FCR approach, you can retract the flap on the lateral side, release the dorsal compartment, first dorsal compartment, and you have a vision of the brachioradialis. So you can do a tenotomy so that the distal radial styloid process can be manipulated. The loss of reduction is either because of the dorsal collapse, loss of radial length, or loss of reduction. Very important, whenever you are taking a wrist views, either preoperative X-rays or shoot in the theater, always do it in this position where you angle your wrist to about 30 degrees in AP and lateral view so that you get a view wherein you can see the lunate, the scaphoid and the articular surface and the joint space, and how far are your screws, how far is your plate. And similarly, if you take this view, you can see the articular surface very well, and you can know whether your reduction is proper, your length of the screws are proper, can be known. Dorsal collapse is basically because of the excessive dorsal tilt. I'll run through that. Second is loss of reduction because of the lunate fossa. Now, this is the lunate fossa fracture. It can involve the volar side, it can involve the dorsal side. Normal volar plate does not capture adequately this lunar fragment. So you need either a second plate or some additional fixation whenever you are addressing that fragment. Otherwise, you will end up in a displacement or in a complication like this. Lastly, the carpal tunnel syndrome. It is trauma related, median nerve symptoms, or those who have pre-existing CTS. It is strongly recommended that you do a carpal tunnel release whenever you are doing a FCR approach. You have to just extend it distally and release it. Palmar flexion of the wrist during distal ulnar screw fixation may lead to reduced median nerve injury during open reduction and volar. Excessive traction of the median nerve is one of the cause which can give rise to a carpal tunnel syndrome. The palmar cutaneous nerve branch of the median nerve during the surgical exposure may also be wrist, and the superficial radial nerve, particularly on the lateral side whenever you're doing a pinning for distal radius. Treatment. It's difficult to treat. Early detection, strict elevation, early digital mobilization, effective pain control, vitamin C, antioxidant, anti-inflammatory have been tried. Some of the plastic surgeons, they also use anti-allergic treatment, Sexine or all those things, and they believe that this is probably in response to an autoimmune syndrome, wherein some patients get excessive pain response and carpal tunnel syndrome. Other set of patients where everything is all right, they don't have. Some of them where X-ray looks good, you are happy, but they have a carpal tunnel. They have the this syndrome. So in them, you can try out
it works for them, that is what they convey. So the indication you must follow, and dorsal fixation I'll skip. To avoid complications and to do a proper technique, adequate exposure is a must. Unicortical drilling, as we discussed, avoid excessive traction of the nerves, closure of the pronator quadratus over the plate, ensure a proper hardware positioning, as we have discussed, will avoid complications, and you will follow the principle. Thank you very much.
When to, hello, Sandeep sir, one question is there. With radial fracture, when we have to discontinue, when there is a fracture of ulnar styloid, when to neglect or when to fix it? Hello.
The question is, how do we address the ulnar styloid process?
When to fix it or
so after you complete the radial fixation, you can pronate and do a ballotment of the distal ulnar.
to fix it. For fix it.
So when the
whether it is necessary to fix it, ulnar styloid or not.
So if there is a ballotment, there is no fracture. Probably there is a TFCC injury and you have to repair it or fix it. If there is an ulnar styloid fracture, if there is a lunate fossa fracture, probably then you have to address either of them. Am I clear?
ऑडियो चिके वाला ते याला फुल लावले का आम्हाला फुल लाव हेडलाईन चं उघडा बोला फुल लावले हे आहे बरोबर
Hello. There is one question for Dr. Shivshankar sir.
त्या लॅपटॉप मधून आउटपुट येणार गेला दुसरा घ्यायला
Sir, as you told us about the external fixation for distal and medius fracture, is there any your criteria? Because external fixation works on ligamentotaxis purely. So, is there any criteria or time duration after which it should not be used, like 2 weeks or 3 weeks, and after that ligamentotaxis won't work, so you don't do that? Is there any your criteria?
No. See, two cases where I showed, the last case where I showed 2 months old injury.
Yes.
So even at 2 months also you can try, but it's an additional just picture you have to use it, because you cannot get the reduction on table. You should have a distraction mechanism. I use a simple distractor, distract it. Once you get the length, then we can use it.
And sir, one more question: have you used it for arthrodesis?
No.
Dear friends, after listening Dr. Ashok Kodke, Dr. Santapure, Dr. B. Shankar and Dr. Gawal, you are little bit confused what to do and what not to do. लेकिन कंफ्यूज होने की कोई जरूरत नहीं है, जिससे आपको अच्छे रिजल्ट आते वो करते जाओ। कभी प्लास्टर लगाओ, कभी केवाई डालो, कभी लगा तो पैसे वाला पेशेंट आता प्लेट भी लगाओ, कोई प्रॉब्लम नहीं। इसलिए मैं एक नई मेथड बता रहा हूँ, जस्ट देखो, पसंद आए तो करो, नहीं तो मत करो। इट्स नॉट जबरदस्ती कुछ भी नहीं। So this is majority of these fractures, although initially reducible by manipulation, may be inherently unstable. In 50% will collapse with simple cross immobilization. In practical observation, so many non-united fractures, functionally they are very good, and we are observed in our clinical practice also. But we are all orthopedic surgeons and we require some work. Therefore, some industry people, and plating is one of the most lucrative surgical intervention. Therefore, we have to learn from the experts like Dr. Gawale sir, Santapure and Dr. Kodke and Simpson. So I am a lesser known expert surgeon. Therefore, I do something different. There is a direct correlation between the functional results and residual deformity. Therefore, trend has shifted towards restoring articular congruence and bony anatomy by internal fixation. Percutaneous spinning is a simple method and it gives good result in majority of the patients. Complications, soft tissue irritation, injury to the radial injury and extension tendons, pain, oligodystrophia, pin tract infection, loss of reduction and loosening of the before the fracture is tonight. Fixation by plate to address distal radius fracture. Fragment specific fixation of lower end fracture by plate is the recent trend by Bowler or dorsal approach or a combined approach, and some of the people they use not only 1, 2 or 3 plates, सामने भी लगाओ, पीछे भी लगाओ और साइड से भी लगाओ. Direct visualization and reduction of fracture, stable fixation and early motion and better function is their propaganda. But look at this picture. The Orthopaedic 2016 randomized controlled trial showed complication rate is 16 to 25% in a scar environment, not in our Kallu Dabru Pattu operation techniques. Evidence-based medicine 2018 article. AOS guideline failed to find evidence to form conclusive recommendation for or against any treatment. Although popularity of polar locking plate fixation continues to grow, there are limited high-powered quality studies to prove its superiority over other methods of treatment. And one of my friends from Ulhasnagar, he is doing a close reduction of all types of lower end radius fractures with excellent result. Dr. Mahapatra. Position of average orthopedic surgeon is like Abhimanyu in a chakra view where you choose a plate and perform a fragment specific fixation, and this is our position. Therefore, we have to attend the seminar like this here, how to apply a plate and what is to choose between among the plate. क्योंकि स्क्रू में कोई कहीं का 4.5, 3.5, 2.7, किसी का 2.5। अब स्क्रू कसते कसते वो टकला हो जाता है। इट इज वेरी डिफिकल्ट, वो ना जाता अंदर ना बाहर निकलता। इट इज अ वेरी डिफिकल्ट सिचुएशन। तो ये प्रॉब्लम्स में तो सभी को आते हैं, और our patients are not affording a 48,000 rupees lower radius multi-lock titanium plate with a specific. So this has profound economic implication to results quoted are good in star surgical environment, but treatment should be affordable, available and accessible. महात्मा ज्योतिबा फुले योजना 18,000 सर्वच काय. आता साला कसं प्लेट लावायचं तुम्हीच सांगा. And in a lower radius fracture, the quotation is only 13,000 rupees. त्याच्यात काय कसं करायचं तुम्हीच सांगा. So a new concept in the treatment of a lower end radius fracture with antegrade intramedullary nail, correct deformity, realign normal osseous anatomy by ligamental taxis, preserve hand and wrist function. And my indication: surgically compromised environment, compromised local condition, poor socio-economic condition, inadequate surgical expertise. And to tell you very frankly, I am not against plating. That is very clear to you all, because I also do when I get an affordable patient. Okay, the lower end radius fracture does not bear weight. Lakshat gya. Several studies have shown that some irregularities at the lower end radius are well tolerated. मतलब सर्वत पहले तो सब कोई भी लोअर एंड रेडियस में तुम सर्जरी बताओ, 2-3 महीने के बाद ठीक है साहब आप जाओ जाओ ठीक है. And this is the CT does not give exact picture for planning, but always not amenable to finding. CT gives exact picture, not amenable to my patient. क्योंकि 5,000 रुपए CT को लगते हैं, वो CT करने को गया ना तो उधर के उधर ही निकल जाता बाबा चलो. 5,000 में तो साला पट्टी बांध दो. CR images are misleading, but barely helps in performing my surgery. So philosophy of my fixation is support the subchondral bone of the distal fragment by antegrade intramedullary laboratory or KYS till fracture union. After routine sterilization, traction, manipulation, KYR fixation, and then you can pass a 2 centimeter longitudinal skin incision was made on the dorsal-radial aspect of the mid-radius about 8 to 9 centimeter, proximal to the radial skylight. The interval between the extensor carpi radial is brevis and extensor digitorum communis, proximal to the abductor pollicis longus. It is very confusion, but you see it's a bare area. You just see here. Yes, you just go here. That's all. Okay. So it is complicated. So then if you have one slanting hole, 2 centimeter incision, deliberate in a large size bone, provided that diameter of the hole is less than half of the width of the bone at the level of. So you use a 2.5 mm drill bit, and then what happens? You just pass your one laboratory wire from that hole up to 2 mm or 1.8 mm, 40 to 40 degree care to avoid penetration into the far cortex. And you can see here how that wire is going to the radial side, pass another wire to the ulnar side. If a DRUC joint is dislocated or subluxated, you can reduce and pass a ulno-radial subchondral wire. And in that also can be, say, a wrap wire, pass 1, 2 wires, 3 wires. If osteoporotic, you can use 4 wires, but not to the single hole, but at least 2 holes. From 2 holes, near about 5 mm away from each other. And then what you do, you can say summary of procedure: distraction, K-wire fixation, passing a wire subchondral, blunt end, not the, they are blunt wires. And you can see here how the articular surface is and closure of the wound. If there is some comminution, then give augmentation by unilateral external fixator, simple 4 weeks, radiological evaluation, 3 weeks immobilization, and these are all examples. I will go through it very quickly. This article is available on PubMed. 18-month follow-up. Wonderfully restoration of articles. Some of the parameters are lacking, but functionally it's all right. Another example, multiple wires, 6 weeks follow-up. Another example, a plaster was applied, so antegrade wire bypassing this, and ultimately you can see here how there is a restoration of the anatomy. Another example, a displaced fracture, antegrade wires, perfect anatomical restoration. Another example, so there are innumerable examples I can quote, and you can see this is a complex fracture where you cannot treat this fracture by even locking plates also of a very different kind of fracture, because it is a totally circumferential fracture, anterior posterior rib fracture. So even a plate cannot hold it. Ligamentary taxis, external fixation, K-wire fixation, and you can see a 2 years follow-up. Another lunate fracture, most important to reduce and fix it, difficult to fix by screw also, and you can see how indirect elevation. So this method I have published it is in PubMed now, 2021 November. This is the article in the Malaysian journal. It is in the PubMed. You can go to it. I did near about 50 patients, and there are some of the complications. That does not mean that this is one of the best method. No, it is one of the method in the arena of lower and radius fractures. And take out myself. The choice of treatment is yours in consultation with the patient and with the economic consideration. Don't force a poor patient to buy a plate of 45,000 rupees unnecessarily in the pretext of doing something very good to the patient. With transfer of limitation data available, relying on the surgeon's experience and patient preference, I think lower and radius should be treated not with the book picture, but with the consultation and available expertise with that particular surgeon. Thank you very much.
Thank you, sir. Now I call Dr. Modwani sir to give us lecture on fracture calculation approaches. I would love to call moderator Dr. Bhandari sir, Kagni sir, and Piker. Post lunch 10 lectures. I request everyone to please stand up, move your body, stretch your body, and then sit up.
Section लैपटॉप वो एक आगे फिर स्लाइड्स में चालू कर चालू है फोल्डर नहीं मिल रहा था डायरेक्ट डेस्कटॉप चालू करना बैक करने के स्लिप दबा दी तो बैक हो जाता है डेस्कटॉप दबा नहीं ना सर ये लो बाहर बाटा जी
Good evening again. So now I am demonstrating. It's not a lecture; it's a video demonstration of the sinus tarsi approach to the calcaneum. As such, we know that there are two approaches to the calcaneum. One is lateral extensile. We everyone are aware about the lateral extensile approach, but this is a unique sinus tarsi approach which I will demonstrate first. And if time permits, there is another video for the lateral extensile approach also. It's a pre-recorded actually video, but here I will not running the voice. Most burning issues in the calcaneum, we are all aware that it is the wound complications. So lateral extensile approach, they have been used very frequently, but it is not uncommon that the risk of the wound complications reported in the literature is up to 40%. Also, you cannot use it in the diabetic, uncontrolled sugar patients and PVD and the swelling patients. There are many methods to manipulate the K-wire by K-wire, but is it actually working? No. Percutaneous procedure without opening the joint, you cannot get a good reduction. So what is the problem? Loss of height, loss of calcaneal width, varus valgus malunion, subtalar arthritis, and lot many other problems related to the calcaneal fracture malunion. So this is a patient 35-year-old having a preoperative X-ray showing good amount of the varus, joint depression, polar angle is almost negative. You can see that the joint is posterior facet is almost completely depressed. This is a post-operative soft tissue assessment. In the sinus tarsi, you can operate on day 1, provided there should not be ecchymosis or the blister on the lateral aspect of the foot. You don't have to wait for 2 to 3 weeks if your approach selection is perfect. So keeping the patient in the lateral position, same like the lateral extensile approach, keep the pillow under the ankle so that you get some of the counter while putting a screw. Simply, this was a video made in the rural place. So this is a tourniquet applied, patient in the lateral position. Now, what are the surfaces we need to mark for the sinus tarsi approach? You can discharge the patient on day 1 if you are going absolutely right and it's a minimal invasive approach. So this is a C-arm position which is very important. So you have to move the C-arm in one direction only, AP and lateral in one direction so that you get an axial view. Look at here, I am moving a C-arm in only one direction and I am getting a lateral view, I am getting a axial view. These are the two views which are important when you are operating any calcaneal fracture through any approach. So after clean painting and the draping, this is how you need to mark the position. Mark the distal fibula and mark the base of 4th metatarsal, not 5th, 4th. And this is a line of the sinus tarsi. You have to take 4 to 5 centimeter of the incision directly deep up to the deep fascia. You can find the extensor digitorum brevis as a sharp red muscle. Stop to that level. There is no way to get a sural in this approach. So here I am going directly deep up to the extensor digitorum brevis. Don't separate the skin, subcutaneous tissue, deep tissue. Make sure there is no nerve. You are anterior to the peroneal tendon. Gentle retraction. This is not a watershed area. This is an area where the blood circulation is good. The chances of the wound complications are less. There is no way that the lateral calcaneal artery comes on the way. Very safer approach. Now just avoid in this thing, just avoid the injury to the peroneal tendon. So while cutting and going deep to the sinus tarsi, don't go very deep so that you cannot even identify the peroneal tendon and you are directly injuring it. When you get a fat, when you get a fat globules, when you get a fat globules around the sinus tarsi, it means you are in the right place. So if you see after separating the skin subcutaneous tissue, if you find that there is some fat, it means you are in the right place. Directly go with the 15 number knife deep to the sinus tarsi. Now identify the calcaneofibular ligament. Very easy. Calcaneo to fibular. Very easy. One strout ligament which comes on the way, you need to cut that ligament. Because there are 3 sets of the lateral ankle ligaments. At the end, you can resuture it, or suppose if you are not resuturing it, no problem. It's the only ligament which you need to compromise. Minor bleeders can be cauterized. This is how I am cutting a calcaneofibular ligament. Moment you cut a calcaneofibular ligament, you get a bleeding or you get a hematoma coming out. So it means you are in the right place. This is the lateral process of the talus which is visible. The deep cut directly up to the capsule. You can easily identify that this is the sinus tarsi region because the posterior facet is depressed. So there is a lot of space in the sinus tarsi. When the talus and the calcaneum is properly articulated, there is no space. But when it is depressed, there is a good space. You can put an artery or any instrument to identify whether you are in the right place or not. Don't injure the articular cartilage. Now I am just separating the peroneal tendons. I am just keeping the peroneal tendon relatively free from the soft tissue. And this is the knife going to the peroneal sheath directly to the bone to get some space of the lateral wall. Deep wash, because usually we operate a calcaneum after 7 days, so there are collected bloods in the medial part. You're operating through the lateral part, you may not be able to see the medial part. So a lot of wash to see the sustentaculum. 1 K-wire to the talus, lateral process of the talus. Look at the retractor, which is safely retracting the peroneal tendon. The sural is much away from the peroneal tendon, so there is no way to injure it. And another wire, obliquely another wire is going into the calcaneum. Any part of the calcaneum on the lateral wall. Because but we just want to see by distraction to see the other part of the subtalar joint. This is a very important instrument, and I think the only instrument which is important apart from the general instrument when you are operating through this approach, it's called intermal retractor. It's a small joint distractor. So gentle retraction to the talus and the calcaneum so that you can see the medial part of the joint. This is how you can see the medial sustentacular part. Look at here, talus separating the calcaneum, and this is how you can see the medial part. It is a stable fragment through which you can assess my joint is reconstructible or not. That's what we discussed in the case. Look at the fracture. Now it is very clearly visible that there is a 3-part fracture, Sanders type 3 displaced. Look at here, you can easily identify this is my fracture line. If it is old, just put any blunt instrument, try to mobilize it. If it is not old, you can get easy movements of the fragment and you can elevate by many ways that I will show you later. So just take out all clots, identify the fracture, take out the intermittent retractor. If the retraction is done, no need to put a wire. Take out all wire retraction. This is how the mobilization of the fracture fragment is done. 1 K-wire to correct varus of the valgus. So suppose here in my case there is a varus, so I am putting posterior to anterior wire to control the tuberosity varus, only to the tuberosity, and give a valgus force. So just keep the K-wire up to that position, move it varus of the valgus, and now I am trying to elevate the posterior facet, which is the important part of this surgery. through any instrument, even the reverse scoop, you can elevate the posterior facet which is depressed inside the body. So this is how you elevate the posterior facet. Once you get a good elevation of the posterior facet, just transfix it to the talus. This is another instrument which you can use to maintain the elevation of the posterior facet. Now, if suppose after elevation of the posterior facet, if it's not stable, put a lamina spreader inside the subtalar fragment to the secondary fracture line and just elevate it until you pass a K-wire in the neutral position. This is how you elevate the posterior facet. See in the lateral view of the X-ray that whether this elevation is giving you the positive polar angle or not. For that, you need to get a good mobilizing peroneal tendon so that it should allow the retractors to go inside the fracture fragment. 2 K-wires after correcting the axial varus alignment. See in the axial view and the lateral view, positive polar angle, correction of the varus. 2 views are very important, and now it is important fixation of the lateral wall to the sustentaculum. So I always use a hand drill to avoid the injury. Most of the time we use a hand drill, and just we are going directly to the sustentacular fragment, lateral to the medial, oblique direction, not the transverse wire, because the subtalar joint is a C-shaped joint. So if you put a transverse wire, you may land up with the intra-articular pinning. Sustentacular screw fixation, very important part. This allows the subtalar joint facets to remain in the elevated position. Drilling of the tuberosity, fixation of the tuberosity with 1 cc screw, 6.5 mm, or you can use the headless screw also. And now after fixing everything, you need to see what is my lateral wall. If it is significantly blown out, comminuted, impinging the peroneal tendon, put a lower end radius T plate, 2.7 mm T plate or the L plate. Now we have a sinus tarsa plate also. This is a video of 2016 when the sinus tarsa plate was not available. But still I am using, in majority of the cases, I am using the lower end radius plate because it gives a fixation to the anterior facet also, which is also a part of the injury. So calcaneocuboidal joint reduction, fixation of the anterior column, middle column to the tuberosity, subperoneal plate application, and a locking plate application, locking screw application through the plate so that it should not hurt the peroneal tendons. Yeah. So this is how it looks. Tendons over the plate, sustentacular screw, and this is how it looks on the lateral, on the axial view. Correction of the valgus or varus, and in the closure, important that you should repair the EDB muscle so that the plate is not palpable, tendons are free and superficial, and the skin suturing, nothing. This is how we do the closure. You can discharge the patient on the second day. No need to apply the cast. Thank you. So fracture of the medial column is usually a salient feature of open injuries. Open calcaneal fracture, they are usually medially damaged, or it is medially open. Otherwise, like majority of our fractures, the medial part is usually, it's called a constant fragment. It's called a stable fragment because there is a strong set of the interosseous ligament which makes it stable with the talus. So if it is very, very small, comminuted, non-reconstructible, but make sure that it is not a open fracture.
Can I?
Yes, sir.
How to avoid injury in the posterior tibial artery by passing screw to the sustentacle callus? Injury to the artery or medial side.
The screw to the sustentacular falla is from lateral to medial, yeah, right? Yeah. So for that, you have to keep a direction of the guide wire, oblique guide wire. So this is in the axial view. It is very important to see the axial view while putting a sustentacular screw. Tip number 1. Tip number 2 is this is the subtalar joint. You have to put a wire from here to here. So confirm in the axial view that you are going to the sustentacular bone because it's a very solid fragment. Throughout the drilling, you get a feeling that no, I am inside the bone. And there is no way to injure the artery because the sustentacular has a good association, it has a close association with FHI tendon. So zyada se zyada it may hurt the FHI tendon. Arteries, they are in the tarsal tunnel, so no relation with the sustentacular.
Sir, thank you for such a brilliant demonstration of fracture calculum. Now I would like to call Dr. Ashok sir to show us the bouquet technique for fixation.
After an excellent video demonstration. This is basically a bouquet technique for boxer's fracture with metacarpal neck fracture. So this boxer's name itself is a misnomer. It is never seen in a professional boxers. So if you see the mechanism, a clenched empty joint strikes a solid object. So what is the problem? There is loss of metacarpal head, palpable metacarpal head in the palm depending on the displacement and rotation. So here we can see there is loss of prominence of the metacarpal head. So what is the solution? Each case doesn't require a surgery. So let us go into some anatomical fact. If you see the little finger, it is always short almost by one phalanx. But if we flex, all the fingertips come in the same position. So how does this happen? If we extend, it is shorter. When we flex, they come in the same position. So there is 30-degree extra motion at 4th and 5th carpometacarpal joint. This is utilized to compensate 30 to 70-degree flexion at the metacarpal head. Now, how is it useful? Anatomical fact, relatively high degree of motion is seen at the 5th carpometacarpal joint. Can tolerate a marked angulation in the AP plane. So, several authors have reported functional results can be achieved with little or no correction of these fractures in AP plane. This is the X-ray view what we asked for this metacarpal, so we can see it in a better way. Treatment, either it is conservative or surgical. Conservative, manipulation, flexed fracture is relocated, rotated fracture is derotated. So this is the JAS manual, which is not done nowadays. So we give pressure on the metacarpal head to reduce it. So in this way, in a flexed PIP joint, we reduce the fracture. A JAS, the problems are there are pressure source, then PIPJ flexion contracture and recurrence of deformity. That's why we don't do it. A comparison of two methods of immobilization of fifth metacarpal. So this is the first method where we give an extension cast with 3-point mold and there is an outrigger splint. So these are all conservative treatment and comparison has showed there is no difference. So we can do whichever way we want. Does close reduction work? The effect of close reduction on fracture. So there is an ultimate angular deformity. After 3 weeks, almost total collapse. So choice, close method preferred, percute or open reduction internal fixation. Then these are various surgical methods which are being described. We pass K wires, 2 parallel K wires, then cross K wires across the fracture site. Then there is something called internal body where we pass 2 K wires through the metacarpal head. But here we can get some impalement of the interosseous muscle. Plate, again very invasive. This is that Faucher's bouquet technique where we pass multiple K wires as a bouquet type into the metacarpal head. So this is a patient where he's a ENT surgeon and he had this boxer's fracture. So we see for this angle. So if it is more than 70 degrees, we should operate. If it is less than 70 degrees, we can conserve. So this ENT surgeon, he's a microsurgeon. So he rests his hand on the table while doing the surgery, and he was very much interested in getting this operated. So a procedure for bouquet pinning, we take 0.8 millimeter K wires, multiple K wires, we bend it in this fashion and we turn it like what we do in pencil. It works on the principle of 3-point fixation. So again, very less inventory, and we make an entry point and through that we pass this wire. So we take multiple shoots and see if the wire are inside and how is the reduction of the fifth metacarpal. So this is an intra-op video showing all the 3 wires inside the fifth metacarpal, and see now all the 3 wires are fanning out into the metacarpal and it does reduce the fracture. So this is what is seen. We just take a single stitch. So what are the absolute indications? If the angulation is more than 70 degrees for the fifth metacarpal head, we should undertake surgery. If there is rotation, if there is fracture of the fifth ray, open fracture and pseudo-plot. These are some examples. Now this is a fracture where we undertook a conservative treatment because the angle was almost 50 degrees. So we just applied a outrigger splint and it was nicely healed. So this is the patient. And this is the X-ray after doing conservative treatment. So we should discuss with the patient. If conserve, they might get some head, loss of head of the metacarpal. If surgery, they might land up in MP stiffness, but with bouquet pinning, there is no any question of getting any stiffness because we immediately ask them to mobilize. So 30 to 70 degree angulation is acceptable, may lose prominence of metacarpal head, conservative preferred, avoid scissoring and close reduction, loss. Summary, again, mostly conserve up to 70 degrees. Speak with the patient about the pros and cons. Even we are now doing this technique for the metacarpal, for the phalanx, where we make an entry point and pass multiple small K wires intramedullary. Thank you. There is a question, do we put a slab? Yes, we put a slab at least for 2 to 3 weeks, but then we put a dorsal slab and ask for mobilization. So any hand fractures, our first intention is how to get a good functional hand and wrist. And the immobilization should be such that they can have a good finger movement at the metacarpophalangeal.
In this case, we usually use a block, no local anesthesia.
Thank you, sir. Now I would like to call Dr. Shivashankar sir to show us a keyhole surgery humerus fracture. I think most of us are waiting for this lecture. I call Dr. Shivashankar sir.
Good evening, all the brave warriors still sitting in the hall. I'll be talking about the humeral interlocking healing by keyhole surgery. Here is a case of distal fracture of the humerus treated with the nailing. It's sometime in the late 90s or early 2000. At 6 weeks, you can see good callus and full function. Another case, an advocate when in Mumbai came back to Solapur to get operated. See the incision, just a small incision. I have never changed this incision in the last 30 years. 96, I was using this incision. Today also, I'm using the same incision. So again, you can see after the fracture is united, you hardly can see the incision. I have removed the implants also, full function. So don't blame that nail will cause stiffness in the shoulder. Again, abrasion and huge bruising, again treated in the proximal third fracture with the nailing in 2005. I admit that all the patients are advised to do passive mobilization using the opposite hand immediately. And usually by about 10 days time, they'll be able to do active abduction. This is after 2 years when he came for implant removal, full function work. There is no restriction whatsoever, and this is the end result. You had your own, one of your senior person, Dr. Lavekar. I don't know when we came. Chennai sir should be able to remember. I think 2003 or 2004. One of his hand has been operated by me in the hospital, and he has got a good function. And if you are really doubting whether such a small keyhole surgery can be done, ask him to show the incisions. So this is nowadays I use 2 screws proximally and 2 screws distally, and this is a humeral shaft fracture again treated in similar fashion after the implants have removed. After the fracture consolidated, implants have been removed. Can you make the incision? So this is when the patient came for implant removal. So this is after a month after the implant removal. The whole video of about 40 minutes is available on YouTube. You can search for Dr. Shivashankar and you will get them. This is an interesting case. Recently, there is a system available where you can compress the fracture also in the humerus vein with a bolt. In this case, I used that there was a bad fracture, son of a veterinary surgeon, and he came with this bad fracture after a week's time. And this is, you can see, this is the condition of the skin. So there is no question of doing any open plating or anything. So what I did was I wrapped the whole arm with a sterile dressing material. The incision was taken by a keyhole incision. You can see I passed the guide wire first. Over the guide wire, I pass a cannulated drill bit, take out that, and then I pass a guide wire through that. So the reaming is done. I almost always do the reaming. So only till about in the late 90s, I was not doing the non-ream nailing, but since early 2000, I always ream them. And I had to use this was a solid nail. So I have done the distal locking first. Then there is a system in the proximal end. You pass the dynamic bolt there and press the instrument from the top of the nail so that the screw will be pushed down so that the fracture will get compacted. Then you do the static locking. Once you do the static locking, you can remove the bent bolt and you can insert a regular straight bolt at that side. So this is what I have done. You can see that whatever the bad wound was there, abrasion area, I have totally kept out of my all incision area. And this is immediate post-operative picture of the same patient. This is when the patient on third day clinical picture. Then You can see the small incisions to put the nail, and at 3 months he had some pain. The fracture, you can see there is some delayed signs of union. At 3 months he had some a gap was seen, as you can see in the lateral picture. I advised him bone marrow injection at that time because he also had some pain, but unfortunately he came after 1 month. So he came after 1 month. At 4 months I did the bone marrow. It's a platelet plasma. It's not the patient's own blood. It's from the blood bank. I just sent a requisition. I want A group platelet plasma. They give 50 ml of fresh frozen plasma, which we inject at the fracture site under CR control. When he came after 1 month in December, the pain had totally gone, and at 6 months you can see the fracture totally healed without any problem, fully consolidated. At 1 year, total union, no problem. I have done the removal of the implant also, and the patient, this is a clinical picture a month after the implant was removed. So I can make a bold statement that I have been a nailer ever since beginning. Before nail was, humeral nail was available, I was using retrograde locking, retrograde laminating wires, and I used to do the nailing. Even extreme humeral fractures, I do nailing. I do use anterior bridge plate in 2 cases. I was influenced by Sergio to do them, and I have done good number of cases also. Conservative treatment plays a good role, and during the pandemic, I have treated few of the cases with the functional cast bracing. The problem of the interlocking is there are not much articles have appeared, and everybody talks about the complications. There are so many complications, especially the shoulder problem, nerve palsy, shoulder infection, adhesive capsulitis, non, etc. So I am not talking about anything bad about the plating or anything. How I do good surgery? Always, almost nowadays, I pass a joystick in the proximal humeral head. So advantage you will see, instead of rotating the arm by the assistant, I can rotate the K-wire in this fashion and take AP and lateral picture of the entry side, because my entry should be in line with the middle canal. So that has to be properly rotated to get a beautiful picture. So here I am using 1.8 millimeter guide wire, which is passed at the junction of articular and non-articular portion in the center of the middle canal. Again, you can see 90-degree lateral view picture is taken, and that will give me exactly, because if the patient assistant rotates it, it may not be a 90-degree rotation, it will be 60-degree rotation. You will have a misleading picture. So here you can see 90-degree to one another, beautiful pictures, and you can, once your guide wire is proper, take a 8 millimeter small incision in line with the fibers of the deltoid. So you are not cutting any of the deltoid, you are only splitting, and enlarge that with a small hemostat artery forceps. Then you pass a 4 millimeter cannulated reamer, which comes with a 6.5 millimeter CC screw. Again, I am not using any powered instrument because I am only using to and fro motion. I don't want the soft tissue to get entangled. So I am passing over the guide wire. Now I will remove the guide wire, and after removing the guide wire, I will pass a reaming guide wire, 2.5 millimeter long guide wire, which is used for, yeah, I am passing that guide wire, and assistant gives just gentle traction. I can manipulate the joystick, the drill bit, I can flex, extend and reduce the fracture under C-arm, and I just pass the guide wire across into the distal fragment. Once the guide wire goes across into the distal fragment, then there is no problem. We can confirm under C-arm, and I normally hammer it with the suprapatellar region so that it won't come out in between during the reaming purpose. Then again, I enlarge the entry with a 8 millimeter cannulated entry point maker, which comes with a set. Again, 90-degree to and fro motion only, no full reaming. And when I start reaming with a flexible reamer, I start with 5, 5.5, 6, 6.5, 7, 7.5, 8, 8.5. You can see that my assistant stretches the skin on either side so that the soft tissue will not come in the way. So burning of the skin or surrounding tissue which will cause necrosis can be prevented. I always ream, as I said, so that I know the size of the canal, so that the proper size nail can be passed. I normally ream 5 millimeter more. I normally use 8 millimeter nail, so I use a 8.5 millimeter reaming. Again, the whole YouTube is available on the site. Some of the important things: C-arm should not come in your way. You should have a free access from the head end. Then don't open to make an entry. Always use a keyhole. First pass the guide wire, confirm that they are properly positioned. Then pass a cannulated drill bit over that. Then pass a guide wire. Then this is what I have already said. Enlarge the entry with 8 millimeter reamer. It comes. Gentle traction by the assistant. Small pillow underneath the elbow, so that the distal part is elevated. Normally, we keep a small pillow in the under the shoulder, so the shoulder is elevated. So small tape is required, and then gentle manipulation, and then don't use the F tool. It is good for femur, but not for humerus. So pass the wire gently. Reaming control should be in your hand. Don't ream across the fracture side. So this is very, very important. Then when you're passing the nail, always give a constant watch. You can see right down, the fracture has got distracted. The reason is, if you see the humerus is slightly curved anteriorly. Our flexible reamer gets bent and goes anteriorly, but our nail is straight. When the nail is passed, sometimes it gets distracted. So always keep a watch, and you have to use a thinner size nail or ream again extra. Here in this case, I used a thinner size nail. Again, see the reduction when you are passing the nail at the fracture side. Many a time there will be varus valgus mal-alignment, and unnecessary you will struggle afterwards. So here I have lost iatrogenic fracture because I didn't look at the X-ray properly at that time. Also, your entry should be in the center, both in AP and lateral picture. Here I have used a slightly, as you can see on the right side, a eccentric entry. Though I could ream it, when on the left you can see my reamer went, but when I pass the nail, iatrogenic fracture of the medial fragment has happened. So your entry should be in line with the medullary canal. Then use the C-arm judiciously. If you use that X-ray tube below the table and take it near to the table, automatically the hole gets zoom. You need not have to use any zoom pictures. So automatically you can make the hole larger in size and you can drill. Use a sharp K-wire and make a dent in the anterior cortex. Exactly, take it in under the C-arm in the center, then make a dent with using a hammer. Once a dent is done, you can drill it with hand. Otherwise, what happens is the guide wire or the drill bit keeps slipping. So then you can use a awl to drill the anterior cortex, but don't drill with this the posterior cortex, otherwise the posterior cortex gets shattered. So only drill for the anterior cortex. Then use a small wire over your screw so that it won't get lost in the distal hole. Always compact the fracture. Do the distal locking, extract the nail first before you do the proximal locking. Compression has to be done properly in this fashion. So that is very, very important before you do. So you can see that distracted fragment can be compressed. Humerus does not tolerate any distraction. So you have to see that your fracture is compacted beautifully at the end of your procedure. And you also should know that the end of the nail should be subchondrally buried. Nowadays, I apply little bone wax over the nail so that bone will not grow inside. So that when I am doing the removal, it becomes easy to attach my extraction board. Otherwise, the bone grows inside and many times the attachment is difficult. Shoulder problems are mainly due to nail which is too long. So always start the mobilization as soon as you do the surgery. Patient should be able to do in the immediate post-operative period, initially assisted, and by the end of 1 week, he should be able to do on his own active abduction. Regarding radial nerve palsy, operatively existing, it's usually neuropraxia. You don't have to explore it. Nailing can be done. Only thing is inform the patient that I will do MNCV studies, nerve conduction test at around 6 weeks time, then I will take a call. I had in my life about 15 cases of radial nerve palsy patients coming to me. All have done the nailing. Unfortunately or fortunately, no one had any problem. All of them recovered within 3 months time. So this was one of the such cases, segmental fracture. with radial nerve palsy. You can see I am using the splint in the immediate post-operative period. She also required. Many ladies sit on the scooter. The sari pallu gets entangled to the wheel, and I get at least one patient every year with an abrasion like this, and I have been treating all of them with this same technique. So, friends, humerus fracture doesn't tolerate any gap, especially transverse fractures. This is Dr. Poddar from Latur. He had this humerus fracture which I had done the nailing. I was not doing distal locking in the early 2000. At that time, I treated him, and you can see there was gap. For 2 years, there was gap. But he was doing even reaming, hand reaming with the same hand. After 10 years, after repeatedly asking him, he finally sent me an X-ray where you can see that the humeral fracture has united. So this is same Dr. Ashok Poddar. We have Dr. Lavekar has come. Which hand, sir? Right hand. So you can see his abducting his right hand completely. He has been treated in a similar fashion. So some cases do have non-union. In such cases, I have used just a ring above and a ring below, and I have compressed the fracture. I remove the locking and compress it above and below, and they have done beautifully well. Friends, plating complication is 4%, nailing is 7%. Unfortunately, what happens is with the plate phase, it's like a heart attack. Patient goes to anybody, sells the house and get the surgery done. But if the nail phase, it's like a ONE. He keeps on going to everybody. He goes to Dr. Patni, he will go to Navekar, Dr. Chichani, Dr. Paliwal, Dr. Chavan, everybody goes. So we think that the number of cases of failure with nailing is too much. It's not like that. They postpone the surgery, that's why, because they are not incapacitated. With a nail inside with non-union, they are working. But a nail, if a plate breaks, they have to get it done. Whosoever is the person who they approach, they will get the surgery done. So don't worry too much. You can get all the things done properly. This is the last case I will show, though there are many more slides, I will end here. So this was a improperly treated cases. 2 surgeries were done, and after the locking failed, I treated this with a nail with an augmentation plate and bone grafting. This is a sister of a local MLA high pressure case, and it consolidated without any problem. Thank you very much.
Sir, in failure of plate, do you prefer nailing?
Yeah, earlier I used to nail when a plate fails and plate when a nail fails. But nowadays I know that a non-union requires absolute stability. So that can be given only by a plate. So if I use a nail, I put a plate. That's the reason why I showed the last case where I put a small plate. Because if you depend upon the interlocking which is away, there is still some torsional rotations which cannot be controlled. Non-union requires absolute stability. So nail with plate augmentation is a beautiful thing which nowadays I am following.
Let's call Dr. Rodke sir to show us PIP injuries and the management regarding.
After listening to Shiva sir, we feel that every humerus should be nailed. I would like to ask Shiva sir, what is your opinion about putting cast extension of elbow in conservative treatment for humerus?
Yes, that is, I think, nowadays because everybody is talking, and too many papers also have come in the last 1 year since the lockdown. Many have tried, and it really works well, because if you put a cast in flexion, there is angulation which happens. If you put it in extension, then properly the neutralization of the forces happens both anterior and posterior. The muscles are stretched, and the reduction happens in due course of time on its own, and then not a heavy cast is also required. Lightweight cast also, just with 1 or 2 layers of fiber cast you can apply them, and they do very well. Because though I have not tried them, I have tried one patient, but the patient has not come for follow-up. But I have seen the results since I'm in so many WhatsApp groups, I keep seeing every day 1 or 2 cases treated somewhere in the world, and they are doing beautifully.
So moving on to another small joint, EIP joint. So if this fracture dislocations, if they are not treated in a correct way, they are really very forgiving because they don't have much of movement, and those are painful moments. So a PIP joint injury. So the patient comes with an injury or swelling, tender, EIPJ, reduced range of motion. So we should not have a very casual approach, like it's nothing and everywhere. We should not go for a body strapping. This is an usual X-ray which has been ordered, an AP and a lateral or an oblique, wherein we usually miss the PIP joint injury. So here we can see a AP, oblique, and so this lateral, that too a magnified lateral, is important to diagnose PIP joint injury. So classification, volar lip fracture dislocation, most common. You can even get a dorsal lip fracture and a pilon fracture. So this is a classification where if the bone involved is less than 30, it is a stable, 30 to 60 is tenuous, and more than 50 or 60 is an unstable joint. Treatment options, so many types of treatments available, like from extension block, pinning, splinting to hamate arthroplasty. So the one which is given in red, that is what I prefer. We'll just go one by one. What is it? Extension block, splinting, or a pinning. So if the fracture involved is less than 30 degrees, it gets very well reduced with an extension block splinting. That's something like this. So what we allow further flexion, but we don't allow extension. So in extension, it is getting displaced or subluxed. Later on, we apply such kind of splint where the extension is slightly increased. This is an extension block pinning. So we pass a K-wire through the joint, and but this again there is a problem with the extensor digitorum tendon. Transfixation. So we can see there is a V sign, and also there is a mallet, and here we have done a joint transfixation wire. Again, not a very good modality because we are not sure about the movements, how they. This is fourth type where we do a close reduction in internal fixation. We pass a K wire. Again, problem with the extensor digitorum tendon. So this is passing a K wire, close reduction, internal fixation. There is something called open reduction, internal fixation. Here, we open on the volar side. So if this is the fracture, we open on the volar side, we pass through screws. This is a dynamic traction external fixation. So Suzuki frame. So this is a recommended treatment where we give a dynamic external fixator and we get good movements. There is something called volar plate arthroplasty. Whenever there is involvement more than 50% of the fracture of the base, here we use the volar plate through the joint and use it as an arthroplasty. So this is the volar plate. We do a shotgun approach and we use this volar plate. We pass between the proximal and the middle phalanx and we do an arthroplasty. Any hamate arthroplasty, again when the presentation is late, so we use a part of hamate. It exactly coincides with the base of the second phalanx described by Heath Hastings. So this is a late presentation. So there is, again we do a shotgun approach. We take a part of hamate and we match the articular surface. We fix it with 2 screws. So here we are doing the matching, and this is the bone graft taken from the hamate, fixed with 2 screws. So here I am just showing about the Suzuki frame. So what we require is we require 2 6-inch K wires, 1.2 or 1.5, and 1 9-inch K wire, and 2 rubber bands, and this much is the inventory: a drill machine, C-arm, strong plier. Strong plier, why? Because we bend it at 90 degrees. So usually done under a flexor tendon sheet block. This is the wire. This is what I am showing about Suzuki. So the 9-inch wire goes into the head of the proximal phalanx, and 6 inches go into the base and head of the middle phalanx. So this middle wire is called the reduction wire. So this is what is described by Suzuki. The wire which goes from the head of the proximal phalanx has to be into the center of rotation. And this is the final construct where we use a strong plier or a unused needle holder, and we bend it and we apply this rubber band traction. So what is described is they use a dental rubber band, which is very costly. Nowadays we are using this saline that thing, and it works very well. So this is on table, we get full flexion, and we encourage them further movements and mobilization. So this is how it works. System is stable with the axial traction pin and rubber bands come in line, and this is how it works. Case, so there is a fracture dislocation, subluxation with a V sign positive, presented late. So we did a Suzuki dynamic external fixator, and this is a nice union with a very good reduction as well as union of the fracture. It is described in Green's hand surgery textbook, which is difficult to treat with open reduction, internal fixation, and percutaneous pin. Now, this is another new technique where we use the Zimmer static traction technique. Again, a case, fracture dislocation with a V sign positive. There was also a fracture in the third metacarpal. So this is middle finger. So what we use is an aluminum splint we use, and it is done under local anesthesia, and this is the procedure. We do it under local anesthesia, and through the nail we pass a feature. So we use 1,0-proline or ethylone. We pass into this nail that will act as a fixed traction unit. This is that aluminum splint. So we put a plaster over that, the aluminum splint, in a functional and slight extension of the wrist, and we mold that splint like this. So now your wrist is at 30-degree extension and finger is at flexion. So almost 90 degree or more than 90 degree, and we check under C-arm in the lateral view, and we get a very good reduction. So this is the construct. This we keep for 3 weeks, and this is the X-ray. So the V sign is gone, fracture is nicely reduced, it is in position, and after 3 weeks we remove that and we put sort of extension block thing, and we encourage movements. And this is what we get at after full physiotherapy. So what I do, if the patient presents from till day 10, we do a Zimmer static traction, which I just showed. If the patient presents from day 10 to 6 weeks, 1.5 months, we go for a Suzuki because till that time, after day 10, it is very difficult to get in the Zimmer static fraction because the fracture has started become gummy. After 6 weeks, if the patient presents, then we either go for a hemi-hamate or a volar plate arthroplasty, between which we prefer a hemi-hamate if there is a big fracture chance. Thank you.
Sir, have you used any time Jazz fixator?
So jazz fixator, the problem with jazz fixator is you cannot mobilize. In few neglected, dislocated cases, we have used, because Dr. Patankar has showed that he uses a jazz fixator, he distracts the joint, wait for some time, and then he uses that same wires to mobilize. In fresh cases or where we cannot use a jazz fixator because we cannot mobilize it. Our intention is not only about fracture healing, our intention is how to get good mobilization.
Like one more time. टाकून दे म्हणतात त्यांना डिटेक्ट करते नाही ते डिटेक्ट करत नाही तू त्याची वाट बघायला कधी टाकते त्यांना मग ते डिस्प्ले कामं नाही लागत किती सगळ्याची अडचण तू काय करू नको एकदा विजय दाबला ना राहू दे विजय टू पे चले जाता हूं क्यों टीबीया मोड पे करने आ रही है सर व्हाट सर काही येते विचारतच यांच्याकडे 2 दिवसात काही केलं त्यांना सांगता
If you see this chair and the plated handle, the intention is there. The intention is good, but the execution is poor. And that is what I'm going to talk on lag screw and DCP principles. So here is the execution. The spectrum of stability in treating fractures are either by direct healing or by indirect healing. And when we mean direct healing, we attempt to make a gap which is less than 2 millimeters. We make an attempt so that there is no movement. We make an attempt, there is a good blood supply which is preserved. And that gives you absolute stability. Indirect healing is the one in which we leave a gap which is more than 2 millimeters. We have controlled movement because of the proximal and the distal fixation, and we preserve good supply here also. So that gives you a relative stability. The examples is here in this humerus, where we have done an extra-articular plate. So we have not used the interfrac screw. We have used the plate in a bridging mode. That is, We have fixed screws proximally and distally and spared the zone which has fractured. And you can see there is a good callus formation and union. So this is relative stability where we see a good callus and a union. So in a direct or an absolute stability here, we don't see that callus. The fracture unites without any callus. So this is the difference between absolute stability and relative stability. So absolute stability can be executed in such type of fractures as well. You can see there is a butterfly fragment here in the distal fragment. There is a long oblique fracture. So an interfrac screw and an extra-articular plate here is used, and you can see that has healed in an expected time. So this was a fracture. You can see the extension. You can see the sharp edges of the short oblique fracture. And at 1 year, you can see how beautifully that has healed without any callus. So this is the magic of absolute stability. No callus and a good healing. The implants that produce absolute stability are the lat screw fixation. That means we do an interfrac compression or axial compression with compression plate and sometimes a buttress plate. These are the three examples of absolute stability. A lat screw fixation is a technique, not a type of screw. Any screw can function as a lat screw to provide interfrac compression if it is inserted properly. The shaft screw or half threaded screws are the only screws that is designed as a lat screw to provide interfragmentary fixation, and in neck femur is the one example where these can be used, or an intercondylar fracture where these can be used as a lat screw. The lat screw, if it is compressed properly, generates a force of 2,500 to 3,000 newtons. A lat screw results in absolute stability. Where can we use the lat screws? Which are the fractures which are suitable? Long oblique and butterfly, which has a wedge fragment like this. A short oblique in forearm, in a smaller bone, do not attempt that. In a longer bone like a femur, tibia, or sometimes humerus, you can use a lat screw. Where you require a good buttress in a metaphyseal fracture, you can use a lat screw. So these are the examples where you can do lat screw fixation. Oblique fracture like this, or a wedge fragment, or a split fracture where you have a segment which is split into two. Axiom is a rule. Anytime a screw crosses a fracture line, it must be inserted as a lat screw to provide interfragmentary screw. So if you are passing any screw which is going across a fracture, it cannot be a normal screw. It has to be an interfrac screw. Axiom. So this is how you achieve a compression. Axiom 2, that is, axiom is a rule. The ideal direction of a lat screw for generation of compressive forces is perpendicular to the fracture plane, but often, like this is the fracture, your screw has to be perpendicular to that, and then only you can compress that fracture. But most often you don't get that. So the inclination halfway between perpendicular and little bit more towards the fracture along the long axis can be chosen, but the drawback of that is if you bend excessively, if you go on the other side excessively, you may get a displacement like this when you compress that fracture. So it has to be somewhere in between, not exactly perpendicular, because very often it is very difficult as per the fracture configuration. Screw must glide in the near cortex. That means you should have overdrilled the near cortex. Thread hole only on the far cortex. Screw head stops at the near cortex. So you must understand the terms. The near cortex is the one through which you are passing the screw. Far cortex is the one in which you are bringing the cortex towards the, or bringing that fragment towards the screw.
So the technique involves a good exposure where you see both the ends of the fragment, wedge fragment, which you want to compress. You reduce firmly. If you have not reduced it, if you have not held it with a forceps or a fragment holding forceps, your screw, when you drill across, there will be a mismatch. So hold it properly with a reduction forceps or a trowel clip, and then pass the lag screws like this, perpendicular to the fracture, and then fix the plate over that in a neutralization mode, and that is how you can achieve a union if you follow the technique. That is the range of movement. So the technique involves drilling the near cortex with 3.5 millimeters drill bit, that is over drilling. So the near cortex or the near hole is called a gliding hole, and the hole which you are making on the far cortex is a pilot hole, or it is also called as a thread hole. So the far cortex is drilled by 2.5 millimeter over an insert sleeve, that is in the pilot hole. So 3.5 for the near cortex, 2.5 for the far cortex. But traditionally, while passing the screw, we are doing 2.5 in the near cortex and 2.5 in the far cortex when you're using a 3.5 screws. So here, if you do that, that means instead of 3.5, you use a 2.5, and then at the end, you over drill it. There will be a mismatch which will give rise to a problem like this. So the gliding hole and the pilot hole will not match if you have not used a 3.5 and 2.5 drill bit for the near cortex and for the far cortex. So it will end up in a displacement or a reduction, something like this. So avoid this mismatch. Use a countersink, allows to give you a uniform compression. Eccentric loading will lessen the degree of compression. So if you are not use countersink, you will end up in having the head fixation on the cortex only on one side. The other side remain out, so you will not get a uniform compression. So if you have countersink, you will get a uniform compression across the fracture. So reduce the prominence of the head. Measure the length of the lag screw with a depth gauge and fix the appropriate screw like this. So here, once you have achieved the reduction, then over drill with a 3.5 like this, withdraw it, insert a drill sleeve, that is a glide hole, gliding hole or glide hole, insert a sleeve which will go across the fracture, and then drill the far cortex with 2.5, remove the sleeve, use a countersink, and then pass the screw like this. So if we have not used it in this fashion, that means you will get a compression when you fix it. If you have used a same size drill bit, your screw will be only a position screw, that it will not compress. So if you want a compression, you have to use a 3.5 in the near cortex and 2.5 in the far cortex to get a compression like that. This was a patient who had a split in the shaft, and you can see the two interfrac screw have reduced it, and then a neutralization plate, that is a healing at 7 years. If you have a combination like this, don't use an interfrac screw. Here, this is a situation where, or if you have a smaller bones like radius and ulna, don't use an interfrac in this. You will end up in giving a combination. So which fractures are not suitable for lag screw? When you have a small butterfly wedge fragments, when you have a short oblique fracture, and elderly osteoporotic, these are not suitable for lag screw fixation. So you can see a wedge fragment which has been lagged, and that has led to a non-union in this. It requires a different type of fixation, a bridge plate, wherein you compress the fracture and achieve a union.
Insufficient reduction of a simple diaphyseal fractures will lead to implant breakage or a delayed healing. When you are using a lag screw in a locking plate, they should never be used through the locking plate, because you will not achieve a lag screw effect, will not achieve an interfract compression when you are using it through the locking plate in such oblique fractures. What will happen? The plate will break because the forces are unequal. So such fractures in this situation has to be used by a bridge plate. So that was about the interfract fixation. 2 minutes more for DCP principle. So DCP principle is basically using a plate appropriately to get a compression across the fracture in a transverse fracture. So it gives a direct healing where you reduce the gap less than 2 millimeters. There is no movement, and you can see this is a short oblique fractures. You have achieved absolute stability and a healing where you don't see the callus. Implants that produce absolute stability are the compression plate like this, or you can use a LC DCP which has a combi hole, wherein on one side there is a provision for threaded screws, and other side you have a DCP hole which can glide your screw when you are passing it. So which fractures are suitable for a compression plate? These are transverse fracture, short oblique fractures, some simple type A metaphyseal fractures, and osteotomies when you are doing it. So axial compression from DCP or LC DCP can produce absolute stability, but that needs anatomic reduction. So what are the methods by which we can achieve compression in transverse fracture? By using eccentric screw placement, by using Mueller's tension device. You can use other tension devices, or you can pre-stress or pre-bend the plate. I'll give an example of each. Dynamic, when you're using in a transverse fracture, when you're using a dynamic hole of a DCP to achieve a compression, here pass the central screw first, center screw first, and then use eccentric drill or eccentric drill guide to pass the screw in a eccentric fashion in a DCP, where the screw is at the edge, and then once you tighten it, the screw glides in the center, thus achieving the fracture. So what is the effect? The bone shifts to the left like this, and the plate shifts to the right to achieve a compression at the fracture. So that is the principle of DCP. Second method by which you can compress is you can pre-bend the plate slightly. It forces the opposite side to compress. Otherwise, in situation, you may leave a gap on the opposite side. So if you pre-bend the plate, so the far cortex can be compressed in a better way. Third method is a Mueller's tension device. It is very useful whenever you are closing or compressing the larger gaps. We are achieving compression in a non-union in a situation like this where you want to compress. So that is a very useful instrument. In oblique fractures, if you have to use it, you have to use it on the obtuse angle side. Otherwise, it will end up in a distraction or displacement of the fracture. So it has to be used on the other side. Another very good instrument is this compression expander tool. It is useful in achieving compression. It can also be used in distracting the osteotomy or the fracture or aligning it here. So once you distract it or compress it through that same hole, you can then pass the screws. Similarly, it can be, the instrument can be used like this to compress as well. How do we compress oblique fractures? So it has to be always, these fractures should be compressed. First fragment on the obtuse side, pass the central screw on the acute side. On the obtuse side, put it in a eccentric mode, and then once you tighten it, you will get a good compression like this. Attempting a lag screw in the presence of comminution will risk the healing, and it will end up here. A lag screw has been used in this small
butterfly fragment in a small oblique fracture. So that ended up in a avascular necrosis. That segment had to be taken out because it had a non-union. It went in a non-union. Whenever using a DCP mode, keep a working length. That means keep 1 or 2 screws across the fracture empty. If you are putting all the screws, that generate lot of stress and that leads to a fracture, implant fracture, which is not good. Another example here where all the principles of interfragmentary compression and a DCP has been used, and you can see that has healed in expected time when you use it appropriately. Cause of reoperation are mechanical reasons, that is using a wrong fixation technique, insufficient reduction of simple diaphyseal fractures that leads to delayed non-union implant breakage, where you can see here persistent gap at 3 months and the plate broke at about 5 months. So here a different mode was used and that is how the fracture healed. Take home messages: absolute stability implies there is no motion between the fracture fragments and the normal functional loads. The best method to achieve absolute stability is with interfrag compression, that is by lag screw technique, is indicated in articular fractures and simple diaphyseal fractures. Fractures treated with absolute stability can be expected to heal with direct bone healing and no callus. Thank you very much. I would request Dr. Sandeep Gawai sir to continue his talk on indications, principles, and complications of reaming. Now, please hold on. I understand everybody is hungry, but these topics are very essential. People have come up from very far off place, and we won't get to hear all this again. So please be patient. Cocktails and starters are behind. So, between principles must be wide enough to occupy the entire cross section of the medullary canal as it crosses the entire length. So that was Gerhard Kuncher long back, about 50 or 60 years back. So why do we need reaming? It increases the intramedullary canal diameter so that we use a stronger nail, we improve the working length, and the fixation stability is better in axial, rotational, and bending forces. So earlier, what was used is, along with the Kuncher nail, the ender's pin or the Lamoury's wire were stacked along the nail to improve the thickness of the nail so that you get good stability in the proximal and distal canal. Indications: mechanical. When you have a small diameter canal, and you have a non-compliant patients, we increase by reaming the canal diameter to this size so that we can accommodate a larger nail. This is particularly useful when we are doing reaming in fresh fractures. Also, other indications would be non-union, where you have to do an exchange, you have to put a thicker nail, or when you are using an auto bone graft, that means in doing the exchange, during the exchange nailing. The contraindications of reaming are the polytrauma patients, where you require lesser operative time because of his medical condition, and you want to just pass the nail without reaming. Situations where blood loss is not acceptable, so we can pass the nail without reaming. Reaming may increase in certain conditions, in certain situations of patients, chances of fat embolism or ARDS. So those are the only contraindications where reaming should not be used. It is also controversial whether you should ream in open tibial fractures. It may jeopardize both endosteal and periosteal blood supply
And that is the reason it is not recommended in 3B and 3C. Type 1, type 2, type 3A, all can be rim, you can use a rim nail. In the presence of acute infection, again, it should not be used, and in tumors, again, it is contraindicated. So, rimming should always be done with a power equipment. Dedicated reamer attachments to a specific power drive must be attached. They reduce the revolution, which automatically increases the torque. So otherwise they will mismatch. So there are 3 different types of reamers. One wherein you have the first reamer which cuts the medullary canal. That is the smallest size. Either in some sets it is of 8 millimeter, in some it is 8.5. So that first reamer is a cutting reamer. The second reamer is 8.5, 9, 9.5, 10 and onwards. They have shape like this. They are expanding reamer. So you can see at the tip, they don't have any cutting edge. And the third type is where you are using it for suction irrigation, where you are aspirating from the medullary canal, the medullary contents, which can be used for grafting. So the reamers most often in the commonest sets, they start from 8.5, they are up to 13.5. So these are the 8.5 reamers which have front cutting edges. The above 8.5, these are the tips are blunt. The cutting edges are at the back. So they are known to expand the medullary canal. So that is the difference. To reduce the likelihood of reamer heading jam intraoperatively, do not skip the head sizes. That means you go on reaming in a serial fashion. Don't jump from 8.5 to 9.5 or 10. So go on serially reaming it 8.5, 9, 9.5. Otherwise, if you jump, your reamer may get stuck in a medullary canal. So the flexible reamer shafts, which connects the reamer to the shaft, are in 8 millimeters, 8 to 9. These are front cutting reamers in different sets. 8 millimeters have a shaft diameter, 9.5 to 12.5, and 10 millimeter shaft is for those where the reamers are from 13 to 19 millimeters. They must be used with a 3 millimeter rod, which is or the guide wire, as the reamer locks to the head to the shaft in that. Most often this is not done, where the company provides you a 2.5 or a 2 millimeter guide wire, and then there is a mismatch here that generates a lot of heat and thermal necrosis of the medullary canal. So whenever you're using the sets, the guide wire has to be of the corresponding size. It has to be of 3 millimeters. The flexible reamers and the guide wire. Now, the guide wires can have a tip at the end, or some of the guide wires they have bead. The bead can be at the end, or the bead can be at a distance here at about 1 or 0.5 centimeters. So the reason here is, if you pre-bend the guide wire, or if you use this bend dial, it is very useful whenever you have a displacement like this. So you can rotate the guide wire if it is bent. So otherwise it will tend to go out. So even if you have a displacement like this, a pre-bent guide wire, by rotation, you will be able to negotiate it. So insert it with the universal chuck or a T-handle. If you try to insert it with hand, what will happen? The guide wires will bend. Bent guide wires or a scratch guide wires, they are not good in a long run. The reason is your reamers, they take a lot of energy and heat to bypass that bend, and particularly when you are inside the medullary canal, they will generate a lot of heat. That means you will have a corresponding necrosis of the endosteum. What do you do when you have a jammed guide wire? So you drill proximally and distally. Don't go on drilling in one direction. You withdraw, drill, withdraw, drill. So that is why you can negotiate and take out the reamer from the guide wire. Guide wire with multiple bends, scratches will require reaming. Guide wire are not the canal for a long time. Heat generation and necrosis will be significant. There are also monoblock flexible front cutting reamers. Like they act like a drill bit to start a pilot probe. Whenever you are reaming a narrow canal, it is necessary to use reamers or a monoblock flexible reamers to open the canal to at least the first size, that is 8 millimeters. Widen the medullary canal to 8 millimeters before using the front cutting 8.5 medullary canal reamer under power. Some have a very narrow canal. So in them, use a hand reamer, which is usually little flexible of 8 millimeter size, ream it and then use the power reamer subsequently. Monoblock flexible reamers, they come in the size of 6 to 10.5 millimeters shaft in 0.5 increment. Hand reamers 6, 7, 8 must be kept ready whenever you are reaming. Sometimes in a younger individual, after making the entry with a owl, you are stuck where you cannot pass the guide wire in the metaphysis. So here that 8 millimeter hand reamer is very useful in negotiating the strong metaphysis in young individual when you start reaming it from the entry point and then you stop it somewhere here when you find the canal, and then you can pass the guide wire or then subsequently expand it. So this is over that you can use the reamer, or you can use a cannulated cheese cutter through the entry point to some distance and then connect it with the guide wire. The reaming and the nail insertion has to be careful. If you have a reduction or a sag, particularly in the femur, throughout you have to maintain that reduction. Otherwise, there will be a lot of energy wasted in reaming the cortex. It will either splinter or there will be explosion fracture, or the guide wire and the reamer will come out from here. So you have to maintain the reduction whenever you are reaming and whenever you are passing the nail. Otherwise, your guide wire and the reamer will come out in one of the reaming. So a good reaming practice is inspect the reamer head for dullness before every surgery that requires reaming. If these are blunt, do not use them. They produce a lot of necrosis because of the heat. Reamer should always be used with a ball tip reaming rod. They should not be used without that. Widen canal narrower than 8 millimeters with hand reamers or monoblock flexible reamers. Rim in 0.5 millimeter increment. Do not skip the reamer head size. Whenever you are exchanging from beaded wire to a normal guide wire, insert a medullary plastic sleeve, remove the ball tip reaming rod, because some of the nails they do not allow, they require an exchange of a beaded guide wire to a normal guide wire. Rim in 0.5 to 1 millimeter, maybe 1.5 greater than the nail which you are using. So over rim by at least 1.5 millimeter whenever you are reaming. Insert the nail and remove the rod appropriately. Inspect for the damaged blunt heads, because they increase the intramedullary pressure and temperature. They must be replaced and not sharpened. These are not for sharpening. They have to be replaced. Flexible reamers, these are the old reamers where there was a coil shaft, never where they used to ream in only one direction. If you try to use a reverse reaming, the coil, it would coil the shaft. So it is difficult to then, you are stuck up in those situations. But now these are no more available. These are obsolete. The complications related to reaming, the reamers or the nail, they act like a narrow piston inside. So it is whenever you are reaming in a closed canal, you are pushing a piston inside. That means whatever is the medullary contents, when you are forcing or using a pressure, it is dispersed through the Haversian canal, through the cortex in the circulation. So if you are forcibly doing that, lot of fat from the medullary canal will be released in the blood circulation. The pressure put on the fluid in a vessel is same in every direction and puts the same force on every part of the container. This is the Pascal's law. And the intramedullary pressure, whenever it is resting, is about 30 to 60 millimeter. When you open the canal, it is about 200 to 300 millimeter. When you insert the guide wire or the first reamer, it generates the intramedullary pressure to about 1000 millimeter of mercury. Whenever you are doing sequential reaming, always go slow. If you forcibly go inside, it will generate a pressure which will be about 1000 milligram. That means the Pascal's law. If you are forcing your guide wire, if you are forcing your nail, if you are forcing your reamer, more fluid, more fat will be dispersed in the circulation that may give rise to complications. So nail insertion also has to be slow whenever you are inserting that. Don't insert with the force. During trauma, fat is released in the blood circulation and that is responsible for fat embolism syndrome or ARDS. To conclude, the effect or the good part of this is a non-union, and just by exchanging, close exchange, reaming appropriately, using appropriate length and a nail. You can see here appropriate reaming, using the thickest, largest nail, locking it properly. This non-union has healed in expected time. So reaming effect are also biological. There is an internal bone grafting when you are doing a serial sequential reaming. It stimulates the blood flow. It activates greater cellular humoral response. It enhances the fracture healing, and the same is the example here. So goal of fixation with intramedullary nail is to achieve stable fixation, resulting in indirect fracture healing with callus. Summary: increased fracture union with ream nail is expected. It gives better mechanical properties, minimal adverse effect. Contraindication to reaming are also to the intramedullary nail. Thank you very much.
For the presentation. Good evening, all of you. Coming to the proximal humerus fractures fixation with pillows plates or different modalities to fix it. With the time constraint, what I have done, I have cut down on the theory part and I have put few cases, interesting cases. So hope you find the cases interesting. So coming to the indications of plating, 2-part displaced fractures or 2-part with dislocation, 3-part fracture or with dislocation, 4-part with or without dislocation, coronal split in the humeral head, and valgus impacted fracture. So these remain the indication for fixation. Coming to the approaches, most common is deltopectoral approach, and in few cases we can go with deltoid splitting approach.
We all know this deltopectoral approach, and we are all doing and using this approach. We should be very careful with the axillary nerve when we are using a deltoid splitting approach. So this is how we do the deltoid splitting approach. This is the commonly used pillows plate for fixation of most of the fractures. We should attack the tuberosities. We should fix them with ethibond. Slight medial impaction is desirable. Anatomical reduction of calcar is not needed in all the cases. A slight impaction at the medial side might even increase the stability of reduction. So you should not worry about the medial impaction at the calcar. Coming to the correct plate position, the plate should be about 5 to 8 millimeter distal to the top of the greater tuberosity. Should be aligned properly along the axis of the humeral shaft, and it should be slightly posterior to the bicipital groove. So this is how we put the plate. This is the correct location to put a pillows plate. So now directly coming to some clinical cases, 45-year-old male patient. So this was 3-part fracture dislocation. You can see his humeral head lying far away from the shoulder, and it has gone into the axillary fossa. So we, considering his age, right hand dominant, we did not want it to replace him, so we fixed it. So this is his post-op AP and lateral view, and this is his function at 2 years. No avascular necrosis. So avascular necrosis is very less than what it has been thought, what it is described in the literature. Clinically, disabling avascular necrosis I have rarely seen, even in such cases. Another patient, 45-year-old male, road traffic accident. Again, you can see a fracture dislocation with metadiaphyseal extension of the fracture. So here we put a very long plate. We brought the head back into the glenoid, 2 interfract screws and a very long plate, and did at 3 months already showing signs of union, and this is his clinical pictures. Another case, varus, 2-part, 2 or maybe you can call it as a 3-part fracture. You can see a fragment of the greater tuberosity. So this is how we disimpacted it using an artery forceps intrafocal, disengage it to bring it back into a normal valgus, and then this is the further reduction. So those 2 screws, the calcar screws, are very important. We did not disimpact the medial impaction, but we have restored the normal valgus, normal neck shaft angle has been restored, and this is the lateral view. So the trick was to disimpact it with the instrument. Another patient with another case, very simple 2-part fracture. Here, considering the simple fracture geometry, we used a very short plate, AP view, lateral view, well aligned plate, well reduced fracture. Another case, displaced 2-part fracture, a pillows plate again, anatomical reduction, lateral view. Another 3-part fracture. Here you can see the greater tuberosity is extending distally with the cortex of the lateral shaft. The head has subluxated distally. So this is how. So here the trick is to first reduce the greater tuberosity to the head, and then you convert this 3-part into 2-part, and then put the plate. And this is the final picture. This is the final picture. Another patient. Here, if you at the bottom, if you see this X-ray, it looks pure metaphyseal fracture, spiral long oblique fracture. But if you see the CT scan, you will be shocked to see a split in the humeral head. You can see a transverse split in the humeral head, and even on the axial cuts, you can see there is displacement of there is coronal split, and there is displacement of the humeral head. So again, we did not wanted to throw this humeral head, and we wanted to salvage this shoulder. So this is how. Here again you can see one antero-posterior screw. This is Here we reduced both the halves of the humeral head. We brought the two anterior and posterior part of the humeral head together with the CC screw, 4 mm CC screw with the washer, and then the rest of the fixation was as usual. Another patient, 3-part fracture. So in all the fractures, what you see is these long calcar screws. They are very important screws. So the principle is same. What we follow for neck femur, fracture neck femur. So this calcar is restoration of this Gothic arch. This medial Gothic arch is important and support with a long calcar screw. This is an antivirus calcar screw we put. And this is the lateral view, nice reduction. Another patient, so this is, if you see the X-ray, you don't, you are confused what is happening with the humeral head. But once you see this axial cut, the humeral head is rotated 90 degrees and it is impacted. It is, you can see it is behind the glenoid here. It is impacted. So again, a very tricky situation. Here we use the joystick. So this is a K-wire into the humeral head. We disengaged the dislocation. We brought the humeral head in contact with the glenoid and then another K-wire to fix it temporarily. So the first K-wire is only into the humeral head, but the second K-wire, if you see, it is now fixing the cortex, the lateral cortex to the humeral head, and then the fixation. Here, considering the extreme fracture dislocation, we have used every hole in that plate, and you can see nice reduction. Another patient, elderly patient, 3-part fracture, gone in varus. So here, additional tension band was used to fix the greater tuberosity. It was separate fragment. We did not want it to leave it separate. So here you can see we used the tension band to fix the greater tuberosity. This is the deltopectoral approach, what we use routinely. Another patient here, had we not done CT scan, we would have missed this coronal split in the humeral head. But with a plate, good quality Philos plate, we are able to salvage these heads too, especially in younger patients. Another patient, 50-year-old male, 4-part fracture. This is a CT scan, impacted humeral head with separate tuberosities, GT, and so here we have used a very innovative device, that is an intramedullary fixation device. Tomorrow you may see the sawbone demonstration of this device. This is an intramedullary fixation device by Humerus. The original device was invented by was called as Bill Bucket. So this is a modification of Bill Bucket design. So here you have to work inside the fracture. A staple is placed under the humeral head, and then an independent stem is inserted. A telescoping stem is inserted into the metaphysis, and then both they are engaged together. So here you can see the humeral component and the diphyseal component have been engaged here in this fashion, and you can close the soft tissue around. So there is no surface implant. So this is the intramedullary fixation device. All the soft tissue can be tied around the prosthesis. Here you can see a nice tension band, soft tissue tension band has been created around the intramedullary device. And this is the final picture. Here you can see the reduction of the medial arch has been restored, the length has been restored, and you can see the greater tuberosity, the lesser tuberosity, everything has fallen back in place. So this is the device. You will see it tomorrow. This is by Humerus. This is a French design, and it comes in 2 parts. One for the humeral head and one for the shaft. And this is the final AP and lateral view, well aligned fracture in both AP and lateral view. And these are the components which has been used. This is, I'm just trying to show the restoration of the medial anatomy, medial Gothic arch has been restored. And this is the patient. When he came for at the end of 2 weeks, he is trying to do active mobilization. And this is how this prosthesis works. This is a jack. This works like a jack. Once you fix it, then towards the end of surgery, you can restore the length. You jack it up, and then there is a locking screw. So you restore it to the desired length. So this is the final step. This is another patient. Here you can see one Herbert screw has been used to fix the coronal split. Once we fix the coronal split in the humeral head, we have used this intramedullary fixation device. So that was a 4-part fracture. Last 1 or 2 cases. This is epileptic patient. There was only impaction of the articular surface. You can see on the axial cuts. And this has been fixed with few Herbert screws. So this is a different kind of injury. I don't know how to classify this injury. Intra-articular impaction of the humeral head. This was the final picture. Another patient, bilateral impaction fracture of the humeral head. He was epileptic. This we won't go into this. This is like the salvage surgery. He had many failed previous attempts of fixation. Ultimately, we have to do a reverse shoulder on him, and you can see the nice function of his shoulder. So this was done as a last resort. He had many previous failed surgeries. Another patient, 4-part elderly patient, and then we had no other option than to replace him. So this is how we do a hemiorthoplasty for 4-part displaced fracture in elderly patient. So for elderly patient, had he been a young patient, I would still prefer to fix him using that intramedullary device. I think let me stop here. You can ask a few questions if any questions. Thank you, sir.
Thank you, sir, for that excellent talk and given. Now, may I request Dr. Shivshankar, sir, present leading in extreme distal fracture.
HDMI काढणे का लॅपटॉप घेऊन गेला त्यांनी
Good evening. Since all the topics are good, we have decided that we'll do everything before we move to the fellowship dinner after this. So don't worry, it will start only after everything is over, and we will not waste any time in between. That is the assurance I can give. There is no tea break now. There is no in between break. So immediately after the lecture, there will be hands-on workshop picture, and we'll go up for the fellowship. Okay, friends, twin brothers, one had this fracture, treated with a blade and had a reasonably good outcome. I used the fracture of the tibial fibrosity and elevated the whole extensor mechanism and treated in this fashion. Other twin had little simple looking fracture. Again, I did a nailing. Both of them had met this accident. So there are varieties of way to fix. I will just restrict myself to nails. This is the selection stage which came in India for the first time. Dr. Tanna's anesthetist, Dr. He came out with Medtronics, and that Medtronics company was doing this nail, which had lot of nails. I used few of them, but majority of them failed because of the hole at the fracture site. So then in the 90s, 96, 97, This the nail came with only 3 distal holes and 2 proximal holes, and then we started using them, and we started getting reasonably good result with that. For osteoporotic fractures, I used to use a cannulated 6.5 millimeter cannulated screws, and I could get the nails without the third hole also. I thought that the fracture is coming at that site. I used to ask for a special nail, and within 24 hours I used to get that, but I don't get it nowadays. Then we started using for floating knee, suprapatellar nail, both for femur and tibia, and that was the trend at that time. Before we had this GPS nail, I had used quite a good number of them to get good results out of that. And here is few more simple fractures which have been treated in similar fractures even after the implants have been removed. Majority of the time people think that once you put an implant to the knee, it's very difficult. Almost all my cases I have done the implant removal. Then from extra-articular fracture, I entered into the intra-articular fracture. With a split, I applied CC screw by percutaneous method and then inserted the nail, and the patient had an excellent function. This is after 4 years before the implant was removed. Then from C1, C2 to I graduated to C3 type of fractures also. So I started reconstructing the parts around the nail, and the patient used to get beautifully good results. So you can see that there is a void medially. In spite of that, there is no plate or additional things done. Fracture united, and I removed the implants also in that patient. Another badly communicated fracture, again I have treated in the similar fashion, and beautifully it restored the anatomy around the nail. Because the nail is in the center, whether there is a gap laterally or medially, it doesn't matter. The bone heals around the nail beautifully, and again you can see I removed the implant in there. Another patient with a compound fracture, so much of communication in the suprapatellar and intramedullary area, I could only fix with KMR, but this patient had a stuck-up partition. I released the partition by doing partition plasty, and he had about 90 degrees of knee flexure. Plating is also good, especially if there is medial continuation. But if the medial continuation is not there, the problem comes. The problem with the plating is if a too rigid implant, helicopter effect will happen, and peri-implant fractures are very, very high. If there is communication medially, you require a medial plate, otherwise a single lateral plate fails. A communicated fracture here, I have treated with 2 plates, went on to unite beautifully. Another communicated fracture, yes, I did between 2008 to 2015. Again, I went back to nailing. I did lot of went back to plating. I did lot of them. Then this article came before that. One more case. Here you can see nailing has been done. There is no bone anteriorly, but the bone heals without any problem. This will not happen with a plate. I will give it in writing. This will never happen with a plate. So nail is along the axis of the weight bearing. Another case, badly communicated fracture. You can see I had to play jigsaw puzzle with the fragment and put them back as anatomically as possible. But alignment is good. There is a void medially. But if you see the alignment is good. Then everything heals without any problems. The gap gradually gets filled up in due course of time. It won't get filled up in 3 months or 6 months. It will take 2 to 3 years, but definitely bone will follow. So nail is definitely better option. I'll just directly go to that part. This article really opened my eyes. You can see that when you put a plate on one side, there is hardly any bone formation on the opposite cortex. 0 millimeter. Whereas if you put a nail, 330 millimeter at 12 weeks. So when you put a plate, there is 0 bone formation. If you put a nail, 330. Nail works like a Illicero. There is axial micromotion. It forms lot of bone. Secondary healing is very, very good with a nail, which will never happen with the absolute fixation with a plating. That's why we got the far locking cortex plates available. Friends, this far locking cortex, I have not used it. I attended a workshop in Bombay in 2015 or 16. These are some pictures from the presenter. Each plate costs around 1.5 lakh with all the screws and other things. But if you consider a nail, if you put the nail in the center, do a distal locking only lateromedially, then it can toggle and you have to put a locking bolts. But nowadays, multi-locking nails are available. You don't have to put the locking bolts, and good stable fixation will be there. Just after the talk, we'll be demonstrating the hands-on workshop on the same nail. So this is the nail I'm using. These nails have thread inside the hole. So you have to, like a plate, you have to pass these bolts through the threaded portion of the nail. So this nail will never toggle mediolaterally, and also multi-locking is very, very important. Dr. Prakash Chavan is there? Yes. So this is what I was telling. For a comminuted fracture like yours, I will use augmentation plate along with nail. So what I did the suprapatellar nail first, then added a plate by the side. So I have opened the laterally distally and also I applied a plate. I put all my knee patients on a 90-degree frame so that if the patient is keeping the leg extended, getting flexion is difficult. But if they keep in flexion, getting extension is not at all difficult. So always I use the frame. So this patient, you can see nail with augmentation, especially for young comminuted fractures. I use this technique. They work beautifully well. So nail, even if there is medial comminution distally also, that is more than sufficient. So there is some valgus deformity of the left side where he had another fracture, but right side thigh is the where I have used the augmentation plate. Recently done. Pro nailing also can be done. Anti-grade nailing with augmentation plating also can be done. So multi-locking suprapatellar nails are available. And myself, Dr. Amit Ajgaonkar and Jamin Washington from Ahmedabad, we share our cases, we discuss our cases. We do left and right since 2015. We have a lot of cases. I will show a few of them. This Amit Ajgaonkar case where he used the nail and the bone grafting, and he used this type of nail. So this is a nail which is different than mine. At 18 months, you can see full function of the knee with good restoration of the anatomy of the femur. Another case, comminuted fracture of the femur, again nailing has been done and the fracture has healed beautifully around. The patient is able to squat and the patient is able to walk also without any problem. Another case, this very distal fracture, again treated with a suprapatellar nail. This is Dr. Jamin Washi's case, and he has done this case. There was an intra-articular fracture. He treated with a small incision with a screw also, and this is all the incision. This is the immediate posterior X-ray. This is the follow-up picture. At 9 months, he is walking comfortably, full weight bearing without any problem, and he has got 120 degrees of knee flexion. Another case similarly which has been treated. Very distal fracture, intra-articular fractures also. Even if there is medial comminution also we have treated, and all of them have done beautifully well with good function. I can show n number of cases because 3 of us share our cases on our own separate group, and all of them have done beautifully well. Femur and tibia, both of them have been treated in similar fashion. Osteoarthritis and also rheumatoid arthritis patient we have treated, and we have got good result with them. With a small incision, we are able to put the nail and get a beautiful result with them. This is a rheumatoid arthritis patient. You can see she is healing just at around 15 days after the surgery. Osteoporotic fracture, again we have treated in similar fashion, and the patient has done. Very distal fracture, again same. As long as you are able to put 3 screws, then it is you can get a good function out of them. And this is after the fracture is confirmed. Segmental fracture, again we have used them, and it has given excellent result. Even non-union, I don't get to use this in non-union, but my friend Jamin Washi has used in Ahmedabad. He has put a plate nail with 3 screws, 4 screws in the distal fragment, and unfortunately I am not carrying this video, that's why it's not working. Some good indications are double fracture of the femur, fracture neck with fracture shaft of the femur, fracture shaft with fracture condyle of the tibia, fracture neck with fracture shaft of the femur, different implant for different fractures, floating knee injuries. Again, peri-implant fracture. If there is a implant in the hip, you can put a retrograde nail. If there is a implant in the knee, also you can put your knee implant as a notch. You can put a nail from down. So what is important is good anatomical restoration. And if you do them, well, it will beautifully heal. A fracture like this, the first thing might come to my mind when I see the X-ray is do a suprapatellar nail. Thank you very much. I showed n number of cases only to give you idea that It can be used for any number of cases and it beautifully helps. A plate only on one side, especially lateral plate with medial void, always it goes into varus or failure. So this nail, if there is gap also, nothing happens. All the cases are healed without any problem.
What is your post-op protocol? Terminated distal.
Other cases, what I do is I thoroughly give wash because we have done the reaming. There is bone debris within the knee joint that will cause serious swelling of the knee joint. And another thing is, if possible, I try to seal nowadays the hole with a bone wax before closing. And I always keep a drain in the knee joint for 48 hours. If you don't keep the drain, there will be serious discharge within the knee and the knee swells up and the knee stiffness is a problem. Always I keep the knee at 90 degree in the post-operative period on some table or some knee frame, and the patient will start extending as soon as the pain stops. So this is very important. I never keep the knee straight or knee on a bolus plate. Always I keep it minimum of 90 degrees of knee pressure. That's also equally important.
Weight bearing.
Weight bearing, I give them walker and ask them to walk. They will decide how much the weight to be put, and as and when they are free, they start walking.
So there is a small announcement. After Motwani's lecture after 10 minutes, there are two workshops. One is a suprapatellar kneeling from UK Street plant, and other is a supracondylar femoral kneeling, multi-lock femoral kneeling, and that is a tibial kneeling by D.K. Sharma pharmaceutical company. So there are two workshops of 15 minutes. So please bear with us. Dr. Motwani's lecture after that, there will be two workshops of 15 minutes each. Distal femoral multi-lock nail and proximal tibial suprapatellar.
I request Dr. Motwani to speak on Achilles tendon.
Good evening again. So I'm the closing batsman, and my next job is to talk on the Achilles tendon. Sorry for shifting the topic because the TTC nail is not working. I mean the video is not working, so we have shifted to the Achilles tendinosis. Again, this is a very common OPD procedure, OPD condition, chronic Achilles tendinosis, Haglund deformity, sometimes rupture. So how to manage a rupture? I have a small video of flexalis longus transfer. They are the three major causes of posterior heel pain: Achilles tendinosis, bursitis, and the Haglund deformity. And most of the time, it is a combination of these three all. So this is a normal calcaneus, healthy bursa, but because of the inflammation of the bursa, you get a swelling, inflammation, fragmentation of the Achilles tendon, finally a bone hypertrophy and Achilles tendinosis. This is a watershed area, last 2 to 6 centimeter of the tendon, where majority of the problems happens inside the tendon, and you get a variety of the calcification, even from the small at the insertion site to sometime up to involving whole substance of the Achilles. Not an uncommon problem. Conservative line, of course, first rest, immobilization, heel lift, stretching, everything. But what if it is not resolving? If it is not resolving, you have tried everything. These are the patients when you go for the Achilles tendinosis, excision, and the Haglund deformity rupture. So this is a 43-year-old female. This is the posterior midline incision. Separate the sural nerve, separate the tendon, identify the haglund deformity, go from side to side, take out the complete haglund deformity. From the osteotomy, this is how you need to shave it. Don't detach the tendon if it is not pathological. Take out the pathological part of the bone and reattach the tendon. What happens if the loss is more than 40% of the tendon, or if the excision is high? So here is a case of 56-year-old female. She had a continuous heel pain and Achilles tendinosis. But one day she came to us with the severe pain and a cluck sound. And this was actually the Achilles tendinosis rupture. So this was the rupture. This is the gait pattern when she is not able to do the dorsal, I mean the single heel rise is not possible. She is not able to manage to walk on toes because the Achilles has not generated a plantar flexion force. So a 56-year-old patient, direct repair is not possible. It's a pathological tendon. Keep the patient in the prone position. Put a round bolster so that it should be hanging foot. Para Achilles incision, not directly over the Achilles, so that you avoid the hypertrophic scar and the shoe wear friction. Posterior medial incision, skin, soft tissue separation. Identify the sural nerve, but mostly it gets retracted in the flap, so will not come on the way. Go right up to the paratendon. Three major advantage: the scar is not central. Identification of the flexor hallucis is easy. Sural doesn't come on the way. Immediately look at the thickness of the flap. This is the thickness you need to preserve to avoid the wound complication. Identify both ends of the rupture Achilles tendon. Look at the devascularized Achilles tendon by identifying the yellow and the red zone. This is how you can identify how much cut we need to take to the tendon. Definitely the gap is huge. This is the proximal end. Now take out the distal end of the Achilles tendon because this is called a pathological tendon. Preserve some of the foot sprint so that you can identify where you need to put a transfer tendon. Take out the devascularized part from the proximal tendon till you get a red zone of the tendon. So this is how we are excising the diseased tendon. Almost 5 centimeter of defect. You have two options: either you transfer the flexor hallucis longus or you do the VY plasty. For VY you need a big incision. So take out the haglund deformity through the mini saw and through the excision part. Now we have to go anteriorly to identify the tendon. Through the nibbler, take out everything, identify the tarsal tunnel where the flexor hallucis longus is going inside the foot from the ankle. This is a low lying belly. Move the great toe so that you can identify what is my FHL, what are the movements happening at the level of the incision is actually FHL. Release the sheath, identify the big tendon, low lying belly going to the tarsal tunnel. No special requirement of the instrumentation. Take a artery forceps, try to get 5 to 6 centimeter length of the tendon. Separate the flexor hallucis longus through the other part in the tarsal tunnel. Arteries, veins, they are much anterior, so you don't have to worry about the neurovascular injury. Tendon stripper, if it is there, good option. Otherwise, you can take out with a 15 number knife, oblique cut to the tarsal tunnel. Put a tendon stripper in the tarsal tunnel and try to get as much as length of the tendon you can get through this approach. Usually we need 5 to 6 centimeter of the tendon. This is how I am putting a 15 number knife with a tendon stripper to secure the other structures. Cut the tendon. This is the length of the tendon we are getting, almost 5 to 6 centimeter. Take a Krakow stitch, shoelace repair, or anyhow through which you can take the tendon. Same like what we do in the ACL. Separate the other part of the sheath so that you get the mobilization of the FHL. Here I am mobilizing the flexor sheath proximally so that I can get a mobilization of the belly and my tendon should come down. This is a replacement to the Achilles tendon. Now the FHL after this surgery will work like the Achilles tendon, and in 6 to 7 months it becomes as hypertrophic as the Achilles tendon. This is how we are taking the stitches inside the tendon. Any method, no special technique. Fiber wire is good, Ethibond 2 number is good, Prolene is another option, or Vicryl also you can take. Take a whole 4 to 5 centimeter fiber wire inside the tendon so that you get a good hold. And this is how you need a good stretching of the tendon. It is inside my tentative diameters, I mean the length is inside my calcaneum. I am drilling from posterior superior to the anterior inferior, or you can preserve some of the Achilles foot sprint so that you can identify where I need to put a drill. Make an oblique drill so that you get a more cancellous surface for the interference screw fixation. Tendon sizer, here it is 5.5, so my drill will be 6 mm, one size bigger, so that tendon should easily cross the should easily cross inside the tunnel. Secure the guide wire, and this is how I am passing a tendon. It should be easily freely movable in the 10-degree equinus through the transosseous tunnel. Give some pressure, give some pull so that there should not be adhesions or any kinking of the tendon inside the tunnel. 10-degree equinus position is important because this is how you can fix the tendon in the good tension. Put an interference screw of same size or little bigger so that it gets a good hold. This is how it is moving. Good tension, 10 to 15 degree equinus. Check the stability of the fixation, and this is how you can see it. Incision size 4 to 5 centimeter, maximum 6, depending on the tendon size. Proximal stump of the gastrocnemius, gastrosoleus, should be reattached to the belly of the FHL, so that it should not be the hanging gastrocnemius. Otherwise, your calf atrophy will be severe. So, proximal stump. This is how I am getting a positive Thomson test. Connectivity of the Achilles and FHL is restored. Suturing by the simple way as we have discussed with the good flap. Pressure band, the simple bandage, pressure free bandage application, casting in 10 to 15 degree equinus. Thank you. This is a post-operative protocol, 20 degree equinus slab for 3 weeks, neutral for next 3 weeks, the full weight bearing walking after 2 months, return to sports after 4 to 5 months. Thank you.
Thank you. I would thank all the faculty members to have done the needful today. May I request Dr. Govind Shinde, our Secretary of NANDED Orthopaedic Society, to give the vote of thanks. Please, Halevar.
Okay. Video.
So just answer two queries.
Yes, sir. Yeah.
So I got a question that why not peroneus brevis and why the FHL? two important things. FHL, it is a locally available tendon, doesn't lead to any morbidity to the great toe. Second, for the peroneus brevis, which is a powerful everter of the foot. So why to compromise a powerful everter of the foot? After transferring the peroneus brevis, there is a significant morbidity to the foot. You may land up with a flat foot deformity, and you require a second incision for transferring the tendon. Second, if the gap is more than 3 centimeters, you cannot bring the Achilles to the heel. So if it is under the 3 centimeter, yes, pull it back to the heel. Otherwise, just proximal stump ligation to the FHL. Reattach, of course. Indication of the surgery when the gap is more than 3 centimeters.
Hello, yeah. Friends, quickly we will demonstrate because without the trade partner support, none of the conference can be really successful. So we have to give credit for them also for coming every now and then, because last week only we had one at Aurangabad. Previous to that we had at Nagpur. Next month we are having it today. So it was a lot of investment from their side also. So let's come to the academics now. Position of the patient. I normally position the patient on 2 pillows so that the thigh is slightly bent at the knee. Knee is bent around 15 to 20 degrees. The assistant pushes the thigh down so that the tibia gets translated anteriorly. Another thing is we pass zoom karo. We pass a Steelman pin at the junction of anterior to 1/3 posterior, anterior to posterior 1/3, so that when we pass the nail will remain parallel to the anterior cortex. Nail will not go posteriorly. If the nail goes posteriorly, again there will be problem of translation happening. So our crux of the treatment is keeping the nail parallel to the anterior cortex. First step is we pass the statement pin, which is about 1 inch above the fracture. Then, if the fracture is middle third or lower third, then in the upper third tibia we pass the statement pin, because we use the same nail for fracture upper third, middle third, and lower third also. So first is statement pin, which has been passed down. Second is inflating the knee joint. We inject saline about 20 to 50 cc and inflate. Third is after taking the incision about 1 inch in front of the above the patella, we immediately insert our index finger and break the adhesions. Almost all the knee joint, the patella will be having some membrane attached to the femur, and that will not allow your subsequent instrument to be passed. So always you break the adhesions, then only you will be able to insert this long sleeve, protector sleeve with the trocar inside. Once you insert the trocar, pass the guide wire. The guide wire is passed just parallel to the anterior cortex and in line with the Fujisawa point on the lateral tibial spine. We insert. It should go parallel to the lateral cortex. Basically, it should not go medially or it should not go laterally. It should go parallel to the lateral cortex. Once it has gone parallel to the lateral cortex, we have hand reverse. We pass the guide wire and we have hand reverse. We ream it. First we ream. I remove this guide wire. That's okay. Through this only we have to remove all the guide wires. But since the guide wire is loose here, I am not using it. And there is a stopper. So when the stopper comes up to here, you can see here up to here, the reaming, the proximal end will be reamed, and subsequent reaming will be done with straight stiff hand reamers for a guide wire. Once the reaming is done, we take out the sleeve and we insert the. Normally, I don't insert this at this stage, so that's why I take this out. So because inserting with this on is little difficult. On a bone model it's okay, but in real life it is difficult. We only insert this and see Now my Steelman pill will be keeping the nail parallel to the intercortex. When it comes at the end, we have to hammer. The final thing is by hammering only. So there is a instrument to extract as well as hammer. Yes. And how we can confirm that the hammering is proper? There is a hole in the cheek. You pass a guide wire that will give an idea under the arm where your nail is entering. So in that time that it is at least few millimeters up control, 1 or 2 more blows. Yes. Okay. Because it's a plastic bone, it has broken. Normally, it doesn't happen in a normal bone. So once the nail is passed adequately inside, what we do is apply. Again, there is a hole here. That same hole which matches, because otherwise you can lock in the opposite direction. So you lock them and do the locking. And the locking is done from the medial side to lateral side. But since I am standing on the lateral side, I rotate it and keep it now on the medial side. Hope you can see. Then there is two lateromedial locking. With the help of the jig, you can do that. Local. I already applied the drill sleeve. So drill, when it comes to opposite parties, you can adjust the drill machine so that you know the length automatically without measuring also. But here, anyway, I will just drill it and take it out and put the screw. So the depth gauge, you can measure the length of the screw you are using it, and since it's the sloping triangular bone, the length of the screw required is normally 32 or 34 only. So you don't require a very long screw. You have to rotate the leg and see that your screw is not too much outside, either medially or on the lateral side. So two medial lateral is locking it done. Then we do the oblique locking. So we do oblique locking. Okay, and one more oblique locking is done from this side. So I do that also so that the fragment which is fractured will get fixed. Yeah. So then the jig is removed and again confirms that your nail is not too much proud outside. That has to be very much confirmed. Both in AP and lateral picture. And that tibia, the diamond pin which is used as polar screw is removed. So 2 medial lateral locking and 2 oblique locking. So that is at 45 degrees to them, 90 degrees to one another. So there is locking at 0 degree, 45 degree, 90 degree, 180 degree. So in all the directions locking is possible. Yeah. For distal tibia, there is 3 optic screws. In the last 15 millimeter, there is possibility other than 3.5. This is a 7 millimeter nail, so it can accommodate 1 anteroposterior screw and 2 medial lateral screws. So that will take care of the distal fragment and it will do the justice in doing the proper locking. Coming to the suprapatellar nail. Suprapatellar nail. Sharma people, please stop. Meanwhile, I'll ask the Yogeshwar people to distribute this pamphlet. It's given to everybody. This has all the steps of the GPS nail. Okay. Coming to the suprapatellar nail. Yes, yes. Oh. Okay. Friends, this is the distance femoral special made by the Sharma Surgicals. This Sharma Pharmaceuticals. Dayanand Sharma Pharma. The advantage of this nail is the interlocking screw is threaded within the nail. So the nail cannot toggle. So you can pass 2 of those bolt digits, 2 mediolateral bolts and 2 oblique bolts again at 90 degrees to one another. So these are the 2 mediolateral bolts. And 2 oblique bolts. Oblique नहीं क्या? दे दो. इसको पास करेंगे. सबको देखते हैं. So there is a good fixation within the 35 millimeter of the 3.5 centimeters of the distal end. There is 4 screw option which is available. So I just passed this. Everybody can have a look yourself. Coming to the technique, what we normally do is we pass the guide wire. Okay. This is the Blumenstadt line. Where the Blumenstadt line will be there, that is the direction. Again, parallel to the anterior cortex, you have to go and parallel to the lateral cortex. In a femur, in the distal femur, you cannot go medially or you cannot go laterally like this. You have to keep very parallel to the lateral cortex and pass the guide wire. Once you pass the guide wire, you have to reach across and then enlarge the entry side. Again, there is a sleeve. Since you have not given the sleeve, I am directly using the centering out and ream. This will ream the entry side up to 13 millimeter. So once that is reamed up to 13 millimeter, the nail is assembled over the jig. Whatever the nail you are using, though they come in 15, 20, 25. Nowadays, I regularly use only 32 centimeter or 36 centimeter nail because it's better to have a proximal at the isthmus, the support, and the nail has to go from the lateral side. So, since we have to go from the lateral side, I had to rotate it. Then over the guide wire we had to pass, but since it is getting stuck in the nail because the wire is bent, I am hammering directly. Again, it has to go slightly about 5 to 10 millimeters in the subchondral bone hammer. Now we can see that it is subchondrally placed. So that's why I am not confirming. Otherwise, normally what we do is we remove this connecting rod. We withdraw the jig slightly and see the gap between the jig and the nail. Then we do the lateromedial locking. First, both the lateromedial locking is done. Yes. Now, the question is, this is little cumbersome. You have to keep on threading this screw. It takes quite long time. If you are using a powered one, you can use it. But since we have only the option of using a hand one, so I'm just withdrawing to show that how it keeps going only millimeter by millimeter. इधर फोकस कीजिए, screw दिखाना. And if you hammer the nail, the threads in the nail gets little damaged and you will not be able to pass this screw. So if you are not able to pass the screw, that indicates you have damaged the nail. So you take care of that. So 2 lateromedial locking has to be done, but we are doing only one for our convenience sake, and then we will be applying the jig to do oblique locking.
अबे माल लेना बोल के तेरे पीछे लगे यार, हम तेरे पीछे कब लगे, हम तेरे पीछे कब लगे.
This is a special type of screw. If you see this, there is cancellous threads on either side to have a cancellous locking, and there is a locking bolt like nearby threads to have a good purchase within the nail. Now we apply the oblique screws, one from the lateral to posteromedial and one from medial anteromedial to posterolateral. आप डाल दो उधर, मैं स्क्रिप्ट निकाल दिया. इसके बाद हम जाएगा, मैं क्लास कर देता हूँ. ओके, उसके बाद क्या हो रहा है? See, now whatever I am tightening, it's not going easily because I hammered the nail little. So that's why I am finding it. So that's why you should not hammer the nail. That's very, very important in this. So I was just discussing with Dr. Santapure said that this nail doesn't tolerate any amount of hammering. If the screws are not going inside, that indicates that you are damaged the screw threads within the nail, and by using little brute force like this, what I am doing, if you are able to pass it, it is fine. Otherwise, best will be to extend the nail. And the nail is not very costly. Nail with the bolting screw, everything is under 4,000 rupees. So it's not very, very costly for using in a routinely. If you have any doubts, I will answer meanwhile when they are tightening it. Any question? Yes, Dr. Patni. Free hand. The proximal locking in free hand. Yes, bicortical locking. That's why you have to measure it exactly. There is a measuring thing. What I normally do is I drill it. When it touches the opposite cortex, I adjust the drill bit and just leave 5 millimeter. Again drill it. Then I know the length of it from the drill bit, how much I have to drill. Okay, anything else? Going to the otherwise, you can come on the stage. Okay, the question is, when the nail goes to the proximal fragment, sometimes the fracture opens up posteriorly. That is the reason why I said that you have to keep the nail parallel to the anterior cortex. If your nail is going parallel to the posterior cortex, when it goes to the next fragment, it opens either anteriorly or posteriorly. So that is very, very important. The nail is given slightly uniform bend. It's not 100% straight. It's not. There is a minimal curve given. We asked him to give little more curve like a femur, but unfortunately, they find it also little difficult to get the things done because they have to change the every set. So that's why they are not yet given. But we are asked to give little more curvature of 400 millimeter like the femur. If that is given, then this problem will not happen. Yeah, up to 30 centimeter, there is locking jig which is available. With that, you can do the locking. That is the reason why they have kept the nail straight up to 30. That's the reason why I use 36 nowadays. That 32 and 36 you have to do by freehand locking only. So, but the chances that it matches with the hole is about 80% because the nail bends to some extent. So by manipulation you can find out the hole and you can do it. Lateromedial. What we do is, what I normally do is I put the nail up to the subchondral area. In the subchondral area, nail will be in the center exactly. Anteriorly, I pass the guide wire and slip it. Posteriorly, I slip it, and I keep the siam in AP. And when the cable touches the lateral cortex, there will be no overlapping. That can be seen. Okay. Okay. See, when the cable is laterally touching, no, that's fine. When it is touching the bone, there will not be overlapping of the bone with the cable. Now you know that you are exactly in the center. Then you make a dent and drill with a Stillman pin. Then feel that opposite hole by the Stillman pin. Then you drill it. Yes, correct. Yes, sir. Okay. Sir, thank you very much. Yes, yes, Chapandi, sir. When there is okay. When there is intracondylar fracture, don't put the nail inside first. Open them by a medial parapatellar approach or lateral parapatellar approach. Put them in position by K wires, and you keep the area for the nail free. And if you are able to pass screws avoiding the screw hole area, then it is fine. Otherwise, just keep K wires, put the nail. Once you put the nail, then you pass the screws by the side of the nail. So that's how we fix them.
So thank you very much. Maharashtra Orthopaedic Association is very proud of NANDED Orthopaedic Association. I think it is one of the best workshop and the lecture series is organized by NANDED Orthopaedic. I cannot name because everybody in every soldier is very important in this endeavor of making this event successful. Tomorrow there are 4 surgeries and there will be 2 hours. Then we will have again lecture series and that will be the end of the course. So thank you very much, and I also congratulate the NANDED Orthopaedic Society functionaries. Thank you very much.
हॅलो, मला माहिती आहे सगळ्यांनी अतिशय मन लावून प्रोग्राम ऐकला. सगळ्यांनी इंग्लिश मध्ये ऐकलं. आता मी थोडस मराठीत बोलतो. तर जी अकॅडमिक फीस होती ती खूपच चांगली होती. आता ज्याची आतुरतेने सगळ्यांनी वाट बघायची ती फीस सुद्धा तयार आहे. तर आपण सगळ्यांनी 3rd फ्लोअरला जाऊन त्याचा आस्वाद आणि सगळं रंगीत कार्यक्रम ठेवलेला आहे त्याचा आस्वाद घ्यावा. तर अजून एक सांगायचं म्हणजे की नांदेड ऑर्थोपेडिक सोसायटी, सरांनी आता जसं म्हटलं, ही फक्त सोसायटी नाही तर ती फॅमिली आहे. ज्या तुम्ही प्रोग्राम बघितला त्यामध्ये कुठलाच एक व्यक्ती काम करत नव्हता, तर प्रत्येक व्यक्ती आपला मन लावून काम करत होतं. हे काही लोक तुम्हाला दिसले पण स्टेजच्या मागचे लोक खूप काम केले, त्यामुळे हा प्रोग्राम खरंच सुंदर झालाय. मी प्रत्येक एनएलच्या प्रत्येक मेंबरला थँक्स म्हणू इच्छितो. आणि सगळे गेस्ट अतिशय सुंदर असं प्रेझेंटेशन केलं, त्यामुळे मी प्रत्येकाचं थँक्यू म्हणतो. आणि कार्यक्रम इथे आता संपलेला नाही आहे, तो उद्या सकाळी 8 वाजता परत आपल्याला लाईव्ह सर्जरीज आहे आणि वरी आता लगेच जेवणाचा आणि म्युझिकचा कार्यक्रम आहे. प्लीज सगळ्यांनी वर 3rd फ्लोअरला यावं. थँक्यू व्हेरी मच. ग्रुप फोटोसाठी सगळे वर या. आणि उद्याचा जो प्रोग्राम आहे ते यशोसाईला 2nd फ्लोअरला आहे आणि शार्प 8 वाजता चालू होणार आहे. सगळ्यांनी 8 वाजता यावं, ब्रेकफास्ट करावं आणि मग आपला कार्यक्रम चालू होईल. हॅलो, सगळेजण मागे या फोटो काढायला. सगळेजण
गोविंद सर, वरती लावायचं आहे काय? वरती लावायचं आहे.